Manual removal of placenta, repair of large vaginal and cervical tears. Pethidine, IM or IV, 1 mg/kg slowly, maximum 100 mg, if no anesthetist is available, and promethazine hydrochloride, IM, 25 mg stat, if vomiting occurs, or metoclopramide, IV, 5 to 10 mg, 8 ounce dose 10 to 45 miles /g per kilograms per minute, adjusted according to response, and diazepam, slow IV. 5 to 10 mg, administered over 2 to 3 minutes, approximately 2.5 mg per minute, to prevent hallucinations. Promedication before ketamine administration. Atropine, IM, 600 micrograms stat, and oxygen, biphase mask, 6 to 8 L/minute per term. Labor and premature delivery. 354. Note 13-13 ketamine is contraindicated in patients with high blood pressure, hypertension, and heart disease. 124. Preterm labor in premature delivery. Preterm labor refers to labor occurring after 28 weeks, but before 37 completed weeks, resulting in premature delivery. The preterm newborn is at risk of death because all its body systems such as lungs, brain, digestive and immune systems are not fully developed. There is increased susceptibility to infection and impaired clotting mechanisms. The baby is also at risk of birth injuries such as cerebral hemorrhage, because the fragile cranial bones do not provide sufficient protection for the brain. Some risk factors for preterm labor include young age of mothers, poor socioeconomic class and smoking. Causes: maternal infections, for example pyelonephritis, malaria, incompetent cervix, premature rupture of membranes, multiple pregnancies, abruptio placentae, diabetes mellitus, preeclampsia/eclampsia symptoms, regular and painful uterine contractions or abdominal pains. There may be a show signs: small maturity, palpable regular uterine contractions, progressive effacement and dilatation of the cervix, ruptured membranes. Investigations: FVC, fasting or random blood glucose, ultrasound scan, for those not in established labor, for gestational age, fetal eye presentation, amniotic fluid volume, placental site, estimation of the fetal weight. Preterm labor in premature delivery. Chapter 13, Obstetric Care and Obstetric Disorders. 355. Treatment objectives: to stop uterine contractions, if labor is not fully established, to allow fetal growth and maturation in utero if feasible, to promote fetal lung maturity, gestations 28 to 34 weeks, to allow labor to progress, if it is already well established, to treat any underlying cause, for example malaria, pyelonephritis, non-pharmacological treatment, avoid sexual intercourse, avoid strenuous physical activity, bed rest, cervical circlage suture for cases diagnosed as due to cervical incompetence, pharmacological treatment. A. Tucolysis evidence rating. B. Salbutamol, IV infusion, 2.5 mg and 500 ml of dextrose 5%, start infusion at 10 micrograms per minute, that is 2 milliliters per minute, and increase rate gradually according to response at 10-minute intervals until contractions diminish, then increase rate slowly until contractions cease. Maximum rate 45 micrograms per minute. Maintain rate for 1 hour after contraction has stopped, then gradually reduce by 50% every 6 hours. Maximum duration 48 hours. Or evidence rating. A. Nifedipine, oral, 20 mg initially, then 20 mg after 90 minutes. If contractions persist, therapy can be continued with 20 mg every 3 to 8 hours for 48 to 72 hours as tolerated by patient. Maximum 160 mg per day. Note 13 to 144. Monitor blood pressure. Magnesium sulfate, IV, 6g intravenous loads initial over 20 minutes, then 2g infusion per hour after infusion. Rate is based on response. B. Fetal lung maturation with antenatal corticosteroids. Gestations between 28 to 34 weeks. Evidence rating. A. Betamethasone, oral, 0.6-7 mg every 24 hours, 2 doses, or premature rupture of the membranes. 356. Dexamethasone, 6 mg 12 hourly for 4 doses. Note 13 to 15 treatment is most effective if delivery occurs at least 24 hours after the first dose of the medicine has been given, and less than 7 days after the last dose of the medicine. Caution 13 to 1. Avoid dexamethasone/methadone use when infection is present. Dangers of steroid use include susceptibility to infection, fluid retention and pulmonary edema and maternal postpartum collapse. Referral criteria: treatment is best done in the hospital, where the facilities can support the adequate care of the preterm unit. Therefore, refer the mother. If the clinic cannot adequately care for the immature unit, it is better to transfer the fetus in utero to the referral center. 125. Premature rupture of the membranes. This is the rupture of the membranes before the onset of labor. The two types are preterm, before 37 completed weeks, and term, after 37 weeks, but 1 hour before onset of labor. Causes: cervical incompetence, genital tract infection, trauma symptoms, gush or leakage of copious fluid from the vagina. Signs: speculum examination reveals clear fluid from the cervical loss or pool of fluid in the posterior vaginal fornix. Smaller uterine size for the gestational age. If complicated by infection, chorioamnionitis, fever, purulent vaginal discharge, fetal tachycardia or bradycardia, maternal tachycardia, uterine tenderness. Investigations: FVC, sterile speculum examination including swab for culture, ultrasound scan, if available, for the gestational age, fetal IM. Premature rupture of the membranes. Chapter 13, Obstetric Care and Obstetric Disorders. 357. Presentation: amniotic fluid volume, normal or reduced, and the placental site. Estimate the fetal weight. Urinalysis and culture. Treatment objectives: to prevent and/or treat infection, to prevent labor, if preterm and baby is very immature, to improve fetal survival through improved fetal lung maturity. Non-pharmacological treatment. Bed rest. Pharmacological treatment. A. Infection prevention. First-line treatment. Evidence rating: B. Amoxicillin, oral, 500 mg 8 hourly for 7 days, and metronidazole, oral, 400 mg 8 hourly for 7 days. Second-line treatment. Evidence rating: C. Amoxicillin plus clavulanic acid, oral, 625 mg 1g 12 hourly for 7 days. B. Infection prevention. Patients with penicillin allergy. Erythromycin, oral, 500 mg 6 hourly for 7 days, and metronidazole, oral, 400 mg 8 hourly for 7 days. C. Fetal lung maturation, for babies 28 to 34 weeks. Evidence rating: A. Dexamethasone, oral, 0.6-7 mg every 24 hours, 2 doses, or dexamethasone, oral, 6 mg 12 hourly for 4 doses. Note 13 to 16 treatment is most effective if delivery occurs at least 24 hours after the first dose of the medicine has been given, and less than 7 days after the last dose of the medicine. They also benefit the premature newborn by lowering the risk of intraventricular hemorrhage and death. Referral criteria: if at sub-district level, refer patients to hospital or specialist for further management. If signs of maternal infection, pregnancy is less than 37 weeks and or premature labor occurs. 14. Chapter 358. Gynecological disorders. 126. Dysmenorrhea. Dysmenorrhea refers to cyclical lower abdominal pain associated with menstruation. The pain is thought to result from uterine contractions. It may be primary when there is no identifiable cause, or secondary when associated with an underlying cause. Causes: often no underlying cause. Primary: uterine fibroids, chronic pelvic infections, for example chlamydial infections. Endometriosis symptoms: lower abdominal pain that is cramping or colicky in nature, but may be dull and constant. Pain may radiate to the lower back or legs. Nausea, vomiting, headaches and dizziness may sometimes be associated with the pain signs. No typical physical signs. Investigations: FVC, sickling, pelvic ultrasound scan to rule out pelvic lesions such as fibroids. Treatment objectives: to relieve pain, to treat underlying cause. Non-pharmacological treatment: bed rest, warm pads applied to the lower abdomen. Abortion. Chapter 14, Gynecological Disorders. 359. Pharmacological treatment. A. Mild cases. First-line treatment. Evidence rating: A. Paracetamol, oral, oral, 1g 6 to 8 hourly. B. Severe cases, ibuprofen, oral, 200 to 400 mg 8 hourly, or mefenamic acid, oral, 500 mg 8 hourly. Referral criteria: refer to a gynecologist if pain interferes with normal activity, especially if treatment is ineffective or an underlying cause is identified. 127 Abortion. Abortion refers to the expulsion of the fetus and other products of conception before the 28th week of pregnancy. It may occur spontaneously, threatened, inevitable, incomplete, complete or missed, or be induced, therapeutic, criminal. Both spontaneous and induced abortion may become complicated by infection, sepsis, and/or profuse bleeding. After appropriate treatment and discharge from hospital, it is recommended that patients report back to hospital if there is lower abdominal pain, fever, vaginal bleeding, and malodorous discharge. A follow-up review should also be done in 2 weeks. Causes: spontaneous abortions, infections, for example malaria, UTI, bacterial vaginosis, etc. Fetal abnormalities, incompetent cervix, chronic illness, for example diabetes, thyroid disorders, sickle cell disease, etc. Trauma, unsafe abortions, interference of the pregnancy with medications, oral, parenteral or douches, or instrumentation. Threatened abortion symptoms: scanty to moderate painless vaginal bleeding, mild pelvic discomfort. Signs: the uterine size is compatible with the gestational age. Abortion. 360. There is no cervical effacement or dilatation. Investigations: FBC and sickling, ultrasound scan to confirm viable fetus in utero with closed cervix. Other investigations for potential underlying causes, for example malaria. Treatment objectives: to maintain a viable pregnancy to term, if possible non-pharmacological treatment, bed rest at home or hospital, to abstain from sexual intercourse, to report back if bleeding or pain increases. Pharmacological treatment: no specific treatment required. Treat any underlying illnesses, for example malaria. Inevitable abortion symptoms: lower abdominal pain, heavy vaginal bleeding, no fetus or products of conception past per vagina, painless loss of liquor per vaginum. Signs: the cervix is dilated with the membranes bulging. There may be loss of liquor. The uterine size is compatible with the gestational age. There may be signs of shock pallor, collapsed peripheral vessels, rising pulse with reducing volume, falling BP, and cold clammy skin. Investigations: FBC and sickling, blood grouping and cross-matching. Ultrasound scan shows the fetus dead or alive. Cervix may be dilated with membranes bulging through it. In instances associated with loss of liquor, there may be lithohydramnios. Ultrasound is necessary only if the diagnosis is in doubt. Treatment objectives: to resuscitate patient and/or prevent shock, to relieve pain, to allow the patient to abort, assist uterine contractions if weak, to evacuate the retained products of conception from the uterus. Abortion. Chapter 14, Gynecological Disorders. 361. To determine cause of abortion if recurrent. To prevent infection with antibiotic prophylaxis. To prevent risk of rhesus incompatibility in future pregnancies. Non-pharmacological treatment. Evacuation of the uterus is done by either of the following techniques: after the expulsion of the fetus, or before the expulsion of the fetus, if it is less than 12 to 14 weeks size. Manual vacuum aspiration, MVA, with or without paracervical block anesthesia, or uterine curettage under paracervical block or general anesthesia. Gestations 12 weeks or less. Uterine evacuation under anesthesia, especially when the uterine size is larger than 12 weeks size. Pharmacological treatment: A. If patient is in shock or bleeding is severe, I fluids and blood transfusion as necessary. B. To relieve severe pain, evidence rating: C. Morphine, IV 2.5-5 mg 4 hourly as required, and metoclopramide, IV 5 to 10 mg 8 hourly as required for vomiting, or pethidine, 75 to 100 mg stat, then 50 to 100 mg 6 to 8 hourly if required, and promethazine, IVN/IM, 25 mg as required, maximum 25 mg 6 hourly, as required to reduce the chances of vomiting, and to potentiate the analgesic effect of pethidine C. Evacuate uterus if uterine size, 12 to 14 weeks. Evidence rating, A. Oxytocin, I, 10 to 20 units per liter of normal saline or uterine size 12 weeks. Evidence rating, C. Misoprostol, oral/SL, 600 microgram stat. D. To prevent infection, amoxicillin, oral, 500 mg 8 hourly for 5-7 days, and metronidazole, oral, 400 mg 8 hourly for 5-7 days. Abortion - 362. E. To prevent rhesus immunization in rhesus-negative women. Evidence rating, A. Anti-DRH immune globulin, IM, 300 microgram, 1,500 units, stat. Within 72 hours of abortion. Incomplete abortion symptoms, passage of large blood clots and/or the fetus and some products per vaginum. Severe lower abdominal pain signs. If bleeding is severe, pallor and/or shock, collapsed peripheral vessels, fast pulse, falling BP and cold clammy skin. Uterine size is smaller than the dates. Cervix is dilated with the fetus already aborted. Whole placenta or parts thereof may be present within the uterine cavity. Investigations, FBC and sickling, blood grouping and cross-matching. Ultrasound scan, to be requested, if doubt exists in the diagnosis, especially in early pregnancies. Treatment objectives: to resuscitate patient, to evacuate the retained products of conception from the uterus, to prevent infection with antibiotic prophylaxis, to determine cause of abortion, if recurrent, to prevent risk of rhesus incompatibility in future pregnancies. Non-pharmacological treatment: digital curettage during vaginal examination, to remove as much of the retained tissues as possible. Surgical evacuation of retained products of conception, for example manual vacuum aspiration, MVA, with or without anesthesia. Post-abortion abstention from sexual intercourse for at least 2 weeks. Post-abortion counseling and psychological support, including family planning, pharmacological treatment. A. If in shock and/or severe bleeding, I fluids and blood transfusion as necessary. B. Abortion with uterine size 12 weeks. Evidence rating, A. Ergometrine, IMEN/IV, 500 microgram stat. Abortion - Chapter 14, Gynecological Disorders, 363, or misoprostol, oral, 600 microgram stat, or misoprostol, sublingual, 400 microgram stat. C. Abortion with uterine size, 12 weeks and 24 weeks. Evidence rating, A. Misoprostol, oral, 600 microgram stat, or misoprostol, sublingual, 400 microgram stat. D. Abortion with uterine size, 24 weeks. Evidence rating, B. Oxytocin, I, 20 units into 1 ounce of sodium chloride 0.9%, and infuse at 30 to 60 drops per minute. Or misoprostol, oral, 600 microgram stat, or misoprostol, sublingual, 400 microgram stat. E. To prevent infection, amoxicillin, oral, 500 mg 8 hourly for 5-7 days, and metronidazole, oral, 400 mg 8 hourly for 5-7 days. F. To prevent infection in patients with penicillin allergy, erythromycin, oral, 500 mg 8 hourly for 5-7 days, and metronidazole, oral, 400 mg 8 hourly for 5-7 days. G. To prevent rhesus immunization. Evidence rating, A. C-section under inevitable abortion above, complete abortion symptoms, cessation or reduction of vaginal bleeding following heavy bleeding with passage of clots and/or the fetus and placenta, resolution or abatement of pain signs. The uterus is smaller than the gestational age. The cervix is closed and firm. No pelvic tenderness. Investigations, FBC, blood grouping and cross-matching. Ultrasound scan, to confirm empty uterine cavity. Abortion - 364. Treatment objectives: to confirm abortion is complete, to assess for and manage anemia if present, to assess for and manage pelvic infection if present, to prevent risk of rhesus incompatibility in future pregnancies. Non-pharmacological treatment, counseling and psychological support, including family planning, non-pharmacological treatment. Treat anemia if present, C-section on anemia in pregnancy. Provide antibiotics if needed, C-section on treatment of incomplete abortion. Provide anti-immune globulin if indicated, C-section under inevitable abortion above. Septic abortion. This is a life-threatening complication of abortion. Most often there is a history of criminal interference with the pregnancy. It may lead to complications such as septic shock, uterine damage, peritonitis, hemorrhage, disseminated intravascular coagulation, DIC, acute renal failure, adult respiratory distress syndrome, tetanus or gas gangrene. Causes: infected retained products of conception. Symptoms: severe lower abdominal pain, fever, vomiting, headache, offensive bloody vaginal discharge. Signs: fever, but temperature may be normal. Tachycardia if in septic shock, low blood pressure. Peritonism, bulky tender uterus. Cervix may be opened or closed. Retained offensive products of conception. Investigations: FBC and sickling test. Clotting screen. Blood grouping and cross-matching. Blood culture and sensitivity. Urine culture and sensitivity. Abortion. Chapter 14, Gynecological Disorders, 365. Endocervical swab for culture and sensitivity. Blood urea and electrolytes. Chest and abdominal X-ray, to exclude foreign body, gas under the diaphragm suggesting uterine perforation. Abdominopelvic ultrasonography, for intra-abdominal and pelvic abscesses, presence of products in uterus, fluids and gas in the pelvis. Treatment objectives: to resuscitate patient, to treat infection, to evacuate uterus, to provide post-abortion counseling. Non-pharmacological treatment: evacuate the retained products of conception. Careful evacuation of the uterus must be done as risk of uterine perforation is high. Gentle digital curettage followed by the instrumental curettage under general anesthesia within 6 hours of initiation of antibiotic therapy. Examine to confirm if uterus is perforated and determine if surgery is required. Psychological support and family planning counseling. Pharmacological treatment: A. Resuscitation for shock evidence rating, A. IV fluids and blood transfusion as necessary. B. Treatment of sepsis. Amoxicillin plus clavulanic acid, IV, 1.2 g 8 hourly for 24 to 72 hours and gentamicin, IV, 80 mg 8 hourly for 5 days and metronidazole, IV, 500 mg 8 hourly for 24 to 72 hours. Note 14:1 culture and sensitivity test results will direct further antibiotic therapy. IV antibiotic therapy should be continued until the patient is afebrile for at least 24 hours. Oral therapy should be continued for at least 7 days. If gentamicin is to be continued, give 80 mg or IV 8 hourly for at least 5 days. C. Evacuate uterus. Note 14:2 to abort fetus if still in utero and or if surgical evacuation of products is not immediately possible. Abortion. 366. Oxytocin, IV infusion, C-section on inevitable abortion, or misoprostol, sublingual oral or vaginal, 600 microgram stat. C-section on incomplete abortion above. D. Severe pain management evidence rating, C. Morphine, IV, 2.5-5 mg 4 hourly as required and metoclopramide, IV, 5 to 10 mg 8 hourly as required for vomiting or pethidine, 50 to 100 mg 4 to 6 hourly, maximum 400 mg in 24 hours, and promethazine, IVN/IM, 25 mg 8 to 12 hourly as required, maximum 25 mg 6 hourly, to reduce the chances of vomiting, and to potentiate the analgesic effect of pethidine. Tetanus prophylaxis. Tetranol, 0.5 ml stat, and human immune tetanus globulin, 250 to 500 units stat. Missed abortion. This refers to fetal death in utero before 28 weeks gestation. Symptoms. There is reversal of the symptoms of pregnancy. There may be recurrent bloody vaginal discharge. Absent maternal perception of fetal movements, if quickening has already occurred. Signs. Uterus is smaller than gestational age/dates. Fetal heart sounds are not heard either with the Pinard stethoscope, or with a fetal Doppler device such as sonic aid investigations, FBC and sickling test. Blood grouping and cross-matching. Blood film for malaria parasites if necessary. Blood clotting profile for the larger pregnancies. Pregnancy test. Ultrasound scan. Fasting blood sugar. Abortion. Chapter 14, Gynecological Disorders, 367. Treatment objectives. To make patient fit for uterine evacuation. To ensure safe uterine evacuation. To establish cause of fetal death, if possible non-pharmacological treatment. Evacuation of the uterus by suction curettage, manual or with machine. 12 weeks gestation. Surgical evacuation of uterus, D&E, after cervical ripening with medication. Second trimester pharmacological treatment A. Ripening of cervix to facilitate surgical evacuation. Evidence rating A. Misoprostol, oral or vaginal, 400 micrograms stat at least 3 hours prior to surgical evacuation. B. Emptying uterus with medication in missed abortion. See section on misoprostol treatment under *induced abortion below, or evidence rating. B. Oxytocin drip may be used for induction, where other cervical ripening methods, for example Foley's catheter balloon, are used. Note 14.2.3 Oxytocin should not be used concurrently together with misoprostol for uterine sizes greater than 20 weeks. A 4 to 6 hour time interval must be given between use of the two drugs. If both must be used, this must be done with extreme caution as risk for uterine rupture is great. Induced, safe, abortion. This refers to the deliberate termination of pregnancy. Termination of pregnancy is requested for, and done for reasons permissible by law either through a surgical procedure, or by pharmacological means. Under the current provisions for Ghana, an induced abortion may be carried out legally only under the following conditions: in case of rape, defilement or incest, threat to the physical and mental health of the mother, presence of fetal abnormality and mental retardation of the mother. Patients given a pharmacological option for abortion will need to be monitored closely for completeness of the abortion process. They should be informed to report back immediately in cases of profuse or heavy vaginal bleeding, fever or offensive vaginal discharge. Investigations. FBC, blood group and rhesus factor. Abortion. 368. Special investigations for medico-legal indications, for example rape, DNA, HIV status, etc. Treatment objectives. To ensure that legal requirements for termination are met. To ensure safe abortion. To provide family planning counseling, and services as needed. To prevent risk of rhesus incompatibility in future pregnancies. Non-pharmacological treatment. Manual vacuum aspiration. 4 to 12 week gestation. Dilatation and curettage. 4 to 12 week gestation. Cervical ripening followed by dilatation and evacuation. D&E. 12 weeks gestation. Pharmacological treatment A. Medication abortion. Evidence rating A. Mifepristone then misoprostol. See table below for dosage regimes for the various gestational ages. Table 14:1, dosage regimes for mifepristone and misoprostol for various gestational ages. Gestational ages: mifepristone and misoprostol. Evidence rating A. Misoprostol, only. Evidence rating A. 4 to 8 weeks. Mifepristone 200 mg stat plus followed 24 to 48 hours later by misoprostol 800 micrograms oral, vaginally, stat followed if needed by 2 repeat doses of 800 micrograms vaginally or sublingually every 3 to 12 hourly, maximum 3 doses. Misoprostol only. 800 microgram stat vaginally followed by 2 repeat doses of 800 microgram vaginally or sublingually, if needed every 3 to 12 hourly, maximum 3 doses. 9 to 12 weeks. Mifepristone 200 mg orally, plus 36-48 hours later, misoprostol 800 microgram vaginally, follow with up to 2 additional doses of misoprostol 400 microgram sublingually or vaginally at 3-12 hour intervals, maximum 3 doses. Misoprostol 800 microgram vaginally stat, followed by 2 repeat doses of 800 microgram every 3 to 12 hours if needed, maximum 3 doses. Abortion. Chapter 14, Gynecological Disorders, 369. Gestational ages. Mifepristone and misoprostol. Evidence rating A. Misoprostol, only. Evidence rating A. 13-24 weeks. Mifepristone 200 mg orally, plus 36 to 48 hours later. Misoprostol 800 microgram vaginally, followed by a repeated dose of misoprostol 400 microgram every 3 to 4 hourly vaginally or sublingually if there is significant bleeding from earlier vaginal misoprostol administration, until expulsion. Maximum 5 doses. Misoprostol 800 microgram vaginally followed by 400 microgram vaginally or sublingually if there is significant bleeding, at 3 to 6 hourly intervals. Repeat dosing until expulsion. Maximum 5 doses. 24-28 weeks mifepristone 200 mg orally, plus 36 to 48 hours later misoprostol 200 microgram vaginally, or orally every 4 hours. Repeat dosing until expulsion. Maximum 5 doses. Decreased dose of misoprostol with increasing gestational age. Misoprostol 100 to 200 microgram vaginally, or orally every 4 hours. Repeat dosing until expulsion. Maximum 5 doses. Decreased dose of misoprostol with increasing gestational age. Note 14-4. Uterine sensitivity to misoprostol increases with gestational age. Lower doses of misoprostol are therefore used for older gestations. *MEDICATIO and abortions in second trimester should only be done by doctor's referral criteria for all types of abortion. Refer early for specialist care if the uterus is suspected or found to be perforated, or if complications, for example infection or profuse bleeding, are severe. Table 14-2. Misoprostol uses and dosage in management of pregnancy complications. Indication dosage notes: induced abortion 0 to 8 weeks. Misoprostol 800 microgram vaginally, or orally or sublingually 3 to 12 hourly. Maximum 3 doses. Ideally used 24 to 48 hours after mifepristone, oral, 200 mg. Induced abortion, 9 to 12 weeks. Misoprostol 800 microgram vaginally followed by misoprostol 400 microgram vaginally or sublingually every 3 hours hourly. Maximum 3 doses. Ideally used 24 to 48 hours after mifepristone, oral, 200 mg. Abortion, 370. Missed abortion, 0 to 12 weeks. Misoprostol 800 microgram vaginally if needed. Repeat dose in 24 to 72 hours, or misoprostol 600 microgram sublingually followed by 2 additional doses, if needed 3 hourly. Give 2 doses and leave to work for 1 to 2 days, unless heavy bleeding or infection. Incomplete abortion, 0 to 12 weeks. 600 microgram orally stat leave to work for 2 days, unless heavy bleeding or infection. Induced abortion, 13 to 24 weeks. 400 microgram vaginally 3 to 4 hourly. Maximum 5 doses, ideally used 48 hours after mifepristone, oral, 200 mg. A lower misoprostol dose of 28 weeks, 13 to 17 weeks. Misoprostol 200 microgram 6 hourly 18 to 28 weeks. Misoprostol 100 microgram 6 hourly. Misoprostol should be used with caution in women with cesarean scar, and only under specialist supervision. Intrauterine fetal death is greater than 28 weeks. 28 to 42 weeks. Misoprostol 25 to 50 microgram 4 hourly. Do not administer to women with previous cesarean section or other uterine scar. Induction of labor, live fetus, 28 weeks. 25 microgram vaginally 4 hourly, or 50 microgram orally 4 hourly, or 20 microgram oral solution 2 hourly. Do not use, if previous cesarean section. PPH treatment 600 microgram orally or sublingually stat. Use as second-line drug, if oxytocin is not available or is ineffective. Cervical ripening prior to instrumentation 400 microgram vaginally 3 hours before procedure. Use for insertion of intrauterine device, surgical termination of pregnancy, dilatation, and curettage. Hysteroscopy. Stat equals single dose taken immediately. PPH equals postpartum hemorrhage. Note: misoprostol is associated with an increase in shivering, diarrhea, and temperature higher than 38 degrees C. Abnormal vaginal bleeding. Chapter 14, Gynecological Disorders, 371. 128. Abnormal vaginal bleeding. This refers to bleeding which deviates from the normal menstrual pattern, in terms of the amount, duration, or interval. Abnormal menstrual patterns and bleeding are common in young adolescents and women within the ages of 45 to 50 years. No cause may be found on investigation in these age groups, as it is mostly due to immaturity or aging of the ovaries and its pituitary controls. Bleeding may be mild or severe and life-threatening. In other age groups, the causes are multiple and may be associated with the identifiable disorders. Postmenopausal bleeding is said to occur when a woman who has stopped having menstruation for 6 to 12 or more months begins to bleed per vagina. Occasionally, bleeding from the rectum and urethra may be confused with genital tract bleeding. Treatment is directed at the cause found. Causes: prepubertal girls, urethromucosal prolapse, coital lacerations due to rape and defilement, trauma, young adolescents, dysfunctional uterine bleeding, complications of pregnancy, coital lacerations due to rape and defilement, accidental traumatic lesions of vulva and vagina, women of childbearing age, complications of pregnancy, including ectopic pregnancy, abortion and carcinoma, coital lacerations, use of hormonal methods of contraception or intrauterine contraceptive device, IUCD, cervical cancer, fibroids, dysfunctional bleeding, perimenopausal women, dysfunctional uterine bleeding. All other causes listed for women of childbearing age also apply postmenopausal women. Pelvic cancers such as cervical cancer, endometrial cancer, vaginal or vulva cancer and ovarian tumors. Withdrawal from estrogen therapy. Atrophic vaginitis, endometritis, coital tears, urethral caruncle, abnormal vaginal bleeding. 372. Symptoms. Vaginal bleeding which deviates from normal menstrual pattern may be associated lower abdominal pain or dysmenorrhea. Symptoms of anemia, dizziness, palpitations, easy fatigue, etc. Signs. Signs of anemia, if heavy bleeding. Other signs related to cause investigations. FBC. Sickling test. Blood clotting screen, for example prothrombin time, INR. Pelvic ultrasound scan, to rule out pelvic lesions. Urinalysis. Diagnostic dilatation and curettage. DDNC. For women of childbearing age and postmenopausal women. Treatment objectives: to resuscitate patient where necessary, to find the cause of bleeding, to treat and stop the bleeding. Non-pharmacological treatment: vaginal coital tear, suturing and theater, inevitable or incomplete abortion, uterine evacuation, surgery, myomectomy, hysterectomy, oophorectomy, etc. Radiation therapy for cancers. Pharmacological treatment: A. Dysfunctional uterine bleeding, mild bleeding. First-line treatment evidence rating: B. Northisterone acetate, oral, 5 mg 8 hourly for 10 to 12 days, to stop bleeding, then 5 mg 12 hourly, days 19 to 26 of cycle to prevent bleeding. Second-line treatment evidence rating: B. Mefenamic acid, oral, 500 mg 8 hourly on days 1 to 5 of cycle, especially if associated with dysmenorrhea. B. Life-threatening bleeding. First-line treatment evidence rating: A. I fluids and blood transfusion as required. Abnormal vaginal discharge. Chapter 14, Gynecological Disorders. 373. An evidence rating: A. Tranexamic acid, oral or IV, 1g 6 to 8 hourly for 4 to 7 days. Second line treatment evidence rating: B. Mefenamic acid, slow IV injection, 500 mg 8 hourly, days 1 to 5 of cycle. C. For recurrent or protracted abnormal bleeding. First line treatment evidence rating: A. Low dose oral contraceptive pill daily for 3 to 6 cycles or longer. Ethinylestradiol plus levonorgestrel or ethinylestradiol plus northisterone. Second line treatment evidence rating: C. Conjugated estrogen, oral, 1.25-2.5 mg daily for 10 to 12 days and evidence rating: A. Northisterone, oral, 5 to 10 mg 8 hourly for 21 days, days 5 to 25, or evidence rating: B. Medroxyprogesterone acetate, oral, 5 to 10 mg daily for 5 to 10 days, days 19 to 26 of cycle. Referral criteria are for all women with heavy menstrual bleeding and or abnormal vaginal bleeding not responding to therapy to a gynecologist for comprehensive assessment and management. 129. Abnormal vaginal discharge. While a vaginal discharge is a notable clinical feature of a sexually transmitted infection, STI, not all forms of vaginal discharge are abnormal or indicative of an STI. Vaginal discharge may be associated with normal physiological changes such as the menstrual cycle or pregnancy. Increased discharge may also occur with the presence or use of foreign substances such as the intrauterine contraceptive device, IUCD. Careful history taking should reveal whether a vaginal discharge is abnormal, and if it is associated with use of chemical substances, for example topical self-medication, repeated douching with abrasive substances, or indeed due to STI. Changes in the characteristics of a woman's vaginal discharge either in color, odor, amount, and presence of additional abnormal vaginal discharge. 374. Symptoms and signs such as soreness and itchiness indicate a need for medical attention. Abnormal vaginal discharge due to STIs may result in serious pelvic inflammation with sequelae such as ectopic pregnancy and infertility. Careful risk assessment is therefore required, see note below, of women presenting with a vaginal discharge, in order to identify the possible causes and provide appropriate treatment regimens, based on the most likely etiology of the vaginal discharge. Factors that must also be considered when selecting treatment for patients include pregnancy status and patient discomfort. Additionally, the syndromic approach must be used to assess the patient, identify risk factors and treat the likely cause of infection. Causes: STI-related Neisseria gonorrhea, chlamydia trachomatis, trichomonas vaginalis, green or yellow, smelly, bubbly or frothy discharge associated with itching. Herpes simplex virus, following extensive first episode of infection. Non-STI-related candidiasis, white, lumpy or thick discharge associated with itching. Bacterial vaginosis, gray or white, fishy-smelling discharge, especially after sexual intercourse. Gardnerella vaginalis. Foreign bodies. Herbal preparation symptoms: abnormal vaginal discharge, change in color, odor, consistency, or amount. Vulval itching, vulval swelling, pain on urination, lower abdominal or back pain signs. Abnormal vaginal discharge, vulval swelling, vulval erythema, lower abdominal tenderness, cervical excitation tenderness, cervical mucus or erosions on speculum examination. Investigations: high vaginal swab for microscopy, culture, and sensitivity, if available. Abnormal vaginal discharge. Chapter 14, Gynecological Disorders. 375. Treatment objectives: to identify and treat non-STI vaginitis, to assess STI risk and treat STI-related infections appropriately, to prevent complications and sequelae, to treat both partners simultaneously as much as possible. Non-pharmacological treatment: promote good perianal and genital hygiene, encourage use of loose cotton underwear, dry underwear out in the sun, keep underwear dry, avoid douching with herbal or chemical preparations, avoid use of medicated soaps. Pharmacological treatment. Box 14-1. Risk assessment parameters used in the risk assessment for cervicitis are: I. Patient's partner is symptomatic, that is, partner has urethral discharge. II. Patient is less than 21 years old. III. Patient is single. IV. Patient has more than one sexual partner. V. Patient has had a new sexual partner in the last 3 months. The risk assessment is said to be positive and treatment for cervicitis is recommended if the answer to I is yes, or the answer to any two of items V is yes. If a woman has a vaginal discharge with no positive risk factor, treat for vaginitis alone. If she has a vaginal discharge and a positive risk factor, treat for both vaginitis and cervicitis. A. Treatment for vaginitis due to trichomoniasis and bacterial vaginosis. Evidence rating: B. Metronidazole, oral, 400 mg 8 hourly for 5 days, contraindicated during the first trimester of pregnancy, or metronidazole, oral, 2G stat, contraindicated during the first trimester of pregnancy, or signitazole, oral, 2G stat, contraindicated during the first trimester of pregnancy. B. Treatment for vaginitis due to trichomoniasis and bacterial vaginosis for pregnant women in the first trimester. Clindamycin cream, 2%, vaginal, 1 applicator full at bedtime for 7 days. Abnormal vaginal discharge. 376. C. Treatment for vaginitis due to candidiasis. Fluconazole, oral, uncomplicated. 150 mg stat as a single dose. Complicated. 150 mg 72 hourly for 3 doses recurrent. 150 mg daily for 10 to 14 days followed by 150 mg once weekly for 6 months, or clotrimazole, vaginal tablets, 200 mg inserted into vagina at night for 3 days, or miconazole vaginal tablets, 200 mg inserted into vagina at night for 3 days, and clotrimazole cream, vaginal, 1% or 2%, apply twice daily for 3 to 7 days, for vulval irritation. D. Treatment for cervicitis due to gonorrhea. First-line treatment evidence rating. B. Cefixime, oral, 400 mg stat, and azithromycin, oral, 1 g stat. Second-line treatment evidence rating. B. Ceftriaxone, IM, 250 mg stat, and azithromycin, oral, 1 g stat. E. Treatment for cervicitis due to chlamydia. First-line treatment evidence rating. A. Doxycycline, oral, 100 mg 12 hourly for 7 days, avoidant pregnant and nursing mothers, or erythromycin, oral, 500 mg 6 hourly for 7 days, or azithromycin, oral, 1 g stat. Recommended in pregnancy. Referral criteria are for all cases of recurrent vaginal discharge and/or treatment failures to a health facility, where speculum examination can be carried out, and microbiological culture and antimicrobial sensitivity tests can be done on the vaginal discharge. Abnormal vaginal discharge. Chapter 14, Gynecological Disorders, 377, Flowchart, Figure 14-2, Flowchart, Abnormal Vaginal Discharge, without speculum. Abnormal Vaginal Discharge, 378, Flowchart, Figure 14-3, Flowchart, Vaginal Discharge with speculum and bimanual examination. Acute lower abdominal pain, Chapter 14, Gynecological Disorders, 379, 130. Acute lower abdominal pain. Acute lower abdominal pain in a woman may have several causes. These include pelvic inflammatory disease, PID, ruptured ectopic pregnancy, and septic abortion. The latter two are surgical emergencies, which require extreme urgency in their management. See sections on ectopic pregnancy and abortions. PID is caused by organisms which may be sexually transmitted infection, sterilized or other bacteria, that descend from the lower genital tract, and produce inflammation of the uterus, fallopian tubes and other structures in the pelvis. However, after excluding ectopic pregnancy, sterilized organisms are the most likely cause of lower abdominal pain in a sexually active woman who has not recently delivered a baby, or has no past or recent history of uterine instrumentation. The presence of intrauterine contraceptive devices, IUCD, favors the development of PID, particularly in the month following insertion. Causes: ectopic pregnancy, appendicitis, ovarian torsion, sterilized, non-sterilized, urinary tract infection, septic abortion, postpartum sepsis, foreign body including IUCD symptoms, fever, lower abdominal pain, pain with sexual intercourse, dyspareunia, offensive vaginal discharge, dysuria or urethral discomfort signs, abnormal vaginal discharge, tenderness on moving the cervix, cervical excitation, on bimanual vaginal examination, lower abdominal tenderness, adnexal masses investigations, pelvic ultrasound, pregnancy test, if sexually active and amenorrhea present, high vaginal swab culture and sensitivity, acute lower abdominal pain, 380. Treatment objectives: to identify and manage potential life-threatening causes, for example ectopic, to treat any underlying bacterial infection, to relieve pain and inflammation. Non-pharmacological treatment: surgery where indicated, remove IUD, if present, 3 days after initiation of drug therapy. Pharmacological treatment: A. For pelvic inflammatory disease, mild cases, first-line treatment evidence rating, B. Ciprofloxacin, oral, 500 mg 12 hourly for 3 days, and doxycycline, oral, 100 mg 12 hourly for 14 days, and metronidazole, oral, 400 mg 12 hourly for 14 days. Box 14-4. Consider hospitalization or referral in the following cases where surgical emergencies, for example ectopic appendicitis, cannot be excluded. The patient is pregnant. PID is uncommon in pregnancy, especially after the first trimester. The patient does not respond respond clinically to oral antimicrobial therapy. The patient is unable to follow or tolerate an outpatient oral regimen. The patient has severe illness, associated with nausea and vomiting, or high fever. The patient has a tubo-ovarian abscess, HIV infection, youth/adolescence, particularly if compliance is an issue. B. For pelvic inflammatory disease severe cases, ceftriaxone, IM, 250 mg daily for 3 days and doxycycline, oral, 100 mg 12 hourly for 3 days and metronidazole, IV, 500 mg 8 hourly for 3 days then doxycycline, oral, 100 mg 12 hourly for 14 days and metronidazole, oral, 400 mg 12 hourly for 14 days. Note 14-5 The use of ciprofloxacin and doxycycline is contraindicated in pregnant and lactating women. Acute lower abdominal pain. Chapter 14, Gynecological Disorders, 381. See Pain Relief. Diclofenac, rectal, oral, IM, 50 to 100 mg 8 to 12 hourly, maximum 100 mg twice daily, or mefenamic acid, oral, 500 mg 8 hourly. Referral criteria: refer to a gynecologist or general surgeon if there is no improvement, or if a pelvic abscess is suspected. Flowchart. Figure 14-5. Flowchart. Acute lower abdominal pain. Female. Infertility. 382. 131. Female infertility. Primary infertility is said to occur when a couple has never achieved the pregnancy despite at least 1 year of uninterrupted and adequate unprotected sexual intercourse. Secondary infertility implies that there has been a previous pregnancy. It is often necessary to evaluate both partners simultaneously and to elicit sexual, menstrual, and obstetric history, the past history of pelvic inflammatory disease, PID, and sexually transmitted infections, STIs, contraception use and other significant past medical history. Causes: female factors, ovulation failure, polycystic ovarian syndrome, PCOS, hyperprolactinemia. Pelvic factors: congenital malformations of uterus etc., tubal disease, pelvic adhesions, uterine fibroids, endometriosis. Cervical factors: male factors, oligospermia, azoospermia, penile and testicular abnormalities, erectile dysfunction. Symptoms: inability to achieve pregnancy despite regular unprotected sex at least 2 to 3 times weekly. Amenorrhea, females. Impotence, males. Signs: female. Absence of secondary sexual characteristics. Virilization changes, hirsutism, clitoromegaly, deepening of voice etc. Galactorrhea, abdominal masses due to uterine or ovarian enlargement. Abnormal vaginal discharge indicative of infection. Male. Abnormal penile discharge indicative of infection. Absence of secondary sexual characteristics. Testicular abnormalities, for example verrucocles, small or absent testes. Female. Infertility. Chapter 14, Gynecological Disorders, 383. Investigations: FBC, sickling, high vaginal swab, blood glucose, hysterosalpingogram, best done under fluoroscopic guidance, semen analysis, serum progesterone level in mid-luteal phase, day 21 to 23 of menstrual cycle, to check for ovulation, thyroid function tests, further hormonal studies, for example serum lernout House B, FSH, serum testosterone, prolactin, to be done by specialist. Treatment objectives: to treat the underlying cause of the infertility if possible, to achieve pregnancy within the shortest possible time. Non-pharmacological treatment: counseling, uterine, tubal and testicular surgery where needed, assisted reproduction technologies, for example artificial insemination, in vitro fertilization with embryo transfer where indicated. Pharmacological treatment: A. Failure of ovulation. First line treatment evidence rating: A. Clomiphene citrate, oral, 50 mg daily for 5 days, starting between the 2nd and 5th day of the menstrual cycle. B. Hyperprolactinemia. First line treatment evidence rating: A. Remakrutine, oral, 1.25 mg knocked for 7 days, with the evening meal or at bedtime. Increase weekly to a maximum of 2.5 mg 8 hourly. Referral criteria: early referral of all patients with infertility to a specialist is preferred, particularly women with uterine, ovarian, or tubal disease requiring surgery, or who require ovulation induction not responsive to clomiphene citrate. Also refer male partners for review by a urologist. Menopause. 384. 132. Menopause. Menopause refers to the point in time when permanent cessation of menstruation occurs due to loss of ovarian function. The cessation of menses is preceded by a perimenopausal phase during which there may be menstrual irregularity. The age at onset is usually between 45 and 55 years. A woman is considered to be menopausal if there has not been menstruation for a period of at least 12 months in the absence of pregnancy. Menopause may be associated with physical, emotional, and psychological upheaval of varying intensity in some women. 60% of menopausal women, however, have mild symptoms or are asymptomatic. The risk of osteoporosis and cardiovascular disease increase after the menopause. Causes: a natural life event due to the aging of the individual, surgical removal of the ovaries, bilateral oophorectomy, pelvic irradiation, premature ovarian failure, pituitary damage from primary postpartum hemorrhage, Sheehan syndrome, cytotoxic, anti-cancer therapy. Symptoms: hot flushes, heat or burning in the face, neck and chest would result in sweating. The flushes may be associated with palpitations, faintness, dizziness, fatigue, weakness. Emotional and psychological problems include mood changes, depression, anxiety, nervousness, irritability, loss of libido, vaginal dryness and dyspareunia. Symptoms due to atrophic changes in the genital tract, increased frequency of micturition and dysuria, stress incontinence, urinary incontinence with coughing or straining. Signs: usually none. Menopause. Chapter 14, Gynecological Disorders. 385. Investigations. Serum Lernatin Houseby, FSH, ostradiol. Routine investigations, for example FBC, blood glucose, lipid profile, urine or blood pregnancy tests, to exclude pregnancy. Treatment objectives: to control bothersome symptoms, for example severe hot flushes, atrophic vaginitis and recurrent cystitis. To prevent cardiovascular morbidity. To prevent osteoporosis, especially in individuals with premature menopause. Non-pharmacological treatment, counseling and reassurance. Encourage active lifestyles, healthy diet, exercise and regular physical checkups for common medical problems. Pharmacological treatment: A. Hormone replacement therapy, HRT, for women with intact uterus. First-line treatment evidence rating: A. Combined conjugated estrogens and progestogen, oral, 28 tablets each containing conjugated estrogens 625 micrograms including 12 tablets containing norgestrel 150 micrograms, 1 tablet daily, or conjugated estrogen and norgestrel tablet, oral, 625 microgram, and 150 microgram, 1 tablet daily on days 17 to 28 of each 28-day treatment cycle. B. Hormone replacement therapy, HRT, for women with previous hysterectomy. Evidence rating: A. Conjugated estrogens, oral, 625 microgram daily. C. For relief of vaginal symptoms only. Evidence rating: A. Estrogen cream, vaginal, apply topically once daily. Note 14-6 women with intact uterus should never be given estrogens alone. Current evidence suggests that hormone replacement therapy in the menopause does not prevent coronary heart disease or strokes. HRT increases the risk of venous thromboembolic phenomena, breast cancer and endometrial cancer after prolonged use, and should therefore be given for the shortest possible time whenever indicated. Carcinoma of the cervix. 386. Referral criteria: refer cases with osteoporosis or severe unremitting symptoms to the specialist. 133. Carcinoma of the cervix. Carcinoma of the cervix is the commonest form of female genital cancer seen in Ghana. While the disease is preventable, in Ghana, the absence of an effective screening system has resulted in most cases presenting late with advanced disease. In developed countries, the incidence of cervical cancer has fallen considerably due to regular screening procedures, for example pap smear, visual inspection with acetic acid, human papillomavirus, HPV test. Vaccination against cancer-causing HPV infection is the ideal method for primary prevention of cervical cancer. Treatment of cervical cancer requires the services of a gynecological oncologist and radiotherapist. Treatment includes surgery and/or radiation and/or chemotherapy. Surgery involves removal of the central tumor as well as the lymphatics draining the area. Times hysterectomy. This extensive surgery should be carried out only by by trained specialists. Radiation treatment often involves localized pelvic irradiation. Causes: human papillomavirus accounts for 80% of cases. Associated risk factors include sexual promiscuity, multiple childbirths, infections with herpes simplex hominis type II, HIV, smoking, low socioeconomic status, family history. Symptoms: asymptomatic, diagnosed on routine cervical screening; symptomatic, advanced disease; abnormal vaginal bleeding in between regular menstrual periods, after sexual intercourse; postmenopausal bleeding; abnormal vaginal discharge; lower abdominal pain; pain during sexual intercourse; weight loss; urinary symptoms, for example dysuria; frequency, incontinence; rectal pain; carcinoma of the cervix. Chapter 14, Gynecological Disorders, 387. Signs: early disease, erosion of cervix or changes of chronic cervicitis; late/advanced disease, ulcerative or fungating cervical lesion on speculum examination. Investigations: cervical biopsy, FBC and sickling status; blood urea and electrolytes; serum creatinine, serum uric acid; chest X-ray, ultrasound of kidneys, CT scan and/or magnetic resonance imaging, to detect aortic nodes and metastases to the lungs and liver; pelvic examination under anesthesia; cystoscopy and proctoscopy with or without biopsy, to allow visualization of vesical or rectal mucosa. Treatment objectives: to treat central tumor, to treat areas of tumor spread with the aim of eradicating the disease. Non-pharmacological treatment: surgery, radiotherapy, a combination of surgery and radiotherapy. Pharmacological treatment evidence rating: A. Adjuvant chemotherapy, C-section on referral below. Referral criteria: all patients must be referred to a specialist for evaluation, to decide on stage of disease and best mode of treatment. Treatment of carcinoma of the cervix is best done in hospital under specialist team care. 14. Chapter 388. Disorders of the kidney and genitourinary system. 134. Acute glomerulonephritis. This is a disease characterized by damage to the glomerular filtration apparatus, which causes protein and blood to leak into the urine. Mechanisms for the glomerular damage may be immune-mediated. This condition may be associated with hypertension and fluid retention. Causes: post-streptococcal infections, pharyngeal or skin infections, infected scabies, other bacterial infections, for example Salmonella, hepatitis B virus, hepatitis C virus, HIV, parasitic, for example schistosoma malaria, systemic lupus erythematosus and other vasculitis. Symptoms: a history of preceding infection, generalized edema most marked around the eyes, breathlessness, anorexia, sometimes associated with vomiting and abdominal pain, fever, seizures, scanty urine, hematuria. Signs: edema, oliguria, urine volumes 400 ml/day, hypertension, hematuria, dark-colored urine, acute heart failure, coma. Investigations: urinalysis, acute glomerulonephritis. Chapter 14, Disorders of the kidney and genitourinary system. 389. Sediment shows erythrocytes, leukocytes and a variety of casts including erythrocyte casts. Proteinuria usually less than 2 g/24 hours, but may be in the nephrotic range. FBC, BU and creatinine. Throat cultures in children may be useful. Chest X-ray may show pulmonary edema. ECG. Immunology, for example ANA, anti-D's DNA, ASO, antistreptolizino, titers. Ultrasound of kidneys. Treatment objectives: to identify and stop the cause of renal injury, to prevent and control complications. Non-pharmacological treatment: bed rest, salt restriction in diet, control fluid balance. Adults control fluid retention by restricting daily fluid intake to 800 ml plus previous day's urine output. Children restrict fluids to 400 ml/m to a body surface area and previous day's urine output. Pharmacological treatment: A. For fluid retention in post-infectious glomerulonephritis. Evidence rating: B. Furosemide, oral or IV. Adult 40 mg daily, increasing to 80 mg daily. Children 1 month 12 years. 1 to 2 mg/kg/day initially. Increase by 1 to 2 mg/kg 8 hourly to a maximum of 6 mg/kg per day, not to exceed 80 mg per day. Neonates 0.5-1 mg/kg 8 to 24 hourly. maximum 2 mg/kg. B. For hypertension and post-infectious glomerulonephritis. Treat blood pressure. See section on hypertension. Referral criteria: refer all patients with complications of renal failure, severe cardiac failure and hypertensive encephalopathy that arise following post-infectious glomerulonephritis to a physician specialist or a nephrologist. Nephrotic syndrome. 390. Patients with other causes such as lupus nephritis or systemic vasculitis should also be referred to a physician specialist or a nephrologist. 135. Nephrotic syndrome. This condition is associated with proteinuria in excess of 3-3.5 g/1.73 meters 2 daily, accompanied by hypobuminemia, edema, hyperlipidemia and hypercoagulable state. Diuretics should be used with caution, and not given as a routine in children with nephrotic syndrome. Causes: primary glomerular disease, minimal change disease, common in children, focal and segmental glomerulosclerosis, membranous nephropathy, membranous proliferative glomerulonephritis, infections, bacterial, post-streptococcal infection, viral hepatitis B and C, HIV, parasitic, Plasmodium malariae, Schistosoma mansoni, filariasis, systemic diseases, diabetes mellitus, systemic lupus erythematosus, amyloidosis, drug-related, non-steroidal anti-inflammatory drugs. Symptoms: early morning facial puffiness, generalized body swelling, foamy appearance of urine, weight gain, unintentional, poor appetite. Signs: periorbital, peripheral, genital edema, ascites, pleural effusion, protein malnutrition particularly in children with long-standing disease. Investigations: urinalysis, BU and creatinine, serum albumin, serum lipids, fasting blood glucose. Nephrotic syndrome. Chapter 14, Disorders of the Kidney and Genitourinary System. 391. Serology, hepatitis B, C, HIV, HB electrophoresis, antinuclear antibody, ANA. Ultrasound of kidneys. Treatment objectives: to relieve symptoms, to treat underlying condition, to prevent and manage complications, to delay progressive kidney damage. Non-pharmacological treatment: restrict salt intake, adequate protein diet. 0.6-0.8 g/kg body weight of first-class protein, eggs, meat, fish, dairy products, per day for adult and 2 to 4 g/kg per day for children. Pharmacological treatment: A. For control of edema. First-line treatment. Evidence rating: C. Furosemide, IV, adult 40 to 80 mg 8 to 12 hourly, maximum 160 mg daily. Children refer to specialist. Note: 14 to 1 in children. Furosemide is used in conjunction with albumin infusion only in severoedema, or furosemide, oral, adult 40 mg daily, increasing to 80 mg daily, maximum 240 mg daily. Children refer to specialist. B. For control of resistant edema. Furosemide, IV or oral, as above for adults and children, and metolazone, oral, adults February 5, 10 mg once daily. Children refer to specialist. Acute kidney injury. 392. Note: 14-2 diuretics should be used with caution, and not given as a routine in nephrotic syndrome in children. C. For control of proteinuria. Lisinopril, oral, adult 5 to 20 mg daily and prednisolone, oral, adults 1 mg/kg daily. Children 60 mg/m2 or 2 mg/kg daily, maximum 80 mg. For long-term management, refer to a pediatrician. Note: 14-3 corticosteroids should be given to children and selected adults with minimal change nephrotic syndrome by specialists only. Referral criteria: refer all patients to a physician specialist, pediatrician or nephrologist immediately after diagnosis and stabilization. 136. Acute kidney injury. Acute kidney injury, AKI, is a term that has now replaced the term acute renal failure, ARF. It describes a sudden decrease in renal function occurring over a period of hours to days, resulting in accumulation of nitrogenous waste products and disruption of blood volume, electrolyte and acid-base balance. The differential diagnosis of AKI includes prerenal azotemia, renal, intrinsic, and post-renal, obstructive nephropathy. Forms of AKI. The most important risk factor for the development of AKI is the presence of pre-existing chronic kidney disease. Other than good medical care with avoidance of volume contraction, prevention of hypertension and avoidance of nephrotoxic agents. No specific interventions have been reliably demonstrated to prevent the development of ACI. During management, a strict fluid input and output chart should be maintained. ACI has been staged by the Kidney Disease, Improving Global Outcomes, KDIGO. ACI working group for severity according to the criteria below. KDIGO ACI definition: injury, based on the ACI criteria. Acute kidney injury. Chapter 14, Disorders of the Kidney and Genitourinary System. 393. Stage serum creatinine criteria. Urine output criteria: 1.5-1.9 times baseline or increase of 26.4 micromole 0.5 ml/kg/hour for 6 to 12 hours. 2.0-2.9 times baseline 12 hours. 3.0 times baseline or increase in serum creatinine to 353.6 micromole/L or initiation of dialysis 24 hours or in urea for 12 hours. Causes: obstetric, septic, abortion, post-cesarean section, severe preeclampsia/eclampsia, postpartum hemorrhage, BPH, HELLP, hemolysis, elevated liver enzymes, low platelet syndrome, gynecological, bilateral ligation of ureters following abdominal hysterectomy, medical, acute glomerulonephritis, hemolysis due to malaria infection, herbal medicines, typhoid fever, G6PD deficiency, diarrhea, vomiting and dehydration, surgical, hemorrhage, peritonitis, acute pancreatitis, obstructive uropathy, burn symptoms, nausea and vomiting, oliguria, anuria, edema, decreased appetite, metallic taste in mouth, hiccups, change in mood, flank pain, fatigue, acute kidney injury. 394. Diarrhea signs. Usually no specific signs. Investigations: urinalysis, FBC, BU and creatinine, serum uric acid, blood culture, urine culture, abdominopelvic ultrasound scan, plain X-ray of abdomen. Treatment objectives: to recognize and correct reversible causes, to prevent further renal injury, to maintain a normal electrolyte and fluid volume milieu, to remove toxic waste from the body. Dialysis, non-pharmacological treatment. Nutrition: give protein of high biological value at 40 g protein/day in adults. In children, 0.8-1 g/kg of first-class protein/day. Daily weighing. Maintain fluid balance. Beware of hyperkalemia. Avoid potassium-containing foods, for example bananas, coconut. Pharmacological treatment. First-line treatment. Evidence rating: CA. Treatment of hypervolemia. Sodium chloride 0.9%, IV, or Ringer's lactate, if there is no hyperkalemia, in cases of diarrhea and vomiting or blood transfusion, in severe bleeding, or plasma replacement, in cases of severe burns. Note 14-4 in children, give 10 to 20 ml/kg fluid boluses. B. To re-establish diuresis after adequate fluid replacement. Furosemide, IV. Acute kidney injury. Chapter 14, Disorders of the Kidney and Genitourinary System. 395. Adult 40 to 80 mg stat. Children 2 to 4 mg/kg stat. Do not repeat. See control of hyperkalemia. Adult calcium gluconate 10%, IV 10 to 20 milliliters, slow IV, over 2 to 5 minutes, and soluble insulin, IV 10 units in 50 to 100 milliliter, dextrose 50%, and sodium bicarbonate, IV 8.4%. 50 mg in 50 milliliters, 1 to 2 ml/kg over 5 minutes, use. Note 14-5. Do not mix calcium gluconate and bicarbonate in the same delivery system. Children, salbutamol, nebulized, preferred, 25 kilograms. 5 mg 25 kilograms. 2.5 mg or calcium gluconate 10%, IV 0.5-1 ml/kg, slow IV, over 5 to 10 minutes, and soluble insulin, IV 0.2 units in 5 milliliter, dextrose 20%, give 2.5-5 ml/kg/hour. Keep blood glucose at 10 to 15 mol/L, and sodium bicarbonate, IV 8.4%, 50 mg in 50 milliliters, 1 to 2 ml/kg over 5 minutes. Utes. Note 14-6 Do not mix calcium gluconate and bicarbonate in the same delivery system. D. Treatment of hypertension crises/encephalopathy. See section on hypertension. Note 14-7 Indications for dialysis. Congestive heart failure, pulmonary edema, electrolyte abnormalities especially hyperkalemia not controlled by conservative means. Metabolic acidosis, uremic symptoms, seizures, pericarditis, hypertensive crises/encephalopathy, chronic kidney disease. 396. Referral criteria. All patients with clinical indications for dialysis must be referred promptly to a center with facilities for dialysis. 137. Chronic kidney disease. Chronic kidney disease, CKD, refers to kidney damage of more than 3 months duration. The early stage of CKD is usually asymptomatic, but can be detected through laboratory tests of serum creatinine and estimation of glomerular filtration rate, eGFR, measurement of urine albumin creatinine ratio, and screening of individuals at increased risk such as those with hypertension, diabetes mellitus or a past history of glomerulonephritis. CKD may manifest either as urine abnormalities, for example persistent microalbuminuria, proteinuria, hematuria, blood abnormalities, for example elevated urea and creatinine, an estimated GFR 90 ml/minute/1.73 m2, and structural kidney changes on ultrasonography. For all stages of CKD, patients should be encouraged to cease smoking, reduce weight if obese, check lipids and treat, and avoid NSAIDs and other nephrotoxic drugs. Table 14-1, Stages of Chronic Kidney Disease. Stage description: eGFR, ml/min/1.73 m2, 1 kidney damage with normal or increased GFR, 90, 2 kidney damage with mild reduction in GFR 60-89, 3. Moderate reduction in GFR 30-59, 4 severe reduction in GFR 15-29, 5 kidney failure. 15 causes: chronic hypertension, chronic glomerulonephritis, diabetes mellitus, obstructive uropathy, renal calculi, polycystic kidney disease, toxins, drugs, herbs, heavy metals, etc. Connective tissue disease. Symptoms: none in the early stages. Reduced attention and concentration, anorexia, nausea, vomiting. Chronic kidney disease. Chapter 14, Disorders of the Kidney and Genitourinary System. 397. Gastrointestinal bleeding, hiccups, breathlessness on exertion, thirst, nocturia, polyuria, muscle cramps, paresthesia, pruritus, insomnia. Signs: lethargy, bleeding tendency, pallor, hypertension, pericarditis, peripheral neuropathy, peripheral edema, asterixis, flapping tremor, increased skin pigmentation and/or excoriation. Investigations: FBC, sickling, blood film comment, urinalysis, blood urea, electrolytes, serum creatinine, calcium, phosphate, fasting blood glucose, lipids, chest X-ray, ultrasound of kidneys. Treatment objectives: to detect chronic kidney disease early in susceptible individuals, to control hypertension, to control blood glucose, to manage underlying causes, to prevent complications and further worsening of kidney function. Non-pharmacological treatment: avoid nephrotoxins, for example NSAIDs, herbal medication, daily intake of fluid of 600 milliliters over previous day's urine output for adults, 400 ml/m2 body surface area in children. Restrict salt intake. Restrict dietary protein to 1 gram/kg/day. Avoid potassium-containing foods, for example bananas. Dialysis: refer to a nephrologist. Chronic kidney disease. 398. Pharmacological treatment. A. To control fluid overload. First-line treatment evidence rating: C. Furosemide, oral or IV, 40 to 120 mg daily. B. Treatment of hypertension. See section on hypertension. C. Treatment of renal anemia. See section on anemia in chronic kidney disease. D. Control of hyperkalemia. Adult calcium gluconate 10%, IV 10 to 20 milliliters, slow IV over 2 to 5 minutes, and soluble insulin, IV 10 units in 50 to 100 milliliter, dextrose 50%, and sodium bicarbonate, IV 8.4%, 50 mg in 50 milliliters, 1 to 2 ml/kg over 5 minutes. Utes. Note 14-8 Do not mix calcium gluconate and bicarbonate in the same delivery system. Children. Salbutamol, nebulized, preferred, 25 kilograms. 5 mg 25 kilograms. 2.5 mg or calcium gluconate 10%, IV 0.5-1 ml/kg, slow IV, over 5 to 10 minutes and soluble insulin, IV 0.2 units in 5 ml dextrose 20%, give 2.5-5 ml/kg/hour. Keep blood glucose at 10 to 15 mol/L and sodium bicarbonate, IV 8.4%, 45 mg. Over 5 minutes, 1 to 2 mol/kilograms, 1 to 2 ml/kg. Note 14-9 Do not mix calcium gluconate and bicarbonate in the same delivery system. Referral criteria Refer all patients with predisposing factors and complications to a physician specialist or nephrologist for further definitive management of chronic kidney disease. Refer all patients requiring dialysis to a nephrologist. Anemia in chronic kidney disease. Chapter 14, Disorders of the Kidney and Genitourinary System, 399. Table 14.2, Summary of Management of Various Stages of CKD. CKD Stage Description. Action 1. Kidney damage with normal or reduced GFR. Diagnosis and treatment. Slow progression by meticulous BP control. Annual follow-up. eGFR, urinalysis and urine protein creatinine ratio measurements. 2. Kidney damage with mildly decreased GFR. Estimate progression and manage as stage 1. 3. Moderately decreased GFR. Estimate and treat complications. If HbA1c/DL, check ferritin, B12 and folate. Annual check of serum calcium, phosphate, and PDH. Refer if eGFR 30 ml/min/1.73 meters. 2. For severely decreased GFR, prepare for kidney replacement therapy. Refer 5. Kidney failure. Kidney replacement therapy, dialysis or transplantation. Refer 138. Anemia in chronic kidney disease. Anemia develops early in the course of chronic kidney disease, CKD, and is nearly universal in patients with CKD stage 5 and stage kidney disease. The prevalence of anemia at higher levels of glomerular filtration rate, GFR, that is CKD stage 1 to 2, is relatively low in individuals from the general population. Anemia of CKD is primarily caused by deficiency of erythropoietin. The kidneys are the major source of erythropoietin, and, as renal function declines, production of erythropoietin declines proportionately. Though erythropoietin deficiency is common among patients with anemia and CKD, other potential causes and contributing disorders should be identified or excluded if initial evaluation yields evidence for disorders other than iron deficiency or erythropoietin deficiency. Correction of anemia in CKD patients improves survival and quality of life. Causes: deficiency of erythropoietin, red cell destruction from microvascular disease from diabetes or hypertension, increased gastrointestinal bleeding, increased oxidative stress leading to shortened red cell survival. Symptoms: C-section on anemia. Anemia in chronic kidney disease. 400. Signs: C-section on anemia. Investigations: FBC, reticulocyte count, transferrin saturation, serum ferritin, stool occult blood. Treatment objectives: to achieve and maintain a target range HB level of 11 to 12 G/DL. Non-pharmacological treatment: C-section on anemia. Pharmacological treatment: A. CKD stages 1-2. First line treatment evidence rating: A. Ferrous sulfate, oral, 325 mg 8 hourly for 4 weeks. B. CKD stages 3 to 4. Iron replacement, target HB should be 11 to 12 G/DL. Ferrous sulfate, oral, 325 mg 8 hourly, or ferrous gluconate, oral, 300 mg 8 to 12 hourly. Evaluate after 4 to 6 weeks. Or iron sucrose, IV, consult specialist, or ferric sodium gluconate complex, consult specialist, and epoetin beta, SC, consult specialist, or methoxy polyethylene glycolipoetin beta, pegylated form of EPO, SC, consult specialist, or darbepoetin alpha, SC, consult specialist. Referral criteria for all adults and children, patients with CKD and anemia to a specialist or nephrologist. Urinary tract infection. Chapter 14, Disorders of the Kidney and Genitourinary System. 401. 139. Urinary tract infection. Urinary tract infection, UTI, is the presence of microorganisms in the urine or tissues of the normally sterile genitourinary tract. Infection may be localized to the bladder alone or the kidneys, or, in men, the prostate. Acute uncomplicated UTI occurs in women with a normal genitourinary tract and usually manifests as acute cystitis, bladder infection, or lower tract infection. Complicated UTI occurs in individuals with structural or functional abnormalities of the genitourinary tract, including those with indwelling devices such as urethral catheters. Congenital abnormalities of the genitourinary tract predispose children to UTI. Proven UTI in the child or recurrent UTI requires further urogenital evaluation. Definitive treatment of UTI depends on culture and sensitivity reports. However, empirical treatment may be initiated while awaiting the report. Causes: bacteremia or septicemia, urinary tract obstruction, for example enlarged prostate in adult males, posterior urethral valves in infants/children. Symptoms: frequent painful urination, hematuria, cloudy/foul-smelling urine, vomiting, suprapubic pain, fever, may be persistent and unexplained. In children, there may be feeding problems, diarrhea, and failure to thrive as well. In children, note 14 to 10 UTI symptoms can be nonspecific in young children. Signs: fever, loin tenderness, suprapubic tenderness, foul-smelling urine. Investigations: FBC, midstream specimen of urine for microscopy, culture, and sensitivity, reculture urine after treatment, abdominal ultrasound scan in children if indicated. Urinary tract infection. 402. Treatment objectives: to relieve symptoms such as fever and pain. See section on fever and pain management. To eradicate causative agent. To prevent complications. To identify patients with abnormalities of the genitourinary tract. Non-pharmacological treatment. Liberal oral fluids to encourage good urinary output. Personal hygiene and proper cleaning after defecation. Pharmacological treatment. Treatment of uncomplicated UTI. First-line treatment evidence rating. C. Ciprofloxacin, oral, adults 500 mg 12 hourly for 7 days, female 10 to 14 days, male, children 15 to 20 mg/kg 12 hourly, maximum of 750 mg daily in 2 divided doses, or cefuroxime, oral, adults 250 to 500 mg 12 hourly for 5 to 7 days, female 10 to 14 days, male, children 12 to 18 years. 250 mg 12 hourly for 5 to 7 days 2 to 12 years. 15 mg/kg 12 hourly, maximum 250 mg, for 5 to 7 days 3 months 2 years. 10 mg/kg 12 hourly, maximum 125 mg, for 5 to 7 days. B. Treatment with complicated UTI, including catheter-related, stones, prostate enlargement, urologic abnormalities and pregnancy. First-line treatment evidence rating, C. Ciprofloxacin, IV, adults 400 mg 8 to 12 hourly for 7 days, to be administered over 60 minutes, or gentamicin, IV, if kidney function is normal, adults 40 to 80 mg 8 hourly for 7 days, children 12 to 18 years. 2 mg/kg 8 hourly for 7 days 1 month 12 years. 2.5 mg/kg 8 hourly for 7 days, or ceftriaxone, IV, adults 1 to 2 t daily for 7 days. Medicines and the kidney. Chapter 14, Disorders of the Kidney and Genitourinary System. 403. Children all ages 25 mg/kg 12 hourly, maximum 75 mg/kg daily, or amoxicillin plus clavulanic acid, IV, children 1 month 18 years. 20 to 30 mg/kg 8 hourly, maximum 500 mg, for 5 to 7 days. Neonates, dose doubled in severe infection, 7 to 28 days. 30 mg/kg 8 hourly for 5-7 days 7 days. 30 mg/kg 12 hourly for 5-7 days. And gentamicin, IV, slow intravenous injection over at least 3 minutes, children 12 to 18 years. 2 mg/kg 8 hourly 1 month 12 years. 2.5 mg/kg 8 hourly or cefuroxime, IV, children 1 month 18 years. 20 mg/kg 8 hourly maximum 750 mg, increase to 40 to 50 mg/kg maximum 1.5 g 6 to 8 hourly in severe infections, neonates, double the dose in severe infections, IV route, only 21 to 28 days. 25 mg/kg 6 hourly 7 to 12 days. 25 mg/kg 8 hourly 7 days. 25 mg/kg 12 hourly referral criteria: refer patients who are very ill, with recurrent UTI, persistent hematuria and congenital abnormalities to the appropriate specialist. 140. Medicines and the kidney. Medicines can lead to renal damage in a number of different ways, and examples are given below. In the wrong circumstances, life-saving medicines can do more harm than good. Doctors, pharmacists, and nurses can help their patients by checking their treatment charts in hospital or at the outpatients department. The medicines listed below may cause renal impairment and must therefore be stopped or not prescribed in patients with deteriorating renal function. All medicines in this table should be dosed based on kidney function, estimated GFR. Avoid concomitant use of nephrotoxic medications and diuretics. Monitor renal function before and during treatment. Patient-related risk factors for all these medicines include age, pre-existing chronic kidney disease, volume depletion, and concurrent use of nephrotoxic medicines. Medicines and the kidney. 404. Medication risk factor. Pathophysiology. Prevention. Acyclovir high dose, IV bolus dose. Deposition of acyclovir crystal. Intratubular obstruction and foci of interstitial inflammation. Crystal nephropathy. Proximal tubulopathy. Avoid bolus dose. Prior hydration. Maintain urine output 75 ml/hour. Slow drug infusion over 1 to 2 hours. Aminoglycosides, for example gentamicin, dose, duration, and frequency of administration. Concurrent renal ischemia or administration of nephrotoxins. Liver disease. Plasma concentration 10 mg/dl peak in proximal tubule. Aminoglycoside bound to an ionic phospholipid, delivered to megalin, endocytic uptake into the cell. Within cell, accumulates direct toxicity. ACI. Maintain therapeutic range. Give once daily dose if necessary. Angiotensin converting enzyme inhibitors/angiotensin receptor blockers, for example lisinopril/losartan. Vasoconstriction, prerenal ARF. Avoid in bilateral renal artery stenosis. Non-steroidal anti-inflammatory drugs, and NSAIDs, for example ibuprofen. Volume and sodium depletion. Diuretic use. Large dose and long therapy. Severe liver disease. Hemodynamically induced ACI due to vasoconstriction via reduced prostaglandin production. Acute and chronic tubulointerstitial nephritis, with or without nephrotic syndrome. Direct toxicity. Chronic interstitial nephritis and papillary necrosis. Avoid co-prescription of diuretics. Avoid large dose, radiocontrast dose and frequency. Osmolarity of contrast media. High osmolarity, medullary vasoconstriction, active transport in thick ascending loop of Henle, increased oxygen demand. Hydration before and after administration. Acetylcysteine unproven. Medicines and the kidney. Chapter 14, Disorders of the Kidney and Genitourinary System. 405. Medication risk factor. Pathophysiology. Prevention. Methotrexate acidocurine high dose precipitates in the urine, and induces tubular injury. Prior hydration. Alkaline urine to pHs greater than 7.03 L. 5% dextrose in water plus 44 to 66 mol of NaHCO3 per day. Cisplat in low chloride. High-dose chloride in cis position replaced by H2O, highly reactive hydroxyl radical via 450 Cypress pounds. DNA injury. Tubular cell death. Nephrogenic diabetes insipidus. Hypomagnesemia may be persistent. Mesna. Cyclosporin/tacrolimus dosage. Postoperative ACI. Diabetes. Hypertension. Decrease PG, and increase 20 heat acid production. Vasoconstriction. Generation of H2O2 resulting in depleted glutathione. decreased GFR, ischemic collapse or scarring of the glomeruli, vacuolization of the tubules, and focal areas of tubular atrophy and interstitial fibrosis. Maintain in therapeutic range. Avoid drugs that raise CYP3A4 inhibitors, calcium channel blockers, interferon prerenal achy-tubulointerstitial nephritis, thrombotic microangiopathy, membranoproliferative glomerulonephritis, tenofoverdose, duration tubular cell cariomegaly, degeneration and necrosis, interstitial nephritis, achy, Fanconi syndrome, acute cystitis, 406. Medication risk factor pathophysiology prevention lithium renal impairment dehydration hyponatremia diuretic use especially thiazide impairment of collecting duct concentrating ability diabetes insipidus chronic tubulointerstitial nephropathy therapeutic range 0.6-1.2 mol/L prevent dehydration avoid low sodium diet avoid thiazide achy acute kidney injury ACE and angiotensin converting enzyme heat hydroxyacetyltetraenoic acid PG, prostaglandin 141. Acute cystitis. Acute cystitis is an acute inflammation of the bladder. Women are affected 10 times more than men due to the shortness of their urethra compared to that of men. 40%-50% of all women will develop cystitis in their lifetime. The ascending fecal perineal urethral route is the primary mode of infection. Occasionally sexually transmitted organisms are involved. Risk factors include urethral catheterization and diabetes. Causes: E. coli, about 80%, Staphylococcus saprophyticus, Klebsiella, Proteus mirabilis, Gonococcus, Enterococci. Symptoms: low-grade fever, frequency, nocturia, urgency, dysuria, hematuria, cloudy and foul-smelling urine, low back and suprapubic pain. Signs: low-grade fever, suprapubic tenderness, hematuria. Investigations: urinalysis, acute cystitis, Chapter 14, Disorders of the Kidney and Genitourinary System. 407. Midstream urine for culture and sensitivity. FBC, FBS. Imaging of urinary tract in recurrent or persistent cases to exclude anatomical abnormalities, lower urinary tract obstruction, etc. Urethrocystoscopy in selected cases. Treatment objectives: to eradicate infection, to prevent recurrence and complications, to relieve pain. Non-pharmacological treatment: liberal oral fluids to encourage good urinary output, pre-coital and post-coital emptying of the bladder, personal hygiene and proper cleaning after defecation especially in females. Pharmacological treatment: A. Acute uncomplicated cystitis, absence of fever and flank pain. First-line treatment evidence rating: A. Nitrofurantoin, oral, adults 100 mg 6 hourly for 5 to 7 days, children 12 to 18 years. 50 mg 6 hourly for 7 days 3 months 12 years. 750 micrograms/kg 6 hourly for 7 days. Second line treatment evidence rating: A. Ciprofloxacin, oral, adults 500 mg 12 hourly for 5 to 7 days, children 12 to 18 years. 250 to 750 mg 12 hourly 1 month 12 years. 7.5 mg/kg 12 hourly, dose doubled in severe cases. Neonates 7.5 mg/kg 12 hourly or cefuroxime, oral, adults 500 mg 12 hourly for 5-7 days, children 12 to 18 years. 250 mg 12 hourly, dose reduced to 125 mg 12 hourly in lower urinary tract infections, 2 to 12 years. 15 mg/kg 12 hourly, maximum 250 mg 12 hour. Benign prostatic hyperplasia. 408. Lie, 3 months 2 years. 10 mg/kg 12 hourly, maximum 125 mg 12 hourly, and evidence rating: C. Mist potassium citric, oral, 10 ml 8 hourly, if urine is acidic, pH of 6 or below, to reduce bladder pain and dysuria. Note 14 to 11. Monitor potassium levels, and avoid in hyperkalemia. Do not give with ciprofloxacin or paracetamol, oral, 500 mg 1g 6 to 8 hourly when required. B. For symptomatic cystitis and UTM pregnancy, cefuroxime, oral, adults 500 mg 12 hourly for 5-7 days and evidence rating. C. Mist potassium citrate, oral, 10 ml 8 hourly, if urine is acidic, pH of 6 or below, to reduce bladder pain and dysuria. Note 14 to 12 monitor potassium levels, and avoid in hyperkalemia. Do not give with ciprofloxacin. Referral criteria are for all cases, which require cystoscopy and all cases of persistent hematuria, recurrent cystitis or bacterial resistance to the specialist. 142. Benign prostatic hyperplasia. Benign prostatic hyperplasia, BPH, refers to non-cancerous enlargement of the prostate gland which results in obstruction of urine flow from the bladder. BPH is the commonest cause of male urinary symptoms in Ghana. The average age at which lower urinary tract symptoms, LUTS, related to BPH occurs, is about 50 years. Men may seek treatment for LUTS either because the symptoms are bothersome, or they feel that it may lead to acute urinary retention, or out of fear that it may be an indication of prostate cancer. It is important to establish what the patient wants from the consultation. In some patients, once reassured that the likelihood of urinary retention and prostate cancer is low, they may not wish treatment. Benign prostatic hyperplasia. Chapter 14, Disorders of the Kidney and Genitourinary System. 409. For the symptoms, currently available medicines can either relax prostatic smooth muscles, or cause reduction in the prostate size, and therefore ease the symptoms of BPH. A combination of available medications, especially in patients with a prostate size more than 40 milliliters, produce better responses than monotherapy. BPH may lead to complications such as recurrent urinary tract infection, acute urine retention with painful distension of the bladder, chronic urine retention with painless gross distension of the bladder, hematuria, and renal failure. Causes: increase in number of prostate cells due to stimulation by testosterone. Symptoms: lower urinary tract symptoms, previously referred to as prostatism, hesitancy, delay in initiating urination, poor or weak urinary stream, straining, terminal dribbling, sensation of incomplete bladder emptying, urinary incontinence, overflow, or bedwetting, frequent passage of urine especially at night, nocturia, urgency and urgent continence signs, enlarged prostate gland on rectal examination, tender palpable bladder acute urinary retention, non-tender palpable bladder chronic retention, uremic signs, for example drowsiness, confusion etc. Palpable kidneys and hydronephrosis investigations. Serum creatinine, prostate-specific antigen, SAP, to exclude prostate cancer. Urine for culture and sensitivity. Abdominal and pelvic ultrasound, to exclude hydronephrosis, if serum creatinine is elevated. Treatment objectives, to exclude prostate cancer, and reassure patients accordingly. To relieve symptoms, and prevent development of complications. To identify and treat any associated complications. Non-pharmacological treatment. Program of monitoring, and watchful waiting through regular checkups for mild symptoms. Bacterial prostatitis. 410. Urethral catheterization for acute retention of urine or suprapubic cystostomy, if urethral catheterization fails. Suprapubic needle puncture, and aspiration/drainage of urine to partially decompress the bladder and relieve pain, when suprapubic cystostomy is delayed. Pharmacological treatment. A. Patients with bothersome symptoms and prostate size less than 40 milliliters, small prostate. First-line treatment evidence rating. A. Tirazosin, oral, 2 to 10 mg at night. Start with 2 mg at night. Double dose at weekly intervals, maximum 10 mg. Or tamsulosin, oral, 400 microgram once daily. Or alfuzosin, oral, 10 mg daily. B. Patients with bothersome symptoms and prostate size more than 40 milliliters, big prostate. Evidence rating. A. Finasteride, 5 mg daily, and tirazosin, oral, 2 to 10 mg at night. Start with 2 mg at night. Double dose at weekly intervals, maximum 10 mg. Or tamsulosin, oral, 400 microgram daily. Or alfuzosin, oral, 10 mg daily. Referral criteria: refer patients who don't respond to pharmacological treatment, or have complications, urine retention, hematuria, renal failure and recurrent urinary tract infection, to a urologist or surgical specialist. 143. Bacterial prostatitis. Prostatitis is inflammation of the prostate gland, which may be bacterial or abacterial. Bacterial prostatitis is more common than abacterial prostatitis. It may present as an acute condition which may either be sexually transmitted or result from urethral reflux of infected urine into the prostatic ducts. Other potential sources may be bacterial spread from rectum or bloodstream. If inadequately treated, this may progress to chronic prostatitis. It is more common in men below 50 years. Bacterial prostatitis. Chapter 14. Disorders of the kidney and genitourinary system. 411. Causes. Gram-negative bacterial infections, for example from E. coli, Pseudomonas, Streptococcus faecalis, Proteus, Klebsiella, Serratia and Enterobacteria. Sexually transmitted infections, for example from Gonococcus and Chlamydia. Symptoms: acute fever, chills and malaise, low back and waist pain, myalgia and arthralgia, rectal/perineal pain, urinary urgency and frequency, nocturia, dysuria, difficulty in urination/retention of urine, hematuria, hemospermia and loss of libido. Chronic insidious onset, relapsing UTI, persistence of bacteria in seminal fluid despite antibiotic treatment, low back and waist pain, urinary urgency and frequency, nocturia, difficulty in urination, hematuria, hemospermia. Signs: acute, swollen and tender prostate on digital rectal examination. Dread. Avoid prostatic massage as this could lead to septicemia. The rectum feels hot from the inflammation. Chronic findings on DRE may be normal or tender prostate. Occasionally for long-standing disease it may feel very firm or hard, as in prostate cancer. Investigations: urinalysis and culture, FBC, ESR, SAP, blood culture, expressed prostatic secretions for culture and sensitivity through DRE. Voided specimen before and after prostate massage compared. Bacterial prostatitis. 412. In chronic prostatitis only. Treatment objectives: to relieve pain and fever, to control infection, to relieve lower urinary tract obstruction, to prevent chronic prostatitis. Non-pharmacological treatment: bed rest, hydration. Hospitalization may be required in severe cases, or when the condition is complicated by acute urinary retention and significant hematuria. Suprapubic cystostomy for acute urinary retention. Urethral catheterization should be avoided. Pharmacological treatment: A. Mild to moderate infections. First-line treatment. Evidence rating: B. Ciprofloxacin, oral, 500 mg 12 hourly for 4 to 6 weeks, and doxycycline, oral, 100 mg 12 hourly for 4 to 6 weeks. 2. ND-line treatment: levofloxacin, oral, 500 mg daily for 4 to 6 weeks, and doxycycline, oral, 100 mg 12 hourly for 4 to 6 weeks. B. Severe infections: ciprofloxacin, IV, 400 mg 8 to 12 hourly, to be administered over 60 minutes, or levofloxacin, IV, 500 mg 12 hourly, or ceftriaxone, IV, 1-2 g daily, and gentamicin, IV, 80 mg 12 hourly. Note 14-13. Initial therapy with parenteral antibiotics is indicated in severe cases. Follow-up should be for at least 4 months. C. For improvement of urinary flow: tamsulosin, 400 micrograms daily, at night, or alfuzosin, 10 mg daily, or scrotal masses. Chapter 14. Disorders of the kidney and genitourinary system. 413. Tirazosin, 2 to 5 mg daily, at night. D. Adjunct treatment in severe presentations. Evidence rating: C. Sodium chloride 0.9%, IV, as required in severe systemic infections, and ibuprofen, oral, 400 mg 8 hourly when required, or diclofenac, oral, 75 mg 12 hourly when required, and lactulose, oral, 10 to 15 ml 12 hourly, and adjust dose accordingly. Referral criteria are for all cases of severe infections or chronic prostatitis for specialist care. 144. Scrotal masses: these are swellings found in the scrotum. Causes: painless swellings, testicular tumor, inguinoscrotal hernia, hydrocele of spermatic umbilical cord, spermatical/epididymal cysts, verrucocele, epididymal tumors, chronic epididymoorchitis, painful swellings, testicular torsion, acute epididymitis, ST or non-ST-related, acute epididymoorchitis, strangulated inguinoscrotal hernia, testicular tumor, usually painless except rapidly growing type or tumor necrosis. Verrucoceles are occasionally accompanied by pain/discomfort symptoms. Swelling and or pain of scrotum or its contents. Sudden onset, for example torsion of testis. Gradual onset, for example spermaticole, hydrocoles. Gradual onset becoming suddenly painful, for example obstructed hernia. Fever may be present in infections, for example acute epididymitis and acute epididymoorchitis. The empty scrotum. 414 signs. Tender or non-tender swelling restricted to the scrotum, except a hernia which may extend into the inguinal area. Fever may be present in infections. Transillumination for cystic swellings, for example hydrocoles and spermatoceles. Hard swelling, for example tumor investigations. Ultrasound scan with or without color Doppler. Laboratory investigations are tailored towards cause and specific treatment objectives to make an accurate diagnosis, to ensure appropriate treatment, to relieve pain, to prevent complications, to expedite emergency intervention. Egg testicular torsion, non-pharmacological treatment. Surgery, elective or emergency. Emergency surgery within 6 hours is required for testicular torsion to salvage the testis. Pharmacological treatment. A. For sexually transmitted infection. Evidence rating. B. Ciprofloxacin, oral, 500 mg single dose, and doxycycline, oral, 100 mg 12 hourly for 10 days, or ceftriaxone, 250 mg single dose, and doxycycline, oral, 100 mg 12 hourly for 10 days. Referral criteria for all emergency cases and those suspected to be tumors to a urologist or surgical specialist. 145. The empty scrotum. This refers to the absence of testis or testes in the scrotum/hemiscrotum. 10% of cases are bilateral. 75% of full-term infants with undescended testes and 90% of premature infants would have spontaneous descent of testes from the intra-abdominal site by the age of 1 year. Persistent undescent of the testis is associated with an increased the empty scrotum. Chapter 14. Disorders of the kidney and genitourinary system. 415. Risk of malignancy, subfertility, atrophy of the testes and torsion. All health workers who see neonates and children should do routine examination of the scrotum and testis to prevent late presentations and complications. Causes. Undescended testes. Unknown/idiopathic. Most cases are congenital. Premature birth. Genetically inherited diseases associated with anomalies like prune belly syndrome and hypospadias. Ectopic testis. Retractile testis. Severe atrophy. Orchidectomy. Agenesis of the testes, rarely. Symptoms. Absence of one or both testes. In children, parents or the health worker may notice this at birth. Signs. Absent testis in both supine and upright positions. Investigations. Ultrasound scan of abdomen, pelvis and inguinal canal. Treatment objectives. To decrease potential for cancer. To improve fertility. To repair hernia. To decrease risk of torsion. To avoid social and psychological complications. Non-pharmacological treatment. Surgical intervention before 2 years of age. All ectopic testes should be operated, because they will not descend. Pharmacological treatment. Non-referral criteria. Refer patients aged over 1 year with no evidence of testicular descent to a urologist or surgical specialist. Priapism. 416. 146. Priapism. This refers to a spontaneous, prolonged, persistent, usually painful erection, which is unwanted, and not associated with sexual desire, and not relieved by coitus. Priapism is classified into 3 types, namely, low flow or ischemic, commonest, high flow, non-ischemic, and stuttering priapism. It is commonly seen as a prolongation of nocturnal penile tumescence, and PT, or early morning erection. This is a well-known complication of sickle cell disease. Patients are usually shy and reluctant to come to the hospital due to stigmatization. Late presentation is therefore common, and herbal medicine applications and spiritual remedies may have been tried to relieve symptoms prior to being seen in hospital. Early reversal within 24 to 48 hours may reduce the high impotence complication reduction rate to 50%. Although the occurrence is usually in adults, it may periodically occur in older children. Causes: idiopathic or unknown in 60% of cases. Drugs, for example marijuana and herbal concoctions. Other causes: leukemia, sickle cell disease and thalassemia, penile trauma, spinal cord injury, pelvic infections, pelvic tumor, iatrogenic, for example intracavernous prostaglandin E1 for impotence, sildenafil citrate, psychotropics, for example chlorpromazine. Symptoms: painful persistent erection signs, erect, tender penis. Clinical signs of sickle cell disease investigations: FBC, blood film comment, sickling status, HB electrophoresis. Urinalysis. Treatment objectives: to relieve pain, to ensure early relief of penile congestion, to prevent complications. Posterior urethral valves. Chapter 14, Disorders of the Kidney and Genitourinary System. 417. Non-pharmacological treatment evidence rating. A. Maintain adequate hydration. Winter's procedure. Corporal irrigation. Surgery. Shunts. Pharmacological treatment. A. Conservative management evidence rating. C. Sodium chloride 0.9%. I. Adults 1 ml 6 hourly and liberal oral fluids. Children 500 ml 6 hourly and liberal oral fluids. And pethidine, adults 100 mg 8 hourly, if required. Children 1 mg/kg, maximum 50 mg 8 hourly if required. And diazepam, IV, adult 10 mg stat, given slowly over 2 to 3 minutes, approximately 2.5 mg every 30 seconds. Then refer children 0.3 mg/kg stat, given slowly over 2 to 3 minutes. Then refer B specialist management. Intracavernous injections. Referral criteria. Referral criteria: patients not responding to conservative management should be promptly referred to a urologist or surgical specialist. 147. Posterior urethral valves. These valves or folds of tissue are congenital obstructing membranes within the lumen of the urethra. It affects between 1 in 5,000, 8,000 males. It is the commonest cause of congenital bladder outlet obstruction. They obstruct urinary outflow from the bladder, but permit easy urethral catheterization. Because the obstruction starts in utero, secondary changes in the bladder and upper urinary tract are advanced at birth. Some patients may be born with severe renal impairment, or this may develop soon after birth if recognition is delayed. Most patients present as neonates or infants. Occasionally presentation is late in childhood. All posterior urethral valves. 418. Male newborn babies should be closely watched to ensure a good stream of urine. Prenatal diagnosis is possible using ultrasound. Causes: congenital valves or folds within the lumen of the posterior urethra. Symptoms: poor urinary stream, crying while voiding, straining to void with dribbling of urine, intermittent stream, failure to drive, fever, poor feeding, abdominal distension. Signs: voiding dysfunction, palpable bladder and kidneys, respiratory distress, signs of sepsis, for example fever, azotemia/uremia, poor physical growth/growth retardation. Investigations: FBC, blood urea, electrolytes and creatinine, urinalysis, urine culture, abdominal ultrasound, micturating cystourethrogram. Treatment objectives: to prevent and treat renal failure, to remove obstructing valves. Non-pharmacological treatment: prompt bladder decompression and continuous drainage, to protect the upper tract from back pressure damage. This is preferably done by vesicostomy in most infants. Indwelling catheters should be avoided in most cases due to complications and death from septicemia. Surgical removal or destruction of the valve. Pharmacological treatment evidence rating. A. Treatment of urinary tract infections. See appropriate section. Referral criteria: refer immediately after diagnosis for specialist evaluation. And urinary tract calculi. Chapter 14, Disorders of the Kidney and Genitourinary System. 419. Treatment. 148. Urinary tract calculi. These are crystal-like objects, which form in various parts of the urinary tract. They consist mainly of mineral salts, that is crystal-forming ions. Some of the common stone types include calcium oxalate, calcium phosphate, magnesium ammonium phosphate and uric acid. Some risk factors in developing stones include crystalluria, affluence, diet, occupation, climate, dehydration, family history and medications. Majority of stones less than 5 millimeters in diameter will pass spontaneously. Causes: hypercalcemia, hyperuricemia, hyperoxaluria, urinary stasis and obstruction, urinary tract infection, struvite, infection, stones, foreign body including urinary catheter and suture material, idiopathic hypercalciuria, dehydration, immobilization especially in the elderly, inborn errors of metabolism for example cystinuria symptoms and signs, location of calculi symptoms signs, kidney/ureter loin pain ureteric colic, sudden acute agonizing paroxysmal pain, which begins in the loin, then radiates around the flank towards the bladder and scrotum/testis in the male and labia majus in the female, may be associated with nausea, vomiting and sweating hematuria. Signs may be few, but tenderness in the loin and abdomen would be felt during a painful attack. Sometimes there may be associated abdominal distension and fever. If there is superadded infection, a hydronephrotic kidney may be palpable. Urinary tract calculi - 420. Location of calculi symptoms signs: bladder/urethra, suprapubic pain, frequency, urgency, hematuria, strangury, an uncontrollable and often painful desire to pass urine, which results in little urine, may be blood-stained, or no urine being voided, retention of urine, suprapubic tenderness, palpable bladder, from retention or a large stone, heart, urethra lump, impacted stone, hematuria. Investigations: urinalysis, urine culture, blood urea, electrolytes and creatinine, serum uric acid, calcium, phosphate, magnesium, plain X-ray of abdomen, ultrasound scan of abdomen, intravenous urogram, retrograde ureteral pyelogram, CT scan, stone analysis. Treatment objectives: to control pain during the acute attack, to aid passage of the calculus, or ensure complete removal of calculus, to remove large stones, to prevent recurrence, if the cause is known, to treat associated infections. Non-pharmacological treatment: encourage oral fluid intake, 2 to 3 L daily in an adult, and avoid dehydration. Avoid low calcium diet. It encourages increased oxalate excretion. Diet therapy: manage acute urinary retention due to bladder or urethral stones by urethral catheterization or suprapubic cystostomy respectively. Pharmacological treatment evidence rating: B. Pethidine, IM, 100 mg 4 hourly as required, or diclofenac, IM, 75 mg 12 hourly, or diclofenac, rectal, 100 mg 12 hourly. Urethral stricture - Chapter 14, Disorders of the Kidney and Genitourinary System, 421, and hyoscine butylbromide, I, 20 mg 8 hourly, or mepeverine, oral, 135 mg 8 hourly may be useful. Caution: 14:1. Avoid morphine as it may cause further ureteric spasm and worsening of symptoms. Give antibiotics if urinary tract infection is present. See section on urinary tract infection. Referral criteria: refer to a urologist or surgical specialist for definitive treatment after initial management. 149. Urethral stricture: this refers to a narrowing or complete obstruction of the urethral lumen due to fibrosis, scarring. It is the second commonest cause of retention of urine in gonorrhea and the most common in young males, usually resulting from previous inadequately treated ST. The commonest site is the anterior urethra, that is bulbar and penile urethra in males. It may be complicated by periurethral abscess, superficial extravasation of urine and urethroCutaneous fistulae, retention of urine and postrenal renal failure. Causes: gonococcal or non-gonococcal urethritis, external trauma for example road traffic injuries, falls, straddle or astride injury and pelvic fractures. Iatrogenic, urethral instrumentation for example catheterization, endoscopy. Postoperative for example prostatectomy. Congenital strictures, rare. Symptoms: lower urinary tract symptoms, LUTS, for example poor urinary stream, split or splate stream, reduced caliber of stream improved by straining, frequency and dysuria, post-void dribbling, incomplete emptying of bladder, urinary overflow, incontinence, urinary retention, acute or chronic. Signs: there may be none in uncomplicated cases. Palpable induration of urethra, periurethral abscesses, extravasation of urine into scrotum and superficial tissue, urethroCutaneous fistulas/watering can scrotum, vasectomy, male, sterilization, 422. Bladder may be palpable if there is retention. Kidney may be palpable in hydronephrsis. Localized induration may be felt along the urethra. Failure of catheterization. This heightens the suspicion of a stricture investigations. Urinalysis, urine culture and sensitivity. Blood urea, electrolytes and creatinine. Ultrasound scan of kidneys, bladder post-void residual urine and spongiofibrosis. Retrograde uretherogram. Antegrade uretherogram/micturating cysto-uretherogram, MCUG, provided a suprapubic catheter is in place. Ureflowmetry. Urethrocytoscopy treatment objectives. To relieve symptoms and prevent complication. To treat underlying cause non-pharmacological treatment. Tricatheterization. A gentle attempt is made to pass a urethral catheter, which will be held up at the site of stricture in patients who present with retention of urine. Confirmation of site of obstruction is still needed by urethrography or urethroscopy. If catheterization fails and patient is in acute retention, suprapubic cystostomy or suprapubic needle puncture and aspiration, try this procedure. If facilities for suprapubic cystostomy are lacking, aspirate as much urine as possible to decompress the bladder and relieve pain before referral. Definitive treatment is surgical. In most cases, referral to a specialist center will be necessary. Pharmacological treatment. None except for urinary tract infection. See appropriate section. Referral criteria. Refer to specialist for further investigations prior to definitive treatment. 150. Vasectomy, male sterilization. Vasectomy is a permanent male contraceptive method, which is a simple, short and safe surgical procedure. It is carried out by trained surgeons, usually under local anesthesia after careful counseling and informed consent. Acute epididymorchitis - Chapter 14, Disorders of the Kidney and Genitourinary System. 423. Vasectomy is the most effective male family planning method. Involving males in issues of reproductive health and family planning, has several benefits with a positive impact on society. Vasectomy should be encouraged for appropriate clients. It is less invasive and simpler than female sterilization. Reversal of vasectomy is a difficult surgery using LUPS/microscope with success rate of 60–80% if done in less than 3 years after vasectomy. Box 14-1, Misconceptions. Vasectomy is ligation of the vas deferens and not castration. Vasectomy does not affect erection. Vasectomy does not affect ejaculation and orgasm. There would be normal ejaculation, but the semen does not contain spermatozoa. Vasectomy does not work immediately. A backup method of contraception is necessary for up to 20 ejaculations, 3 months after the procedure, or until examination of semen shows no sperm. After vasectomy, males will still require the use of condoms to prevent sexually transmitted infections including HIV/AIDS. Box 14-2, Effectiveness rates of various male contraceptive methods. Evidence rating, B. Vasectomy, 99.85%. Male condom, 86%. Withdrawal method, 81%. Preoperative requirements. Detailed counseling, ideally both partners must be present, and informed consent. Counseling should mention irreversibility of procedure, possible recanalization and risk of chronic scrotal pain postoperative. Medical history, physical examination, laboratory investigations, for example HB, sickling, urinalysis. Histopathology. Confirmation of the removed segment of vas deferens may be necessary for medical reasons. Referral criteria. Clients should be referred to a family planning unit or urologist for the procedure. 151. Acute epididymorchitis. This is an acute inflammation of the epididymis and testis, usually due to a bacterial infection. It may follow ascending infection from the urethra, including STIs, instrumentation/catheterization, untreated lower urinary. Acute epididymorchitis - 424. Tract obstruction and genitourinary surgery. It is a known complication of mumps. Poorly managed acute epididymorchitis may be complicated by septicemia, abscess formation, chronic epididymoorchitis, secondary hydrocephalic infertility and Fournier's gangrene. Before managing as acute epididymoorchitis, make sure testicular torsion has been conclusively excluded. Causes: mumps virus, orchitis, Escherichia coli, chlamydia, gonococcus, staphylococcus, streptococcus, pseudomonas, mycobacterium tuberculosis. Symptoms: fever, scrotal/testicular pain, scrotal swelling, urethral discharge, dysuria, malaise. Signs: fever, tender and swollen hemiscrotum, inflamed epididymis and testis, secondary hydrocephal. Positive Prenz sign: lifting of scrotum towards pubic symphysis and the palm relieves pain. Investigations: urinalysis, urine culture and sensitivity, first catch of urine preferred to midstream urine, FBC and ESR, blood culture and sensitivity, scrotal ultrasound/MRI. Treatment objectives: to relieve symptoms, to eradicate the infection, to prevent recurrence, to prevent complications, for example abscess and sterility. Non-pharmacological treatment: bed rest. Testicular torsion of spermatic cord. Chapter 14, Disorders of the Kidney and Genitourinary System. 425. Scrotal support. Surgical drainage of abscess. Avoid unprotected sex until treatment has been completed successfully, and follow-up counseling. Trace and treat sexual contacts. Pharmacological treatment. First-line treatment: ciprofloxacin, oral, adult 500 mg 12 hourly for 14 days, children 5 to 15 mg/kg 12 hourly for 14 days, and doxycycline, oral, 100 mg 12 hourly for 4 weeks in cases of sexually transmitted infections, or azithromycin, oral, adult 500 mg daily for 3 days, children 10 mg/kg daily for 3 days. Second-line treatment: norfloxacin, oral, 400 mg 12 hourly for 14 days, and doxycycline or azithromycin, as above in first-line treatment, or levofloxacin, 500 mg daily for 14 days, and doxycycline or azithromycin, as above in first-line treatment, and diclofenac sodium, oral, 50 mg 8 hourly, or ibuprofen, oral, 400 mg 8 hourly. Referral criteria for all cases of persistent fever and complications to the surgical specialist or urologist. 152. Testicular torsion of spermatic cord. This is cessation of blood supply to the testis due to twisting of the spermatic cord. This is a medical emergency that needs to be recognized before the cardinal signs and symptoms are fully manifest as prompt testicular torsion of spermatic cord. 426. Surgery saves the testes. Delay in treatment could result in testicular atrophy, abnormal sperm count leading to infertility/sterility. It can be classified into intravaginal torsion, which constitute more than 95%, and extravaginal torsion, which is usually found in infants. About 50% of torsion occurs during sleep and early in the morning. It is rare in older children and adults, but common in children under 15 years. Causes: undescended testis, bell clapper malformation, horizontal lie of testis/inversion of testis, long mesorchium, trauma, spasm of cremaster muscles. Symptoms: sudden onset of acute severe pain in one testicle or recurrent pain which resolves spontaneously, recurrent torsion and detorsion. Pain may occur typically early in the morning. Lower abdominal pain on affected side, nausea and vomiting. No urinary symptoms, no fever signs. Swollen, tender and abnormal position of testis and epididymis. Shortened and twisted cord. Oedema/reddening of scrotal wall. Right testis, twisted clockwise. Left testis, twisted anticlockwise. Prenz sign is absent. Elevation of scrotum in the palm towards the pubic symphysis. Does not relieve pain. Table 14-3, distinguishing between torsion and epididymoorchitis. Parameter: torsion, epididymoorchitis, age 15 years/sexually active, onset of pain sudden/early morning, gradual history of coitus usually absent, usually present fever, absent present urinary symptoms, absent present urethral discharge, absent present instis, position of testis changed unchanged. Fournier's gangrene. Chapter 14, Disorders of the Kidney and Genitourinary System. 427. Parameter torsion, epididymoorchitis, swelling, testis epididymis and testis present, sign absent / negative, present / positive blood supply. Doppler test reduced, normal or increased. Treatment: surgical, non-surgical investigations. Urinalysis, FBC. Doppler stethoscope, color Doppler ultrasound scan. 99 MTC per technetics interlation scan. 100% accurate. Treatment objectives: to have surgical intervention within 6 hours of onset, to surgically explore all doubtful cases, to prevent testicular loss. Non-pharmacological treatment: emergency surgery is the standard treatment. If surgery is delayed, then manual detorsion should be carried out carefully to prevent loss of testis. Manual detorsion procedure under local anesthesia, see below, and standing at the foot of bed. Untwist right testis anticlockwise, left testis clockwise. Emergency surgery should follow this procedure as soon as possible. Pharmacological treatment evidence rating: C. Lignocaine 1% into the spermatic cord on both sides. For cord block anesthesia 10 to 20 milliliters. Referral criteria: refer as soon as possible, if surgical intervention is not available, to a surgeon or urologist. Beware, testicular torsion has potential medico-legal implications. 153. Fournier's gangrene: it is an acute fulminant polymicrobial necrotizing fasciitis or gangrene affecting the scrotum and sometimes extending to the perineum, penis and lower abdomen. It is also called idiopathic gangrene of the scrotum. The synergistic infections of anaerobic and aerobic bacteria coupled with obliterative arteritis results in the extensive gangrene. The risk factors for Fournier's gangrene - 428 include diabetes mellitus, HIV/immunosuppression, perineal abscess, infection of scrotum and contents, trauma, extravasation of urine, periurethral abscess and urethral stricture/calculi. The complications of Fournier's gangrene include septicemia, extravasation of urine, exposure of testes and fistula formation. Causes: Staphylococcus spp, microphilic streptococcus, E. coli, Fusobacteria, Clostridium welchii. Bacteroid symptoms: acute onset of painful anterior scrotal swelling in previously healthy tissue, fever, pain in affected scrotum, general malaise signs, fever, prostration, rapidly progressing gangrene, foetid odor, sharp demarcation between dead tissue and healthy tissue, crepitusum palpation of affected tissue. Testis is usually spared. Urinary extravasation, presence of risk or predisposing factors. Investigations: wound culture and sensitivity, serum culture and sensitivity, urinalysis, FBC and ESR, grouping and cross-matching, fasting blood glucose, HIV screening. Plain X-ray of pelvis will reveal gas in affected tissue. Treatment objectives: to resuscitate patient, to treat the infection, to manage concomitant risk factors, to salvage the testes. Bladder cancer - Chapter 14, Disorders of the Kidney and Genitourinary System. 429 to prevent/treat complications. Non-pharmacological treatment, surgical intervention, radical debridement, reconstructive surgery, testis buried in upper thigh temporarily to prevent desiccation, skin grafting and reconstruction of scrotum, scrotoplasty, myocutaneous flaps, nutrition supplement, wound care, management of diabetes mellitus if present, management of HIV/AIDS if present. Pharmacological treatment evidence rating: CA. I fluids, hemotransfusion and hyperbaric oxygen as required for patient's clinical state. B. Antibiotics: gentamicin, IV, 80 mg 8 hourly and ampicillin, IV, 500 mg 6 hourly and metronidazole, IV, 500 mg 8 hourly or amoxicillin plus clavulanic acid, IV, 1 g 12 hourly and metronidazole, IV, 500 mg 8 hourly or cefuroxime, IV, 750 mg 8 hourly and metronidazole, IV, 500 mg 8 hourly. Referral criteria: refer all cases with septic shock after resuscitation and all those who require reconstructive surgery to a urologist or surgical specialist. 154. Bladder cancer. Bladder cancer is the second commonest urological cancer after prostate cancer. It is the commonest of all the cancers, which affect the urinary tract lining, urothelium. Males are more affected than females in a ratio of about 3:1. 1. It is more common in the white race, compared to the black race in a ratio of 4:1. More than 80% of clients with bladder cancer are above 50 years. The commonest pathological types are bladder cancer, 430, transitional cell carcinoma TCC, 90%, squamous cell carcinoma, 8%, and adenocarcinoma and carcinoma in situ, 2%. Causes: chronic infections of the bladder like schistosoma hematobium, bilharzia, and chronic bacterial infections. Smoking of cigarettes. Cancer usually develops 10 to 20 years after smoking, and 20 sticks a day/a packet carries a higher risk of cancer development. Passive smoking may also carry the risk of cancer. Occupational risks: environmental exposure to cancer-causing chemicals used in industries, for example dye, textile, rubber, cable, printing, etc. Genetic and familial factors. Symptoms may be asymptomatic in early disease, 25%. Hematuria, usually painless, painful only in advanced disease and infection/UTI. Irritative symptoms: frequency, urgency, dysuria, flank pain, hydronephrosis, pelvic pain from cancer invasion, edema of lower limbs from advanced disease signs, pallor, wasting, palpable bladder mass, palpable kidney from ureteric obstruction and hydronephrosis, lymphedema of lower limbs, secondary UTI in 30% of cases. Investigations: FBC and ESR, urine analysis and culture, urine cytology, urea, creatinine, electrolytes, ultrasound scan, abdomen or pelvic, CT scan/MRI for staging, by specialist. Special investigations, abdomen or pelvic IVU, urethrocytoscopy and biopsies, by specialist. Examination under anesthesia, by manual palpation of bladder through DRET and pelvic examinations. Treatment objectives: surgical cure for early disease, prevention of recurrence, progression and metastases, management of complications. Carcinoma of prostate. Chapter 14, Disorders of the Kidney and Genitourinary System. 431. Additional treatment with cancer drugs and radiotherapy where necessary, neoadjuvant and adjuvant therapy, non-pharmacological treatment, cystectomy, partial or radical with or without bladder replacement, radiotherapy, pharmacological treatment. Evidence rating, CA. Early stage, BCG or thiodepa bladder installation for superficial tumors after transurethral resection of bladder tumor, TURBT. B. Advanced disease. Chemotherapeutic agents recommended for advanced stage include methotrexate, vinblastine, adriamycin and cisplatin. Referral criteria: refer all cases of bladder cancer for specialist evaluation and treatment. All cases of chronic cystitis should be referred to specialist to exclude bladder cancer. 155. Carcinoma at prostate. 95% of these tumors are adenocarcinomas. The majority of men affected are aged between 65 and 85 years. The incidence increases with age. It is recommended that every male, 40 years and above, should have annual screening by prostate-specific antigen (SAP) tests and digital rectal examination (DRED), since early detection is associated with better prognosis. The benefit or otherwise of screening should be discussed with patients. Patients with a family history of prostate cancer and should consider annual screening from 40 years and above with SAT and DRED. It is worth noting that not every hard prostate on DRED is malignant. Likewise, a normal-feeling prostate does not exclude a malignancy. A prostatic biopsy is therefore necessary to establish a diagnosis. Causes: aging, functional testes, family history of prostate cancer, breast cancer, ovarian cancer. Race: more common in blacks. High dietary fat intake. Symptoms: asymptomatic prostate cancer may be present without symptoms in the early stage. Lower urinary tract symptoms, LUTS, and IBSS. Carcinoma of prostate. 432. Retention of urine. Hematuria, general debility, anorexia, weight loss, listlessness, bone pain, commonly in the waist or limbs, paralysis in the lower limbs or inability to walk, pathological fracture, impotence, hemospermia. Tenesmus signs on DRED. Clinical signs include hard prostate gland with an irregular surface and edges, obliterated median sulcus, adherent rectal mucosa, advanced or metastatic disease, anemia, uremia, wasting, bone tenderness, paraplegia, pathological fracture investigations, FBC, blood urea, electrolytes and creatinine, prostate-specific antigen, SA, liver function tests, abdominal and pelvic ultrasound, transrectal ultrasound, TRUS, of the prostate, if available, transrectal needle biopsy of the prostate, TRUS-guided or finger-guided treatment objectives, to relieve symptoms, to control complications, to achieve cure for early disease, to prevent local progression and metastases, non-pharmacological treatment, urethral catheterization to relieve urinary retention where needed, radical prostatectomy or radiotherapy, under specialist care, for early disease, surgical castration, bilateral orchidectomy, for advanced disease, pharmacological treatment evidence rating, A. Pharmacological treatment of carcinoma of the prostate, which, erectile dysfunction, Chapter 14, Disorders of the Kidney and Genitourinary System, 433, involves hormonal manipulation, which inhibits growth of the tumor, by depriving it of androgens, is best carried out under specialist care. The common drugs used in advanced prostate cancer therapy are A. Antiandrogens, bicalutamide, oral, 50 mg daily, refer to specialist, or flutamide, oral, 250 mg 8 hourly, refer to specialist, B. Oestrogen, stilbestrol, oral, 2 to 5 mg daily, avoiding clients with cardiovascular diseases, refer to specialist, C. LHRH analogs, Glycerolin, South Carolina, preferably in the abdominal wall, refer to specialist, or leuprolide acetate, IM, refer to specialist, and bisphosphonates and fentanyl patches, refer to specialist. Referral criteria: refer all cases to a specialist center for evaluation and management. 156. Erectile dysfunction. It means the persistent inability of a man to achieve an erection, which is adequate in terms of hardness and duration for satisfactory sexual intercourse, so long as a man can achieve a hard enough erection to permit vaginal penetration, with a long enough staying power, to perform the sexual act till ejaculation is attained, he is judged to be potent. The number of rounds per session is irrelevant. The condition may be classified as organic, psychogenic or mixed in terms of etiology. Primary, never been able to attain and or maintain an erection for satisfactory sexual intercourse, or secondary, where impotence occurs in men who have previously had a satisfactory sexual performance. Causes: psychogenic, anxiety, depression, stress, marital conflict. Organic, vasculogenic, arterial insufficiency/occlusion, venous incompetence. Neurogenic, peripheral neuropathy, spinal cord lesions. Traumatic, penectomy, pelvic fracture, with urethral rupture. Erectile dysfunction. 434. Perineal trauma. Endocrine, diabetes mellitus, hypogonadism, hyperprolactinemia, pituitary, adrenal and thyroid disorders. Drugs, for example antihypertensives, antidepressants. Postoperative, cystectomy, radical prostatectomy, abdominoperineal resection. Inflammation, urethritis, prostatitis. Mechanical, congenital penile abnormalities, Peyronie's disease. Endurance-related, heart/renal/liver failure, pulmonary insufficiency. Postpriapism symptoms: inability to achieve erection, inability to sustain erection, reduced sexual desire. Signs: features related to underlying causes. Hypogonadal features, for example gynecomastia, lack of male sexual characteristics. Penile plaques and curvature. Peyronie's disease. Investigations: FBC and sickling status. Lipid profile, urinalysis, fasting blood glucose, serum prolactin, serum Lernauten-Hausby, FSH and testosterone. Treatment objectives: to determine causative factors and treat appropriately. To restore sexual potency. Note 14-14. Erectile dysfunction may be the first warning sign of underlying cardiovascular disease like myocardial infarction. Non-pharmacological treatment: patients should avoid excessive alcohol consumption, cigarette smoking, recreational drug abuse and excessive weight gain. Psychosexual counseling. Pharmacological treatment. Box 14-3. Treatment should be directed at underlying cause, for example change or discontinue medication, if found to be the cause, in consultation with the patient's physician. Male infertility. Chapter 14, Disorders of the Kidney and Genitourinary System. 435. Drugs for erectile dysfunction, for example sildenafil, tadalafil or vardenafil, PDE5 inhibitors, can be prescribed as first-line treatment after careful cardiovascular evaluation. They are contraindicated in ischemic heart disease and those on nitrates. Sildenafil citrate, 50 or 100 mg 30 minutes to 1 hour before coitus, or tadalafil, 20 mg 30 to 60 minutes before coitus, or vardenafil, 10 or 20 mg 30 to 60 minutes before coitus. Note 14 to 15. These medications require sexual stimulation for optimal results. Prostaglandin E1 must only be used under specialist care. Referral criteria. Referral to a specialist center is necessary for proper evaluation and management in most cases. 157. Male infertility. Infertility is the failure of a couple to achieve conception within 12 months of adequate unprotected coitus. About 1/3 of cases of infertility result from pathologic factors in men, 1/3 from factors in both men and women, and 1/3 from factors in females. Male causes therefore account for 50% of infertility. About 15% of all married couples experience reproductive difficulties. Components of infertility history include medical, surgical, fertility, sexual, family, medication, social and occupational history. Causes. For practical purposes, the main causes can be divided into 3. Treatable causes. Potentially treatable causes. Untreatable causes. The causes can also be classified under 3 categories: pre-testicular, testicular, and post-testicular. Table 14-4. Causes of male infertility. Treatable causes, potentially treatable causes, untreatable causes. Varicocele. Idiopathic congenital abnormalities, for example absence of both testis and chromosomal abnormalities. Male infertility. 436. Treatable causes, potentially treatable causes, untreatable causes. Infections of testis, epididymis, urethra, prostate, undescended testis, bilateral testicular atrophy, ejaculatory dysfunction, gonadotoxins, drugs, radiation, erectile dysfunction, blockage of vas deferens, hyperprolactinemia, hypogonadotropic hypogonadism. Symptoms. Patients usually complain of their wives' inability to give them a child. Such patients are quite often very apprehensive, frustrated and reluctant to undergo investigations. Symptoms suggestive of history of ST, UTI, mumps, genital, pelvic or gynostomal surgery and injuries. Signs. Absence of male secondary sexual characteristics. Gynecomastia. Examine external genitalia to assess testes, presence or absence, size, and consistency. Epididymis, thickening. Vas deferens, absence, thickening. Varicoceles, in gynostomal region, scar from previous herniorrhaphy. Penis, size, curvature, hypospadias, epispadias. Urethra, discharge, meatal stenosis, stricture. Investigations. FBC and sickling. Semen analysis. Urinalysis, fasting blood glucose. Specific investigations relating to various causes, for example scrotal ultrasound. Specialized investigations, for example hormonal profile done by specialists. Evaluation of female partner by gynecologist. Treatment objectives. To improve fertility potential. To achieve pregnancy with partner. Hematuria. Chapter 14, Disorders of the Kidney and Genitourinary System. 437. Non-pharmacological treatment. Sexual counseling. Smoking cessation. Reduction in alcohol intake. Avoid local, scrotal, exposure to excessive heat, cold and chemicals. Avoid tight underwear. Use of boxer shorts and cotton briefs, not silk/nylon, is recommended. This reduces heat around the testes to promote spermatogenesis. Pharmacological treatment. This is best provided under specialist care. Referral criteria are for all cases that require special investigation, pharmacological or surgical treatment to specialists. 158. Hematuria. This is the passage of blood in the urine. It may be microscopic or macroscopic, intermittent, or continuous. The pattern of blood in the urine may be initial, terminal or frank/total. Blood in urine is a serious symptom and must always be fully investigated, especially to exclude cancer. Certain drugs and food products may color urine red, resulting in false hematuria, and these should be differentiated from true hematuria, which is detected by microscopic examination of the urine. Examples of such substances are rifampicin and rhodamine B. Food coloring used in cakes, cookies and soft drinks. Occasionally vaginal bleeding may be mistaken for hematuria. Definitive treatment depends on the cause. Causes glomerular. Glomerulonephritis usually presents with dysmorphic red blood cells in the urine or red blood cell casts with proteinuria. Non-glomerular. Urethra, trauma, infection. Bladder, infection, stone, bladder cancer, varices, BPH, prostate cancer. Drug reaction, cyclophosphamide, radiation. Cystitis, parasite infestation, S. hematobium. Ureter, infection, stone, tumor. Kidney, infection, pyelonephritis, stone. Anatomic anomalies, polycystic kidney disease, avifistula, renal vein or artery thrombosis. Neoplasms, renal cell carcinoma, Wilms tumor. Trauma, sickle cell disease, benign prostatic hyperplasia, BPH. Hematuria, 438. Carcinoma at prostate, bladder and kidney. Urinary tract infection. Urinary calculi. Medical causes, for example sickle cell disease, acute glomerulonephritis and anticoagulant therapy. Symptoms. Fever suggests infection, for example pyelonephritis, cystitis, and prostatitis. Colicky flank pain suggests urinary stones. Associated lower urinary tract symptoms suggest bladder or prostatic cause. Blood in the urine, on initiation, mixed with the urine, or at the end of passing urine. Pain/discomfort on passing urine usually associated with infection, calculi or trauma. Painless intermittent hematuria associated with cancers, egg bladder and kidney cancers. Lower urinary tract symptoms, LUTS. Loin pain signs. Pallor. Abdominal masses, for example kidney, bladder. Low or suprapubic tenderness from urinary tract infection or calculus. Investigations. FBC and sickling status. HB electrophoresis if sickling test is positive. Blood urea, electrolyte and creatinine. Urinalysis, urine culture and sensitivity. Abdominal and pelvic ultrasound treatment. Treatment objectives: to treat underlying cause, to arrest bleeding. Non-pharmacological treatment. High fluid intake is advised, in order to prevent clot formation in the urinary bladder. If patient presents with clot retention, then catheterize and refer. Pharmacological treatment. A. For urinary schistosomiasis. Evidence rating: A. Prasequantal, oral, C-section. On urinary schistosomiasis. Urinary schistosomiasis Chapter 14, Disorders of the Kidney and Genitourinary System. 439. B. For urinary tract infection. Give appropriate antibiotics. C-section on urinary tract infection. Referral criteria: refer all other cases as well as those with persistent hematuria for appropriate investigations and treatment. 159. Urinary schistosomiasis. This is a waterborne disease caused by penetration of the skin or mucous membranes by the early stages of the causative organism, Schistosoma hematobium, which in the adult form, settles in the blood vessels of the urinary bladder, resulting in the common presentation of hematuria. This disease is common in Ghana with several endemic areas along the lakes, slow-flowing rivers and irrigation systems. The commonest body sites affected are the bladder, ureters and pelvic organs. Prevention entails avoiding contact with infested water. Chronic infestation may lead to severe anemia, ureteric stricture and hydronephrosis, as well as carcinoma of the bladder. Cause: schistosoma hematobium. Symptoms: initial itching and redness of skin at site of penetration of parasite. Fatigue, low-grade fever, malaise, lassitude, excessive sweating, headache and backache. Later. Terminal hematuria. Painful urination, dysuria. Lower abdominal pain, bladder pain. Signs: pallor, palpable kidney from hydronephrosis due to ureteric stricture, palpable bladder from bladder cancer or retention of urine due to clots or bladder neck stenosis. Drama reveal a fibrosed prostate, enlarged seminal vesicle or thickened bladder base. Investigations: FBC, urine for red blood cells, pus cells, and schistosoma over. Midday urine specimen preferably taken after physical exercise is ideal. Midstream urine for culture, in associated urinary tract infections. Imaging, ultrasound scan, intravenous urogram, IVU, may show persistent or recurrent urethral discharge. 440. Calcification of bladder, ureters, hydronephrosis, and hydroureters treatment objectives to eliminate the causative organism, to manage the complications, non-pharmacological treatment, avoid repeated exposure to infested water bodies, if possible pharmacological treatment evidence rating, A. Praziquantel, oral, adults and children 40 mg/kg as a single dose, treat anemia if present, see section on anemia, referral criteria, refer patient after adequate treatment if hematuria and/or symptoms of urinary infection persist, or if complications like hydronephrosis, bladder mass, retention of urine, severe wasting and severe anemia are present. 160 persistent or recurrent urethral discharge, see section on steroidated persistent or recurrent urethral discharge. 161 retention of urine. Retention of urine is inability to empty a full bladder. It is the commonest urological emergency in Ghana and worldwide. Adult males are more commonly affected. It is rare in children and in females. The causes differ in different age groups as well as in males and females. A family history of retention of urine in benign prostatic hyperplasia, BPH, prostate cancer, breast cancer and ovarian cancer are risk factors. Retention of urine can be classified into 3. 1. Acute retention of urine is of sudden onset with a palpable tender bladder. 2. Chronic retention of urine is of insidious onset and presence with a palpable non-tender bladder and overflowing continence resulting in more damage to the bladder, ureters and kidneys. Post-renal renal failure may complicate this type of retention with hydronephrosis and hydroureters. 3. Acute on chronic retention of urine is when a chronic retention of urine is suddenly complicated by acute retention of urine. Retention of urine. Chapter 14, Disorders of the Kidney and Genitourinary System. 441. Causes. Adult males, above 50 years, BPH, urethral strictures, bladder neck stenosis. Adult males, below 50 years/young males, urethral strictures, urethral injuries, bladder neck stenosis, neurogenic bladder/spinal injury, paraphimosis, urethral calculi, acute prostatitis. Male children, posterior urethral valves, medial stenosis, phimosis, urethral calculi, congenital strictures. Adult females, retroverted gravid uterus, uterine fibroid/myomas, impacted ovarian cysts, neurogenic, postoperative, and pelvic inflammatory disease, carcinoma of cervix with infiltration into the urethra. Symptoms. Retention of urine in BPH precipitated by postponement of micturition, alcohol abuse and infection. Sudden inability to pass urine with painful bulge in lower abdomen for acute retention of urine. Gradual onset of inability to pass urine with painless bulge in lower abdomen for chronic retention of urine. History of urethritis, urethral instrumentation, for example catheterization, or perineal injury, pelvic fracture or surgery in urethral strictures. International Prostate Symptom Score, IPSS, signs. Palpable tender bladder in acute retention of urine. Palpable non-tender bladder for chronic retention of urine. Uremia/azotemia and renal failure. Fever and infections, UTI and prostatitis. Palpable kidneys and hydronephrosis. Hematuria and BPH. Prostate cancer and urethral strictures. Referral criteria. Patients with hydronephrosis on ultrasound scan and renal failure should be referred to specialist. 16. Chapter 442. Sexually transmitted infections. 162. Sexually transmitted infections in adults. Sexually transmitted infections, STIs, result in several clinical syndromes caused by organisms that can be acquired and transmitted through sexual activity. They cause acute morbidity in adults, and may result in long-term complications such as urethral stricture, infertility, ectopic pregnancy, anal fistula, cervical cancer, fetal wastage, prematurity, low birth weight, ophthalmia neonatorum and congenital syphilis. Their control is the cornerstone in improving reproductive health and reducing human immunodeficiency virus, HIV, infections. Comprehensive management of STI is important, and comprises prompt and effective case detection and treatment. However, owing to the lack of laboratory equipment and manpower in primary care facilities where most patients first present, an accurate diagnosis is often not possible. Also, with most STIs, one cannot usually tell which organism is causing the infection from the history and physical examination alone. Multiple infections also occur, with each needing to be treated. Failure to treat one infection adequately may result in the development of serious complications. It is therefore more practical, in managing STIs, to base treatment on a syndromic diagnosis, which identifies all STIs that could cause a particular symptom or sign, and provide treatment for each of them simultaneously. The common clinical syndromes associated with STIs include urethral discharge in males, persistent/recurrent urethral discharge, vaginal discharge, lower abdominal pain, genital ulcer, scrotal swellings, inguinal lymphadenopathy, buboes, anorectal syndromes, anorectal discharge, ulcers, and vesicles, and genital warts. Scabies and pediculosis pubis may also be transmitted by sexual contact. In dealing with patients with STI, privacy and confidentiality, especially with the history taking an examination, are paramount. Education and counseling of STI patients and concurrent management of their partners provide additional opportunities to reduce the risk of STI in the community. STI-related urethral discharge in males. Chapter 16, Sexually Transmitted Infections. 443. See section on sexually transmitted diseases in children for STIs in children. 163. STI-related urethral discharge in males. Cat uses Neisseria gonorrhea, gonococcal urethritis, chlamydia trachomatis, non-gonococcal urethritis. 164. Mycoplasma genitalium. Symptoms: urethral discharge, dysuria or discomfort on urination signs. Urethral discharge. Note 16:1. Gentle milking of the urethra may reveal the discharge, if it is not initially visible. In uncircumcised males, check that the discharge is coming from the urethral opening, and not from the glans penis. Investigations: urethral swab culture and sensitivity, if available. PrivateCare treatment objective is to treat gonorrhea and chlamydia urethritis simultaneously to prevent further transmission to sexual partners. To treat both partners simultaneously as much as possible to prevent development of complications and sequelae to reduce risk of HIV infection. Non-pharmacological treatment. Non-pharmacological treatment evidence rating, CA. For gonorrhea, ceftriaxone, 250 mg stat or cefixime, oral, 400 mg stat or ciprofloxacin, oral, 500 mg stat and STI-related persistent or recurrent urethral discharge. 444. B for chlamydia and mycoplasma. Doxycycline, oral, 100 mg 12 hourly for 7 days or tetracycline, oral, 500 mg 6 hourly for 7 days or erythromycin, oral, 500 mg 6 hourly for 7 days or azithromycin, oral, 1 g-stat. 165. STI-related persistent or recurrent urethral discharge. This may occur due to drug resistance, poor treatment compliance or reinfection following treatment for STI. In some cases, persistence of urethral discharge may be due to infection with Trichomonas vaginalis. Cat uses Neisseria gonorrhoeae, chlamydia trachomatis or mycoplasma genitalium following drug resistance, poor compliance or reinfection after treatment. Trichomonas vaginalis treatment objective is to retreat for gonococcal or non-gonococcal urethritis, if suspected to be due to previous poor treatment compliance or reinfection. To treat infection with Trichomonas vaginalis. To prevent transmission to sexual partners. To treat both partners simultaneously as much as possible. To prevent development of complications and sequelae. To reduce risk of HIV infection. Non-pharmacological treatment. Non-pharmacological treatment evidence rating, CA. For gonorrhea, chlamydia, mycoplasma. Repeat treatment for urethral discharge. B for Trichomonas vaginalis. Metronidazole, oral, 400 mg 12 hourly for 7 days or metronidazole, oral, 2 g-stat, or tianidazole, oral, 2 g-stat, or signitazole, oral, 2 g-stat. STI-related vaginal discharge. Chapter 16, Sexually Transmitted Infections. 445. Referral criteria for all cases of treatment failure to a health facility, where microbiological culture and antimicrobial sensitivity tests can be done on the urethral discharge. 166. STI-related vaginal discharge. While a vaginal discharge is a notable clinical feature of InST, not all forms of vaginal discharge are abnormal or indicative of InST. A vaginal discharge may be associated with a physiological state such as menses or pregnancy, or with the presence or use of foreign substances and chemicals in the vagina. A careful risk assessment, see note below, of women with a vaginal discharge, may help identify STIs and non-STIs and selection of appropriate treatment regimens, based on the most likely etiology of the vaginal discharge. Other considerations for selecting treatment include pregnancy status and patient discomfort. Causes: Neisseria gonorrhea, chlamydia, trichomonas, trichomonas vaginalis, green or yellow, smelly, bubbly or frothy discharge associated with itching. Herpes simplex virus, following first episode of infection. Symptoms: vaginal discharge, change in color, odor, consistency, or amount. Vulval swelling, pain on urination. Lower abdominal or back pain signs. Vaginal discharge, vulval swelling, vulval erythema, lower abdominal tenderness, cervical excitation, tenderness, cervical mucus or erosions on speculum examination. Investigations: high vaginal swab for microscopy, culture, and sensitivity, if available. Treatment objective: to identify and treat non-ST vaginitis, especially candidiasis, which is frequently diagnosed in women being evaluated for STIs. To assess STI risk and treat STI-related infections appropriately to prevent complications and sequelae. STI-related vaginal discharge 446. To treat both partners simultaneously as much as possible. Non-pharmacological treatment. None for STI-related discharge. Pharmacological treatment evidence rating. See Note 16.2. Risk assessment parameters used in the risk assessment for cervicitis are: I. Patient's partner is symptomatic, that is, partner has urethral discharge. II. Patient is less than 21 years old. III. Patient is single. IV. Patient has more than one sexual partner. V. Patient has had a new sexual partner in the last 3 months. The risk assessment is said to be positive and treatment for cervicitis is recommended if the answer to I is yes, or the answer to any two if items IV is yes. If a woman has a vaginal discharge with no positive risk factor, treat for vaginitis alone. If she has a vaginal discharge and a positive risk factor, treat for both vaginitis and cervicitis. A. Treatment for trichomoniasis and bacterial vaginosis. Metronidazole, oral, 2G stat. Contraindicated during the first trimester of pregnancy, or metronidazole, oral, 400 mg 8 hourly for 5 days, contraindicated during the first trimester of pregnancy, or signitatazole, oral, 2G stat. Contraindicated during the first trimester of pregnancy, or tinidazole, oral, 2G stat. Contraindicated during the first trimester of pregnancy, or clindamycin cream, 2%, topical, preferred in pregnancy, and B. Treatment for candidiasis. Meconiazole vaginal tablets, 200 mg inserted into vagina at night for 3 days. Or clotrimazole, vaginal tablets, 200 mg inserted into vagina at night for 3 days. And clotrimazole cream, apply 12 hourly. For vulval irritation, see treatment for gonorrhea. Ceftriaxone, IMP, 250 mg stat. STI-related lower abdominal pain in women. Chapter 16, Sexually Transmitted Infections. 447. Or cefixime, oral, 400 mg stat. Or ciprofloxacin, oral, 500 mg stat. Avoid in pregnant and lactating mothers, and D. Treatment for chlamydia. Doxycycline, oral, 100 mg 12 hourly for 7 days. Avoid in pregnant and lactating mothers. Or tetracycline, oral, 500 mg 6 hourly for 7 days. Avoid in pregnant and lactating mothers. Or erythromycin, oral, 500 mg 6 hourly for 7 days. Or azithromycin, oral, 2G stat. Referral criteria are for all cases of recurrent vaginal discharge and/or treatment failures to a health facility, where speculum examination can be carried out, and microbiological culture and antimicrobial sensitivity tests can be done on the vaginal discharge. 167. STI-related lower abdominal pain in women. Cat uses Neisseria gonorrhea, chlamydia trachomatis, anaerobic bacteria, often relating to recurrent infections, Symptoms: lower abdominal pain, pain with sexual intercourse, dyspareunia, vaginal discharge, dysuria or urethral discomfort, fever. Signs: lower abdominal tenderness, vaginal discharge, tenderness on moving the cervix, cervical excitation, on the manual vaginal examination, adnexal tenderness, adnexal masses instigations, high vaginal swab culture and sensitivity, sterile genital ulcer. 448. Pelvic ultrasound treatment. Treatment objective ES. To treat for gonorrhea, chlamydia and anaerobic bacterial infection. To relieve pain and inflammation. Non-pharmacological treatment. Remove IUD, if present, 3 days after initiation of drug therapy. Pharmacological treatment evidence rating, CA. OUT patients. Cefixime, oral, 400 mg stat or ciprofloxacin, oral, 500 mg 12 hourly for 3 days and doxycycline, oral, 100 mg 12 hourly for 14 days and metronidazole, oral, 400 mg 12 hourly for 14 days. B in patients. Ceftriaxone, 250 mg daily for 3 days and doxycycline, oral, 100 mg 12 hourly for 17 days and metronidazole, oral, 400 mg 12 hourly for 17 days. 168. Sterile genital ulcer. Cat uses herpes simplex, treponema pallidum, syphilis, Haemophilus ducreyi, chancroid, Calamidobacterium granulomatis, granuloma inguinale. Symptoms: genital ulcer, painful or painless, urethral discharge, inguinal swelling, lymphadenopathy. Signs: inguinal lymphadenopathy, herpes simplex, multiple, recurrent vesicular lesions, herpes simplex, syphilitic ulcers, often single, painless and indurated lesions with a clear base and well-defined edges, sterile genital ulcer. Chapter 16, Sexually Transmitted Infections. 449. Occasionally multiple, painful, non-indurated or have a purulent base. Discrete, firm, painless, inguinal lymphadenopathy a week after the primary lesion. Primary ulcer usually heals within 6 weeks, usually without leaving a scar. Chancroid, painful with undermined ragged edges. The base is covered with a purulent exudate, and easily bleeds to touch. Several ulcers may coalesce to form serpiginous lesions. Lymphadenopathy is usually unilateral, and may become fluctuant. Granuloma inguinale begins with a small papule that progresses into an enlarging granulomatous ulcer with trauma. Edges are well defined. Healing is not spontaneous, and is accompanied by extensive scarring instigations. VDRL, if available. TPHA, if available. Treatment objective ES. To treat small ulcers and vesicles, especially if recurrent for herpes simplex. To direct initial management of all ulcers at herpes simplex, syphilis and chancroid concurrently. Non-pharmacological treatment. Keep lesions dry and clean. Pharmacological treatment evidence rating, CA. For herpes simplex, acyclovir, oral, 200 mg 4 to 6 hourly for 7 to 10 days, 5 doses daily, or acyclovir, oral, 400 mg 8 hourly for 7 to 10 days for individuals with herpes and HIV co-infection. Acyclovir, oral, 400 mg 8 hourly for 7 to 10 days or acyclovir, oral, 800 mg 12 hourly for 7 to 10 days. Episodic therapy for recurrent episodes. Acyclovir, oral, 400 mg 8 hourly for 5 days or acyclovir, oral, 800 mg 12 hourly for 5 days or sterile scrotal swelling. 450. Acyclovir, oral, 800 mg 8 hourly for 2 days. Suppressive therapy in HIV-infected individuals. Acyclovir, oral, 400 to 800 mg 8 to 12 hourly for 2 to 6 years. B for syphilis. Benzathine penicillin G, 1.2 μ in each buttock, total dose 2.4 μ, stat, or procaine penicillin aqueous, by deep injection, 1.2 μ daily for 10 days for persons allergic to penicillin. Doxycycline, oral, 100 mg 12 hourly for 14 days or tetracycline, oral, 500 mg 6 hourly for 14 days for pregnant women allergic to penicillin. Erythromycin, oral, 500 mg 6 hourly for 14 days or azithromycin, oral, 500 mg daily for 10 days. C for chancroid. Ceftriaxone, 250 mg stat, or azithromycin, oral, 1 g stat, or ciprofloxacin, oral, 500 mg 12 hourly for 3 days or erythromycin, oral, 500 mg 6 hourly for 7 days. 169 Steroidated scrotal swelling. Cat uses chlamydia trachomatis, Neisseria gonorrhea, treponema pallidum, very rarely. Symptoms: scrotal swelling, scrotal pain, urethral discharge, dysuria, frequency of micturition, fever signs, scrotal swelling, oedema and/or erythema, scrotal tenderness, urethral discharge, steroidated, inguinal, bubo, dash. Chapter 16, Sexually Transmitted Infections. 451. Fever investigations. Urethral swab for culture, urine culture and sensitivity. Ultrasound scan of the scrotum. Treatment. Treatment objective ES. To provide pain relief. To identify and treat ST and non-steroidated causes appropriately. To treat for gonorrhea and chlamydia simultaneously. Non-pharmacological treatment. Bed rest. Scrotal support until inflammation and fever subside. Pharmacological treatment evidence rating CA. For gonorrhea, ceftriaxone, IMP 250 mg stat, or cefixime, oral, 400 mg stat, or ciprofloxacin, oral, 500 mg stat, and B for chlamydia. Doxycycline, oral, 100 mg 12 hourly for 7 days, or tetracycline, oral, 500 mg 6 hourly for 7 days, or azithromycin, oral, 1 g stat, or erythromycin, oral, 500 mg 6 hourly for 7 days. 170 Steroidated inguinal bubo. Cat uses chlamydia trachomatis, lymphogranuloma venereum, Haemophilus ducreyi, chancroid. Symptoms: painful or painless inguinal swelling or swelling signs. Inguinal swellings, unilateral or bilateral, tender or non-tender, steroidated, genital warts. 452. Fluctuant, suppurating, genital ulcer investigations. No investigations required, in view of the syndromic approach. Recommended in managing STIs. Treatment objective ES. To relieve pain, to relieve the swelling, to treat the infection of lymphogranuloma venereum and chancroid concurrently. Non-pharmacological treatment. Aspiration of fluctuant bubos using a wide-bore needle through adjacent healthy skin every second or third day. An incision and drainage should not be attempted. If bubos persist, the patient should be referred. Sequelae such as strictures and/or fistula may require surgery. Pharmacological treatment for lymphogranuloma venereum, LGV, and chancroid evidence rating C. Doxycycline, oral, 100 mg 12 hourly for 21 days, or azithromycin, oral, 1 g stat, or erythromycin, oral, 500 mg 6 hourly for 14 days. 171 Steroidated genital warts. Cat uses human papillomavirus. Symptoms: usually no symptoms. Small painless swellings in the anogenital region. Itching or discomfort in the genital area may cause increased vaginal discharge. Anal or vaginal bleeding during or after sex. Signs: small, flat, papular pedunculated flesh-colored swellings on the skin and mucous membranes of the genitals, penis, vulva, vagina, cervix, urethra, perineal region. Steroidated, anorectal related syndromes. Chapter 16, Sexually Transmitted Infections. 453. Investigations. Acetic acid solution, vinegar, test. Treatment objective ES. To eliminate the warts. Non-pharmacological treatment. Protect normal skin with Vaseline, paraffin, while applying podophyllin. External genital and perineal warts should be washed thoroughly 1-4 hours after application of podophyllin and 6 to 10 hours after application of imiquimod. Cryotherapy with liquid nitrogen, solid carbon dioxide, or a cryoprobe. Repeat applications every 1 to 2 weeks. Electrosurgery. Surgical removal. Pharmacological treatment evidence rating C. Podophyllin 10-25% tincture of benzoin, topical, applied directly to the warts avoiding normal skin tissue. Protect normal skin with Vaseline, paraffin. Repeat treatment at weekly intervals until complete resolution. Or trichloroacetic acid, TCA, 80-90%, topical, apply carefully to the warts avoiding normal tissue. followed by powdering of the treated area with talcum powder to remove unreacted acid. Repeat treatment at weekly intervals until complete resolution. Or podophylodoxin, 0.5%, topical, apply 12 hourly 3 times a week for 4 weeks. Or imigwomen, 5% cream, topical, apply 3 times a week for 16 weeks. Should be washed 6 to 10 hours after application. Note 16-3 Do not use TCA during pregnancy and lactation. Do not use podophyllin or TCA on cervical warts. 172 Steroid anorectal related syndromes. Causes: cedra traumatis, herpes simplex virus 2, HSV2, and gonorrhea. Steroid anorectal related syndromes. 454 Treponema pallidum symptoms: anal discharge, rectal bleeding, pruritus, rectal pain, tenesmus, constipation signs, anal ulcers or blisters, anal growth, tenderness on rectal examination, anal discharge or bleeding. Treatment objectives: to relieve pain, to treat for the major causes simultaneously. Non-pharmacological treatment: keep lesions dry and clean. Pharmacological treatment: A. For anorectal discharge, treat for gonorrhea and chlamydia, see sections above. B. For anorectal ulcers or vesicles. For first episode of vesicular lesions, treat for herpes simplex virus. Acyclovir, 200 mg, 4 to 6 hourly for 7 days, 5 doses per day. Or acyclovir, 400 mg, 8 hourly for 7 days. Episodic treatment for recurrent HSV vesicular lesions, to be started on first day of appearance of lesions. Acyclovir, 400 mg, 8 hourly for 5 days. Or acyclovir, 800 mg, 12 hourly for 5 days. Or acyclovir, 800 mg, 8 hourly for 2 days. And C. For syphilis: benzathine penicillin G, m, 1.2 mu in each buttock, total dose 2.4 mu, stat. Or procaine penicillin aqueous, m, by deep injection, 1.2 mu daily for 10 days. Or sexually transmitted infections in children. Chapter 16, Sexually Transmitted Infections. 455 D. For persons allergic to penicillins: doxycycline, oral, 100 mg 12 hourly for 14 days. Or tetracycline, oral, 500 mg 6 hourly for 14 days. Or erythromycin, oral, 500 mg 6 hourly for 14 days. And E. For chlamydia: doxycycline, oral, 100 mg 12 hourly for 7 days. Or tetracycline, oral, 500 mg 6 hourly for 7 days. Or erythromycin, oral, 500 mg 6 hourly for 7 days. And F. For chancroid: ceftriaxone, 250 mg stat. Or azithromycin, oral, 1 g stat. Or ciprofloxacin, oral, 500 mg 12 hourly for 3 days. Or erythromycin, oral, 500 mg 6 hourly for 7 days. Referral criteria: if the symptoms or lesions do not improve after treatment, refer to a health facility with microbiology support for appropriate treatment and exclusion of other causes to exclude other causes. 173 Sexually transmitted infections in children. Neonates, prepubertal and pubertal children are also at risk of contracting STIs. The modes of transmission in these children are mostly through maternal infections, sexual abuse or exploitation, and voluntary sexual activity in older children. The STLs in this age group include neonatal conjunctivitis, ophthalmia neonatorum, and other STI-related syndromes similar to that in adults. Some of these STLs, for example, gonorrhea, syphilis, and chlamydia, if acquired after the neonatal period, are indicative of sexual contact. For other STLs, for example HPV infections and vaginitis, the association with sexual contact is not clear. 174 STI-related neonatal conjunctivitis, ophthalmia neonatorum, see section on neonatal conjunctivitis under neonatal disorders. STI-related urethral discharge syndrome in children. 456 Management of specific STI and STI syndromes in children. 175 STI-related urethral discharge syndrome in children. A. For gonorrhea children 45 kilograms ceftriaxone, 125 mg stat. Children, 12 years, or child, 45 kilograms cefixime, oral, 400 mg stat or ceftriaxone, 250 mg stat, and B for chlamydia children 12 years. Erythromycin, oral, 12.5 mg/kg 6 hourly for 14 days children, 12 years. Azithromycin, oral, 1 g stat, or doxycycline, oral, 100 mg 12 hourly for 7 days or erythromycin, oral, 500 mg 6 hourly for 7 days. 176 Sterilized vaginal discharge syndromes in children. Note 16-4 examination should be carried out without a speculum. Intravaginal treatment is not recommended for younger girls. Oral treatment may be more appropriate. Non-pharmacological treatment. Ensure good genital hygiene. Encourage use of loose underwear. Dry underwear in the sun or iron with hot plate. Ensure good perianal hygiene. Avoid douching with herbal or chemical preparations. Avoid medicated soaps. Pharmacological treatment A for vaginitis, trichomoniasis, and B acetyl vaginosis, children 45 kilograms. Metronidazole, oral, 7.5 mg/kg 12 hourly for 7 days children, 12 years, or 45 kilograms. Metronidazole, oral, 400 mg 12 hourly for 7 days. Sterilized lower abdominal pain or pelvic inflammatory disease syndrome in children. Chapter 16, Sexually Transmitted Infections. 457, or metronidazole, oral, 2g stat, and B for candidiasis. Clotrimazole 2% cream, topical, vaginal, apply 8 to 12 hourly for 7 days or fluconazole, oral, 3 to 6 mg/kg stat. Note 16-5 intravaginal treatment is not recommended for younger girls. Oral treatment may be more appropriate. And C for cervicitis for gonorrhea children 45 kilograms. Ceftriaxone, 125 mg stat. Children, 12 years, or 45 kilograms. Cefixime, oral, 400 mg stat, or ceftriaxone, 250 mg stat. And for chlamydia children 12 years. Erythromycin, oral, 12.5 mg/kg 6 hourly for 14 days children, 12 years. Azithromycin, oral, 1 g stat, or doxycycline, oral, 100 mg 12 hourly for 7 days or erythromycin, oral, 500 mg 6 hourly for 7 days. 177 Sterilized lower abdominal pain or pelvic inflammatory disease syndrome in children 45 kilograms. Ceftriaxone, 125 mg stat, and erythromycin, oral, 12.5 mg/kg 6 hourly for 14 days and metronidazole, oral, 7.5 mg/kg 12 hourly for 14 days children, 12 years. Ceftriaxone, 250 mg stat, and sterilized genital ulcer syndrome in children. 458 Doxycycline, oral, 100 mg 12 hourly for 14 days and metronidazole, oral, 400 mg 12 hourly for 14 days. 178 Sterilized genital ulcer syndrome in children. A for syphilis. Benzopenicillin, I, children, 12 years. 50,000 units/kg 4 to 6 hourly for 10 days 12 years. 50,000 units/kg 4 to 6 hourly for 10 days or procaine-penicillin, deep, children, 12 years. 1.2 mu daily for 10 days 12 years. 50,000 IU/kg daily for 10 days, maximum daily dose 750,000 units, or benzathine-penicillin, 12 years. 1.2 mu into each buttock during one clinic visit, total 2.4 mu, for persons allergic to penicillin. Doxycycline, oral, 100 mg 12 hourly for 14 days or tetracycline, oral, 500 mg 6 hourly for 14 days and B for chancroid children, 12 years. Cefixime, oral, 400 mg stat, or azithromycin, oral, 1 g stat, or doxycycline, oral, 100 mg 12 hourly for 7 days or erythromycin, oral, 500 mg 6 hourly for 7 days children 45 kilograms. Ceftriaxone, 250 mg stat, or erythromycin, oral, 12.5 mg/kg 6 hourly for 7 days and C for genital herpes simplex. Acyclovir, oral, children. Sterilized anorectal related syndromes in children. Chapter 16, Sexually Transmitted Infections. 459, 2 years. 200 mg 4 to 6 hourly for 5 days 1 month 2 years. 100 mg 4 to 6 hourly for 5 days for infants with known or suspected neonatal herpes. Acyclovir, IV, children 1 month 20 mg/kg every 8 hours for 14 days, for disease limited to the skin and mucous membranes, or 20 mg/kg every 8 hours for 21 days, for disseminated and CNS disease. 179 Steroidated anorectal-related syndromes in children. Anorectal discharge A. For gonorrhea children, 12 years, or 45 kilograms. Cefixime, oral, 400 mg stat, or ceftriaxone, IM, 250 mg stat. Children 45 kilograms. Ceftriaxone, IM, 125 mg stat. And B for chlamydia children, 12 years. Azithromycin, oral, 1 g stat, or doxycycline, oral, 100 mg 12 hourly for 7 days, or erythromycin, oral, 500 mg 6 hourly for 7-day children 12 years. Erythromycin, oral, 12.5 mg/kg 6 hourly for 14 days. Anorectal ulcers/vesicles A. For syphilis, see sections above under. Genital ulcer syndrome in children for treatment of syphilis. B for chancroid, see sections above under. Genital ulcer syndrome in children for treatment of chancroid. C for genital herpes, see sections above under. Genital ulcer syndrome in children. For steroidated anorectal related syndromes in children. 460 Treatment with genital herpes, genital warts in children, see section on treatment of genital warts in adults. Podophylotoxin and imiquimod are not used in children. Scabies, see section on pruritus, pubic lice. Malathion liquid 0.5% and aqueous base apply over whole body, and allow to dry naturally. Wash off after 12 hours or overnight. Repeat after 1 week. Referral criteria: if the symptoms or lesions do not improve after treatment, refer to a health facility with microbiology support for appropriate treatment and exclusion of other causes to exclude other causes. 17. Chapter 461. HIV infections and AIDS. 180 HIV infection and AIDS. Acquired immune deficiency syndrome. AIDS is a late stage of infection with the human immune deficiency virus, HIV. It can affect both adults and children, often predisposing them to opportunistic infections and certain malignancies. Co-infection with tuberculosis, TB, and hepatitis B are particularly frequent in HIV-infected individuals, and must be screened for in all cases. The main risk factors for HIV/AIDS remain transmission by exchange of body fluids and blood products through sexual contact, transfusion, needle stick injury, non-sterile surgical practices, and mother-to-child transfer. HIV infection is currently not curable. However, for persons living with HIV infection, PLHIV, effective antiretroviral therapy, ART, is available countrywide at accredited centers at the regional and district level in both public and private healthcare facilities, to which all diagnosed patients must be referred. Prevention of infection remains the key to reducing its spread. Causes: human immunodeficiency virus. Symptoms: persistent cough, persistent or recurrent diarrhea, weight loss, skin rashes, persistent or recurrent fever, mouth ulcers. Signs: weight loss, chronic diarrhea, prolonged fever, generalized lymphadenopathy. HIV infection and AIDS. 462 Oropharyngeal candidiasis, persistent cough, generalized dermatitis, recurrent herpes zoster, adults. Chronic progressive and disseminated herpes simplex infections, adults. Fingernail changes, for example blue discoloration of the nails, adults. Failure to thrive or slow growth, infants and children. Recurrent common infections, for example otitis media, pharyngitis, infants and children. Investigations: confirmatory HIV test, HIV-1, HIV-2, HIV-1 and 2, HIV viral load, CD4 count. Other tests as required, see Table 17-1 on page D, see Table 17-1 on page D, see Table 17-1 on page 462, Table 17-1. Other baseline tests for HIV: hematological test, full blood count, biochemical test, blood urea electrolytes and creatinine, liver function tests, fasting blood sugar, cholesterol and lipid profile, routine examinations, urinalysis, urine R/E, stool R/E, respiratory examinations, TB screening, chest x-ray, serological tests, hepatitis B, surface antigen, supplementary tests. These tests are performed depending on signs and symptoms. Histology on skin and lymph node biopsy, kidney biopsy, screening for STIs, pregnancy test, pap smear, HPV DNA treatment objectives: to suppress HIV replication to as low as possible and for as long as possible, to preserve and enhance the immune function, CD4 restoration, to improve quality of life, to reduce morbidity and mortality related to HIV, to promote growth and neurological development in children. HIV infection and AIDS. Chapter 17, HIV infections and AIDS. 463. Pharmacological treatment. A. Standard treatment. First line treatment. Table 17-2. Standard treatment. First line treatment for HIV/AIDS medicines. Caution comment. Preferred regimen: tenofovir, TDF, plus lamivudine, 3TC, or emtricitabine, plus efavirenz, EFV. Caution with tenofovir and renal dysfunction. Monitor renal function including urinalysis. Alternative regimen: tenofovir plus lamivudine, or emtricitabine, FTC, plus nevirapine, NVP. Caution with tenofovir and renal dysfunction. Nevirapine is contraindicated in liver dysfunction and NVP hypersensitivity. Monitor renal function including urinalysis. Stop NVP if client develops jaundice or severe rashes, and refer to ART Center for further management. Zidovudine, ACT, plus lamivudine, 3TC, plus nevirapine, NVP. Zidovudine is contraindicated in severe anemia. Nevirapine is contraindicated in liver dysfunction and NVP hypersensitivity. TDF to be used where HB is 25% from the baseline value in a client on AZT. Stop NVP if client develops jaundice or severe rashes, and refer to ART Center for further management. Zidovudine, ACT, plus lamivudine, 3TC, plus efavirenz, EFV. Zidovudine is contraindicated in severe anemia. TDF to be used where HB is 25% from the baseline value in the client on AZT. Second line treatment. Table 17-3. Standard treatment. Second line treatment for HIV/AIDS medicines. Comments. First alternative: zidovudine plus lamivudine, or emtricitabine, plus lopinavir/R, or atazanavir/R. If TDF-based first line. If LPV/R was used for HIV-2 in first line, use ADV/R. Second alternative: tenofovir plus lamivudine, or emtricitabine, plus lopinavir/R, or atazanavir/R. If ZTV-based first line, consider abacavir if patient has used both tenofovir and zidovudine. HIV post-exposure prophylaxis (PEP) for exposed healthcare personnel. 464. B. Special conditions. Table 17-4. Standard treatment in special conditions for HIV/AIDS condition. Recommendation. Comments. HIV co-infection with hepatitis B. See section on hepatitis B. The recommended regimen shall be lamivudine plus tenofovir plus efavirenz. Lamivudine and tenofovir are active against both HPV and HIV. Dual HIV-1 and HIV-2 or HIV-2 infections due to the ineffectiveness of non-nucleoside drugs, nevirapine and efavirenz, in HIV-2 infection. Combination of nucleosides and protease inhibitors such as LPVR or ADV/R should be used. Referral criteria: refer all HIV-positive patients to an accredited treatment center in Ghana. 181. HIV post-exposure prophylaxis (PEP) for exposed healthcare personnel. Post-exposure prophylaxis (PEP) is short-term antiretroviral treatment to reduce the likelihood of HIV infection after potential exposure by preventing the establishment of infection or preventing new infection. PEP reduces staff exposure to HIV infections at work and also clears possible HIV infection from infected dendritic cells. Workplace accidents or injury expose health workers to body fluids of patients. Risk of exposure exposure to blood and blood-borne pathogens is slightly higher for healthcare personnel. The risk of infection for HIV from a percutaneous injury is approximately 0.3%, and that of mucous membranes or non-intact skin are much lower. PEP is particularly effective within 1 to 2 hours, and not more than 72 hours after exposure. Causes. An exposure considered as possible risk is defined as an exposure from possibly infected blood, tissue or other body fluids through a percutaneous injury, for example a needle stick, or cut with a sharp object, or a mucocutaneous membrane or non-intact, chapped, abraded skin contact. The risk of infection appears to be higher after exposure to a large quantity of blood, or to other infectious fluids. Exposure to the blood of a patient in an advanced HIV disease. HIV post-exposure prophylaxis (PEP) for exposed healthcare personnel. Chapter 17, HIV Infections and AIDS. 465. Stage. A deep percutaneous injury or an injury with a hollow bore, blood-filled needle. Signs. None. Symptoms. None. Box 17-1. Steps to prevent occupational transmission of HIV in the event of possible exposure to HIV. The following actions should be taken. The wound site should be cleaned with soap and water. For mucous membranes, the exposed areas should be flushed with plenty of water, for example eyes with water or saline. Assess the level of risk. The risk of possible infection from the exposure should be assessed and classified based on the categories below. Very low exposure. Exposure of potentially infectious material to intact skin. Low risk exposure. Exposure to a small volume of blood or body fluids contaminated with blood from a symptomatic HIV positive patient. Injury with a solid needle or any superficial injury or mucocutaneous exposure. Higher risk exposure. Exposure to a large volume of blood or potentially infectious fluids. Exposure to blood or body fluids contaminated with blood from an HIV positive patient with high viral load. Injury with a hollow bore needle / deep and extensive injury from a contaminated sharp instrument. Exposure to blood from an HIV drug-resistant patient. Investigations. Full blood count. Liver and renal function tests. Hepatitis B surface antigen, HIV serology or PCR, if available treatment objectives. To prevent establishment of HIV infection, non-pharmacological treatment, counseling and testing. Exposed health workers must receive counseling and testing immediately from a trained counselor. The session is to continue throughout the PEP period and thereafter if necessary. Refusal of HIV test by any exposed worker should be documented. Counselor must emphasize safe sex including condom use. All known source patients shall also be counseled and tested. HIV post-exposure prophylaxis (PEP) for exposed healthcare personnel. 466. For HIV infection, if this is not known, pharmacological treatment. Note 17-1 timing. If PEP is necessary, it should be initiated promptly, preferably within 1 to 2 hours post-exposure, and not more than 72 hours after exposure. Evidence rating, AA. Very low risk. Wash exposed area immediately with soap and water. B. Low risk. Tenofovir 300 mg daily for 28 days and emtricitabine 200 mg daily for 28 days or zidovudine 300 mg 12 hourly for 28 days and lamivudine 150 mg 12 hourly for 28 days. C. High risk. Tenofovir 300 mg daily for 28 days and emtricitabine 200 mg daily for 28 days and lopinavir/R 400 mg/100 mg 12 hourly for 28 days or zidovudine 300 mg 12 hourly for 28 days and lamivudine 150 mg 12 hourly for 28 days and lopinavir/R 400 mg/100 mg 12 hourly for 28 days. Note 17-2 If the source patient is HIV/HPV co-infected, then a tenofovir-containing regimen should be used. Follow-up during the period of prophylaxis. A number of baseline and follow-up investigations need to be done to determine HIV serostatus and to monitor the level of drug toxicity. HIV post-exposure prophylaxis (PEP) for exposed healthcare personnel. Chapter 17, HIV Infections and AIDS. 467. Table 17-5, Recommended Monitoring of Drug Toxicity and HIV Serology of Exposed Healthcare Personnel. Baseline tests, full blood count, liver and renal function tests, hepatitis B surface antigen HIV serology or PCR, if available 2 weeks. Full blood count, liver and renal function tests 6 weeks, HIV serology 3 months, HIV serology 6 months, HIV serology. Individuals who seroconvert should have access to comprehensive care and ART services. Box 17-2, Reporting and Documentation. All occupational exposures should be reported immediately to the supervisor. Circumstances of the exposure and PAP management should be recorded. Details should include date and time of exposure, where and how the exposure occurred, exposure site on the body and type of sharp device, type and estimated amount of exposure, fluid, severity, depth/extent of the exposure, source of exposure, and whether the source material contained HIV or blood. Clinical status of source patient. Relevant information about exposed healthcare worker, medical conditions, vaccination including hepatitis B, and medications, pregnancy, or breastfeeding. Document counseling, post-exposure management and follow-ups. 18. Chapter 468. Infectious diseases and infestations. 182. Fever. Fever is a common complaint, which is usually related to an infection of viral, bacterial or parasitic origin. It may be a valuable guide to the diagnosis and severity of infections. Fever is defined as an axillary temperature above 37.5 degrees C, read after keeping the thermometer in place for 3 minutes. Fever above 38 degrees C in children and adults often needs urgent attention, especially if the patient is restless or delirious. Not every fever is due to malaria or typhoid. Every fever should be investigated and treated appropriately. A thorough history, physical examination and appropriate investigation would usually reveal the cause of the fever. In neonates and the elderly, severe infections may not be accompanied by a fever. In infants and young children, fever may be associated with convulsions, collapse, or coma. See table below for possible differential diagnoses and appropriate action. Causes: viral infection, bacterial infection, fungal infections, parasitic infestations, hematological malignancies, for example lymphoma, leukemia, connective tissue disease. Medicine-related symptoms: chills, rigors, body ache signs, temperature 37.50 C. Evidence of dehydration, for example sunken eyes. Evidence of underlying conditions, refer guidelines below. Tachypnea, tachycardia, fever. Chapter 18, Infectious Diseases and Infestations. 469. Investigations. FBC. Blood film for malaria parasites. Rapid diagnostic test for malaria. Cultures of urine, blood, sputum, ear discharge, throat swab, wound swab, cerebrospinal fluid. Depending on presentation. Treatment objectives: to reduce body temperature to normal, to relieve symptoms, to identify and treat the underlying cause of the fever. See guidelines below. Non-pharmacological treatment: keep the patient well hydrated with fluids, for example water, fruit juices, light porridge, rice water or coconut milk. Maintain nutrition, continue breastfeeding in babies. Tepid sponge the child. Wet a towel with lukewarm water and apply to the body starting from the extremities and gradually work your way upwards to the head. Leave a film of water on the body to dry on the skin. Repeat the process as often as needed. Pharmacological treatment evidence rating: A. Paracetamol, oral, adults 1g 6 to 8 hourly, children 10 to 15 mg/kg/dose. May repeat dose 6 to 8 hourly as necessary. Or paracetamol, rectal suppository, adults 1g 6 to 8 hourly, children 125 to 250 mg 6 to 8 hourly. Or ibuprofen, oral, adults 200 to 400 mg 6 to 8 hourly, children 7 to 18 years. 200 mg 6 to 8 hourly 2 to 7 years. 100 mg 8 hourly 6 months 2 years. 50 mg 8 hourly 1 to 6 months. 5 mg/kg 6 to 8 hourly. Treat the cause of the fever appropriately. See appropriate section. Fever 470. Note 18:1 Do not give aspirin to children under the age of 16 years. Control convulsions with diazepam. See section on seizure disorders. Referral criteria: fever persisting for more than 10 days in spite of treatment should be considered as pyrexia of unknown origin, PUO, and should be referred for further investigation. Table 18:1 Guidelines for the treatment of the patient with fever complaints. Diagnosis action. See appropriate section. Rigors: fever, occasionally periodic, sweating, general malaise, joint pains, malaria. Take a blood film, or perform rapid diagnostic tests for malaria parasites and treat appropriately. Rigors: fever, sweating, general malaise, altered sensorium, cerebral malaria. Take a blood film, or perform rapid diagnostic tests for malaria parasites and treat appropriately. Headache, vomiting, drowsiness, stiff neck, seizures, meningitis. Do not delay treatment while awaiting results of lumbar puncture. Cough, brown sputum, rapid breathing, pain on deep breathing. Pneumonia. Give appropriate antibiotic. Increased frequency of urination and/or painful micturition. Loin pain, urinary tract infection. Do urine examination plus culture and sensitivity. Give appropriate antibiotic. Fever, constipation, or diarrhea, maybe with blood. Headache, abdominal pain, general malaise. Typhoid. Start appropriate treatment. Warm, swollen, painful, reddish-looking limb. Cellulitis, erysipelas or impetigo. Give appropriate antibiotic. Fever in a child with cough, sore throat and red eardrums. Otitis media. Give appropriate antibiotic. Tuberculosis. Chapter 18, Infectious Diseases and Infestations. 471. Complaints. Diagnosis action. Fever during pregnancy with loin pain, pyelonephritis. Take sample for urine culture and sensitivity, and give appropriate antibiotic. Pain in a bone, usually a limb bone, painful to touch. Osteomyelitis. X-ray the affected part. Treat as for osteomyelitis. Jaundice preceded by feeling unwell, anorexia, low-grade fever. Viral hepatitis. Do liver function tests. Hepatitis B surface antigen. Treat conservatively. Bed rest. Headache, body ache, runny nose, sneezing, common cold or influenza. Give paracetamol if required. Long-standing fever, weight loss, chronic diarrhea, lymphadenopathy, acquired immunodeficiency syndrome. Manage as appropriate. Sore throat or pain on swallowing, tonsillitis and pharyngitis. Manage as appropriate. Abrupt fever, chills, and malaise, weakness, muscle pain, rash, diarrhea, bleeding. Viral hemorrhagic fever, for example Ebola virus disease. Manage according to standard protocol. 183. Tuberculosis. Tuberculosis, TB, may affect any part of the body, but the commonest site is the lung. Pulmonary TB. Other sites affected include the spine, bone and joints, brain, urinary tract, abdomen and lymph nodes, etc. Pulmonary TB patients who have acid-fast bacilli, AFB, in their sputum, bacteriologically positive TB, are most infectious and spread the disease through airborne droplets when they cough, spit or sneeze. Drinking unpasteurized milk may cause bovine TB, which manifests as abdominal TB. Persons with lowered resistance to infection, such as HIV/AIDS and diabetes, are especially at risk of developing TB. Such individuals tend not to have the typical symptoms and signs of TB. They may have features such as fever, weight loss and diarrhea, which could also be attributed to the condition. In children with severe malnutrition who show poor response to dietary treatment, TB must be considered and excluded. Tuberculosis. 472. Causes. Mycobacterium tuberculosis. Mycobacterium bovis, bovine TB. Mycobacterium africanum M. microdi, M. consacii and M. malmonsi. Rare causes. Symptoms. Adults cough often for 2 weeks or more. Chest pain. Loss of weight. Loss of appetite. Blood-stained sputum. Fever. Drenching night sweats. Children. All adult symptoms and the following: malnourished and chronically ill-looking, cachexia, persistent low-grade fever, lasting 2 to 3 weeks, failure to thrive, fatigue, malaise, poor appetite, back pain and/or lower limb weakness, irritability, vomiting and impaired consciousness, due to TB. Meningitis. Signs of malnutrition, cachexia, pallor, signs of pneumonia or pleural effusion, lymphadenopathy, neck stiffness, altered level of consciousness in TB. Meningitis, spinal tenderness, gibbous, paraplegia/paresis in Pott's disease. Signs of extrapulmonary disease. Investigations: sputum smear microscopy, colonoscopy, chest x-ray, Mantoux test, genes PERT MTB/Rev, line probe assay, mycobacterial culture, full blood count, ESR, liver function test, for monitoring medication side effects, HIV screening, tuberculosis, Chapter 18, Infectious Diseases and Infestations. 473. Treatment objectives. To cure the disease. To prevent further transmission. To prevent the development of drug resistance. To manage drug side effects. To offer psychosocial support. To investigate close contacts. Where a child is affected, always check adult contacts with productive non-pharmacological treatment. Counseling. Encourage good nutrition. Some food supplementation is provided by National TB Program. Encourage adequate rest. Admit severely ill patients. Assign a treatment support or pharmacological treatment. Note 1822. For the purposes of TB management, consider the following definitions. Adults, all persons aged 15 years and above. Children, all persons aged below 15 years. New patients, all persons who have never had TB treatment, or have taken TB treatment for less than 1 month. Previously treated patients, all patients who have previously received TB treatment for 1 month or more. Refer to the TB client card, TB01, for guidance on formulations and dosing by weight. A. Standard treatment. First line treatment. TB treatment category. TB patient type. Treatment regimen. Comments. Adults initial phase. Continuation phase. New patients Cat I+3. All new cases, including new smear positive PDB, new smear negative PDB, concomitant HIV disease, extrapulmonary TB. 2 months of HRZE equals 56 doses of HRZE. 4 months of HR equals 112 doses of HR. Treatment is once daily in HIV disease. Treatment can be extended to 8 months. Tuberculosis, 474. TB treatment category. TB patient type. Treatment regimen. Comments. Previously treated patients Cat II. Previously treated sputum smear positive PDB. Relapse. Treatment after interruption. Treatment failure. 2 months of S plus 3 months of HRZE equals 56 doses of S and 84 doses of HRZE. 5 months of HRE equals 140 doses of HRE. Request drug susceptibility testing, DST, before start of treatment. Treatment is once daily. TB meningitis and osteoarticular TB. All cases 2 months of HRZE equals 56 doses of HRZE. 10 months of HR equals 280 doses of HR. Treatment is once daily. Children initial phase. Continuation phase. Comments. New patients. All new cases, including new smear positive PDB, new smear negative PDB, concomitant HIV disease, extrapulmonary TB. 2 months of HRZE equals 56 doses of HRZE. 4 months of HR equals 112 doses of HR. Treatment is once daily in HIV disease. Treatment can be extended to 8 months. Previously treated patients. Previously treated sputum smear positive PDB. Relapse. Treatment after interruption. Treatment failure. 2 months of S plus 3 months of HRZE equals 56 doses of S and 84 doses of HRZE. 5 months of HRE equals 140 doses of HRE. Request DST before start of treatment. Treatment is 1 daily. TB meningitis and osteoarticular TB. All cases 2. HRZE equals 56 doses of HRZE. 10. HR equals 280 doses of HR. Treatment is daily. Isoniazid, H, rifampicin, R, pyrazinamide, Z, ethambutol, E, streptomycin, S. Note 1823. Treatment month is 28 days. All patients taking isoniazid, H, should take 25 mg of pyridoxine, vitamin B6, to prevent peripheral neuropathy. Dose of pyridoxine should be doubled in HIV patients. Tuberculosis, Chapter 18, Infectious Diseases and Infestations. 475. Asterisk indications for steroid use in childhood TB include endobronchial TB, large pleural effusions, pericardial effusion and TB meningitis. The duration of steroid use should not exceed 1 month. All children under 5 years and all HIV-positive children who are contacts of a TB patient should be given prophylactic isoniazid at a dose of 10 mg/kg body weight for at least 6 months. Table 1822, Dosing for TB medicines. Anti-TB drug, abbreviation, recommended daily dosage, maximum dose, adult dosing. Children dosing isoniazid, H, 4 to 6 mg/kg, 375 mg, 10, 15 mg/kg, 300 mg, rifampicin, R, 8 to 12 mg/kg, 750 mg, 10, 20 mg/kg, 600 mg, berzinamide, Z, 20 to 30 mg/kg, 2000 mg, 30, 40 mg/kg, 2000 mg, ethambutol, E, 15 to 20 mg/kg, 1375 mg, 15, 25 mg/kg, 1200 mg, streptomycin, S, 12 to 18 mg/kg, 1000 mg, 20, 40 mg/kg, 1000 mg. B. Adjunctive treatment. Pyridoxine, vitamin B6, oral, adults 50 to 100 mg daily for 3-8 months, children 25 to 50 mg daily for 8 months, and prednisolone, oral, in cases of TB meningitis and TB pericarditis, adults 40 to 60 mg daily, 2 to 4 weeks, then taper off on improvement over 2 to 4 weeks, and discontinue children 1 to 2 mg/kg daily, 2 to 4 weeks, then taper off on improvement over 2 to 4 weeks and discontinue. C. Treatment in special situations. Chronic kidney disease. New cases, adults and children, owing to a high risk of uveitis, give the following: intensive phase, HRZ for 2 months, continuation phase, HR for 4 months, pregnancy and breastfeeding. Give standard treatment. Do not use streptomycin, ototoxic to fetus. Note 18 to 4. Prevention of drug resistance. To prevent the development of drug resistance to rifampicin, it is RICOM. Drug-resistant tuberculosis. Dr. D.B. 476. Mendithiazide plus rifampicin combination tablet is used instead. Prescribing rifampicin alone is not approved and must be discouraged. During treatment, the patient must swallow all the oral drugs, preferably on an empty stomach under direct observation. The patient needs to be under close supervision by a health worker or a responsible person or member of the community with support from health staff during the full duration of treatment. Monitoring during the course of treatment. All smear-positive pulmonary TB patients should have repeat sputum smears examined after 2 or 3 months of treatment, at 5 months, and at the end of treatment. If result is smear positive, request for mycobacterial culture and drug sensitivity testing. 184. Drug-resistant tuberculosis. Dr. D.B. Drug-resistant tuberculosis, Dr. D.B., must be presumed, suspected, in persons who remain bacteriologically positive, either smear positive, culture positive or genes PERT positive, after intensive phase of standard first-line TB treatment with or without clinical improvement. Persons who test rifampicin resistance positive at initial diagnosis with genes PERT must also be treated as cases of Dr. TB. These persons must be further evaluated using TB culture and drug susceptibility testing, DST, or newer molecular diagnostic tests such as line probe assays, LPA. Persons at high risk of drug resistance are TB patients failing category I plus III or category II treatment, contacts of confirmed Dr. TB patients and TB/HIV co-infected patients not improving on treatment. Persons at medium risk of drug resistance are relapsed TB patients, return after loss to follow-up, and healthcare workers newly diagnosed with TB. Patients are classified according to the pattern of documented drug resistance profile. The drug regimen for treatment is selected based on the following principles: history of drugs used to treat TB patients, profile of drug resistance in gamma and/or DST, profile of the patient. A minimum of 4 new core medicines that are known to be effective. Kanamycin/capreomycin, an injectable medicine, is the backbone of the 4 core medicines and should be used in the intensive phase. Ineffective fluoroquinolone should be used due to the extensive use of earlier generation fluoroquinolones. May include the first-line drug to which the strain is susceptible. Cross-resistance may occur between drugs of the same group, and this is taken into consideration. Drugs are administered daily under strict dot throughout the injectable and continuation phases. Treatment of multi-drug resistant TB, MDR-TB, and rifampicin-resistant TB, RRTB, patients is prioritized. Treatment duration is 20 to 24. Drug-resistant tuberculosis, Dr. D.B. Chapter 18, Infectious Diseases and Infestations. 477 months and is determined by sputum smear and culture. Bacteriological conversion. Treatment lasts 16 to 18 months after bacteriological conversion. Progression from initial to continuation phase is dependent on at least 4 consecutive months of negative sputum cultures. Community-based care is promoted and gone over facility-based care, except in situations requiring admission for management of complications. The practice of infection prevention and control should be maintained at all times during treatment of these patients. Treatment adherence is critical in the treatment of Dr. TB due to limited number of available, effective medicines. Treatment is challenging due to long duration, drug toxicities and side effects. Clinical teams must use a patient-centered care approach and support patients throughout treatment until cured. Psychosocial and economic support is required from treatment supporters, patient families and clinical teams throughout treatment. Early detection and prompt management of drug side effects ensures successful outcomes. Treatment. Pharmacological treatment. Note 18-5 treatment with multi-drug resistant TB, MDR-TB, and rifampicin-resistant TB, RRTB, patients is prioritized. Treatment duration is 20 to 24 months, and is determined by sputum smear and culture. Bacteriological conversion. Treatment lasts 16 to 18 months after bacteriological conversion. Progression from initial to continuation phase is dependent on at least 4 consecutive months of negative sputum cultures. Second-line treatment. B. Multi-drug resistant TB, MDR-TB. TB treatment category. TB patient type. Treatment regimen. Comments. Adults and children. Initial phase. Continuation phase. Multi-drug resistant tuberculosis, MDR-TB. All newly diagnosed MDR-TB with or without HIV and symptomatic contacts of confirmed MDR-TB with or without HIV. 8 months of ZCM-LFX-PDO-CS number. 12 months Z-LFX-PTO-CS number. Treatment is daily. Treatment month is 28 days. Modify treatment according to culture results. Number for every 250 mg of cycloserine give 50 mg of pyridoxine, vitamin B6, to prevent peripheral neuropathy. Dose of pyridoxine should be doubled in HIV patients. Asterisk. Is an alternative to seize drug-resistant tuberculosis. Dr. TB - 478. C. Treatment protocol for other resistant types. Table 18-3. Treatment protocol for other resistant types. Resistance pattern. TB patient type. Treatment regimen. Comments. Adults and children. Initial phase. Continuation phase. Streptomycin resistant, S. Monoresistant 2 months of HRZE 4 months of HR. Ethambutol resistant, E. Monoresistant 3 months of HRZ 6 months of HR. Isoniazid resistant, H. Monoresistant 9 months of HRZE at extra dose of isoniazid up to a maximum of 300 mg daily for treatment duration. Streptomycin and isoniazid resistant, SH. Polyresistant TB 9 months of HRZE at extra dose of isoniazid up to a maximum of 300 mg daily for treatment duration. Isoniazid and ethambutol resistant, HE, polyresistant TB 9 months of RZLFX extend treatment to 12 months, if extensive lung destruction from X-ray image H, E, and S, Z, polyresistant TB 3 months of KM-PDO-LFX-RZ 15 months of PDO-LFX-RZ modified MDR regimen plus R mono or polyresistance rifampicin resistant TB 8 months of HZCM-LFX-PDO-Cs, PA 12 months of HZLFX-PDO-Cs, PA full MDR regimen plus H. Asterisk. Is alternative to Cs. Note 18-6 definitions. Monoresistant TB. TB bacilli have resistance to only one from the first-line anti-tuberculosis medicines, streptomycin, isoniazid, rifampicin, pyrazinamide or ethambutol. Polyresistant TB bacilli have resistance to at least 2 medicines, but not to both isoniazid and rifampicin. Rifampicin resistant, RRTB. TB bacilli have resistance to rifampicin with or without resistance to other first-line anti-tuberculosis medicines. This may be mono, poly, multi or extensively drug-resistant TB. Typhoid fever Chapter 18, Infectious Diseases and Infestations. 479. Multi-drug resistant, MDR-TB. TB bacilli have resistance to at least both rifampicin and isoniazid. Extensively drug-resistant, XDR-TB. TB bacilli have resistance to one of the fluoroquinolones and at least one of the three injectable second-line drugs, kanamycin, capreomycin or amikacin, in addition to MDR-TB. Table 18-4, Dosing of second-line medicines anti-TB drug, abbreviation, recommended daily dosage, maximum dose, adult dosing, children dosing, pyrazinamide, Z, 20 to 30 mg/kg once daily, 2000 mg, 30 to 40 mg/kg once daily, 2000 mg, kanamycin, kilometers, 15 to 20 mg/kg once daily, 1000 mg, 15 to 30 mg/kg once daily, 1000 mg, capreomycin, cm, 15 to 20 mg/kg once daily, 1000 mg, 15 to 30 mg/kg once daily, 1000 mg, levofloxacin, LFX, 750 to 1000 mg once daily, 1000 mg, 15 to 20 mg/kg/day in 2 divided doses, 1000 mg. Ethionamide, ETO, 500 to 750 mg daily in 2 divided doses, 1000 mg, 15 to 20 mg/kg/day in 2 divided doses, 1000 mg. Prothonamide, BDO, 500 to 750 mg daily in 2 divided doses, 1000 mg, 15 to 20 mg/kg/day in 2 divided doses, 1000 mg. Cycloserine, Cs, 500 to 750 mg daily in 2 divided doses, 1000 mg, 10 to 20 mg/kg/day in 2 divided doses, 1000 mg. Para-aminosalicylic acid, PA, 8g once daily, or in 2 divided doses, 12g, 200 to 300 mg/kg/day in 2 to 3 divided doses, 8g. Note 18 to 7 Ghana will be adopting a shorter treatment regime, 9 to 12 months, for management of Dr. TB. Please keep checking with the National TB Control Program. Referral criteria for all patients to ADOT's Treatment Center for Management and Monitoring under Ghana National Tuberculosis Program. 185 Typhoid fever. Typhoid fever, enteric fever, is a severe bacterial illness which occurs where sanitary conditions are poor, permitting contamination of food or water with feces. The bacteria, which are spread by the fecal route, invade the intestinal wall and spread through the bloodstream to all organs. They are passed into the stool and urine of infected patients. Organisms may continue to be present in the stool of healthy carriers, that is, typhoid fever. 480 patients with positive stool cultures 12 months after treatment, or those with long-term subclinical disease. If improperly treated, typhoid fever may result in complications such as intestinal perforation with peritonitis, bloody stools, acute psychosis and severe intravascular hemolysis leading to acute kidney injury, especially in G6PD deficiency. Public education on good personal hygiene, hand washing and appropriate disposal of solid waste would often prevent the disease. Screening of food handlers, by carrying out stool cultures, to exclude carrier status, and safe handling of food, fruits, and vegetables are also helpful preventive measures. Causes: Salmonella typhi and pyratyphi. Symptoms: fever which increases gradually to a high fever, and persists for weeks. Fever does not respond to antimalarials. Constipation in the early stages. Abdominal pain and diarrhea in the second week of illness. Severe headache, dry cough, psychosis and confusion may occur. Signs: high fever with a relatively slow pulse rate. Occasionally pulses fast, especially with myocarditis or intestinal perforation. Abdominal tenderness. Hepatosplenomegaly, tender. Confusion. Signs of chest infection, pneumonitis. Investigations: FBC, differential RDT/blood film for malaria parasite, to exclude malaria. Blood culture, stool culture, urine culture. Note 18-8 Notes on diagnosis. Diagnosis of typhoid fever is based on a strong clinical suspicion backed by MRI. Blood cultures, positive during first 10 days of fever. Stool cultures, positive after 10th day up to 4th or 5th week. Urine cultures, positive during 2nd and 3rd week. The above tests are superior to the Widal test, which is unreliable and rarely useful in confirming a diagnosis of typhoid fever. Typhoid fever - Chapter 18, Infectious Diseases and Infestations. 481. Treatment objectives: to eradicate the infection, to detect and manage complications, to prevent transmission of infection to other people. Non-pharmacological treatment: tepid sponging to reduce body temperature, if required. Pharmacological treatment evidence rating: B. Ciprofloxacin, oral, adults 500 mg 12 hourly for 10 to 14 days, children 10 mg/kg 12 hourly for 10 to 14 days, or ciprofloxacin, IV, to be administered over 60 minutes, adults 400 mg 8 to 12 hourly for 10 to 14 days, children 10 mg/kg, maximum 400 mg, 12 hourly for 10 to 14 days. Note 18 to 9. Ciprofloxacin should be used within children. Ciprofloxacin may rarely cause tendinitis. At the first sign of pain or inflammation, patients must discontinue treatment and alternative treatment, for example azithromycin/ceftriaxone, started. Second-line treatment evidence rating: B. Ceftriaxone, IV, adults 2 to 4 g daily for 7 to 10 days, children 100 mg/kg daily for 7 to 10 days, or azithromycin, oral, adults 500 mg daily for 7 days, children 10 to 20 mg/kg for 7 days. Referral criteria for varial patients and those with complications such as intestinal perforation, intravascular hemolysis and peritonitis to the appropriate specialist. Healthy carriers should also be referred for specialist management. Malaria - 482. 186. Malaria is a very common infection in Ghana. It follows the introduction of protozoan malaria parasites into the bloodstream by the bite of an infected female Anopheles mosquito. Malaria is a major cause of significant morbidity and mortality, especially among vulnerable individuals, such as children under 5 years of age, pregnant women, sometimes with adverse fetal and maternal outcomes, patients with sickle cell disease, and visiting non-resident Ghanaians and expatriates. Based on the clinical severity, cases of malaria are categorized as either "uncomplicated" or "severe." A diagnosis of malaria can be suspected, based on the patient's symptoms and the physical findings at examination. However, for a definitive diagnosis, to be made laboratory tests, blood film and/or rapid diagnostic test, must demonstrate the malaria parasites or their components, since the clinical presentation of the condition can be similar to other common diseases such as typhoid fever, urinary tract infection, septicemia, pneumonia, and meningitis in both adults and children, and measles, otitis media, tonsillitis, etc. in children. In Ghana, diagnosis is progressively being shifted from clinical to laboratory confirmation as the basis for treatment. Rapid diagnostic test, RDT, may be used to confirm a diagnosis if microscopy, blood film, is not available. Preventive measures in the community mainly target elimination of the insect vector or prevention of mosquito bites, while additional chemoprophylaxis is required for vulnerable individuals. The development of resistance of malaria parasites to anti-malarial medications is a matter of major public health concern. This phenomenon is largely the result of overdiagnosis and wrong diagnosis of malaria by healthcare practitioners and patients alike, with its attendant overtreatment and sometimes partial or incomplete treatment, leading to overexposure of the parasites to the anti-malarial drug pressure. Additionally, artemisinin in combination therapy, ACT, rather than monotherapy with artemisinin derivatives, is currently recommended for the treatment of uncomplicated malaria, to prevent the development of drug resistance. It is therefore necessary to obtain laboratory confirmation of a diagnosis of malaria before starting treatment. Exceptions to this principle are children under 5 years and cases of suspected severe malaria, where laboratory confirmation is not immediately possible. In such circumstances, the complete course of the appropriate anti-malarial medication or medications must be given. Causes: Plasmodium falciparum, commonest and responsible for most of the deaths and morbidity associated with malaria in Ghana. Uncomplicated malaria Chapter 18, Infectious Diseases and Infestations. 483. Plasmodium malariae. Plasmodium ovale. 187. Uncomplicated malaria. Symptoms: fever, chills, rigors, sweating, headache, generalized body and joint pain, nausea and or vomiting, loss of appetite, abdominal pain, especially in children, irritability and refusal to feed. In infants, signs: fever, mild pallor, mild jaundice, splenomegaly. Investigations: microscopy, thick and thin blood films for malaria parasites, rapid diagnostic test, RDT, FBC. Other tests as indicated. Treatment objectives: to avoid progression to severe malaria, to limit the duration of the illness, to minimize the development of drug-resistant parasites. Non-pharmacological treatment. In children, tepid sponging to reduce body temperature. Pharmacological treatment. First-line treatment. Evidence rating: A. Artesunate plus imodiaquine, oral, see Table 18-5 on page 484, Table 18-6 on page 484, Table 18-7 on page 484, or artemether plus lumefantrine, oral, see Table 18-8 on page 485, or dihydroartemisinin plus piperacquine, oral, see Table 18-9 on page 485. Uncomplicated malaria. 484. Table 18-5, artesunate plus imodiaquine co-blistered formulation, regimen for once daily dosing, weightage: artesunate, 50 mg tablets, number of tablets to be given: imodiaquine, 150 mg base tablets, number of tablets to be given: day 1. Day 2, Day 3, Day 1, Day 2, Day 3, 5-10 kg 1 near 11 to 24 kg 1 to 6 1 1 1 1 1 1 24-50 kg 7 to 13. 2 2 2 2 2 2 50-70 kg 14 to 18. 3 3 3 3 3 3 is greater than 70 kilograms. 18. 4 4 4 4 4 4. The dose in mg/body weight is imodiaquine 10 mg/kg plus artesunate 4 mg/kilograms, taken as a single dose daily for 3 days after meals. Table 18-6. Artesunate plus imodiaquine co-blistered formulation, regimen for twice daily dosing, weightage: artesunate, 50 mg tablets, number of tablets to be given: imodiaquine, 150 mg base tablets, number of tablets to be given: day 1. Day 2, Day 3, Day 1, Day 2, Day 3 AM PM AM PM AM PM AM PM AM PM AM PM 5 to 10 kg 70 kilograms. 18. 2 2 2 2 2 2 2 2 2 2 2. The dose in mg/body weight is imodiaquine 10 mg/kg plus artesunate 4 mg/kg, taken as 2 divided doses daily for 3 days after meals. Table 18-7, artesunate and imodiaquine fixed dose combination, standard regimen, using the 3 available dosing strengths: artesunate, AS, plus imodiaquine, AC, number of fixed dose combination tablets, to be given: weightage: tablet dosing strength: day 1, day 2, day 3, 8 kg 2 to 11 Missouri, AS, 25 mg AC, 67.5 mg 1 Uncomplicated malaria. Chapter 18, Infectious Diseases and Infestations. 485. Table 18-7, artesunate and imodiaquine fixed dose combination, standard regimen, using the 3 available dosing strengths: 9 to 17 kg 1 to 5 as 50 mg AC, 135 mg 1 18 to 35 kg 6 to 13 as 100 mg AC, 270 mg 1 36 kilograms 13 as 100 mg AC, 270 mg 2. Each fixed dose combination tablet contains both artesunate, AS, and imodiaquine, AC, at the dosages indicated. The product packaging clearly indicates which dosing strength applies to which age group. The maximum daily dose of artesunate/amodiaquinus 200 mg/600 m/g. Table 18-8, artemether and lumefantrine, dosing regimen, artemether, 20 mg, plus lumefantrine, 120 mg. Number of tablets to be given: weightage: day 1, day 2, day 3. First dose, second dose, after 8 HRS, AM/PM, 12 4, 4, 4, 4, 4, 4. Table 18-9, dihydroartemisinin and PrivateCare, dosing regimen, weightage: dihydroartemisinin, 40 mg/PrivateCare, 320 mg base. Number of tablets to be given: day 1, day 2, day 3. 5-10 kilograms, 70 kilograms, 18 3, 2. Severe malaria - 486. 188. Severe malaria. Severe or complicated malaria can arise from delay in diagnosis or inappropriate treatment of uncomplicated malaria. It mostly occurs in children under 5 years of age, pregnant women and non-immune individuals. The events causing most deaths in severe malaria are related to cerebral involvement, cerebral malaria, severe anemia, hyperglycemia, severe dehydration, renal failure and respiratory acidosis. The diagnosis of severe malaria is based on clinical features and confirmed with laboratory testing. Not all cases of severe malaria have hypercythemia, and initial blood film examination may be negative. Where the diagnosis is suspected, treatment must be started without delay while awaiting confirmation. Symptoms: poor oral intake, for example breast milk in children, repeated profuse vomiting, dark or cola-colored urine, passing of very little urine, difficulty in breathing, generalized weakness, inability to walk or sit without assistance, altered consciousness, change of behavior, confusion, delirium, coma, repeated generalized convulsion signs, hyperpyrexia, axillary temperature, 38.5 degrees C, extreme pallor, severe anemia, HB5G/DL, marked jaundice, circulatory collapse or shock, cold limbs, weak rapid pulse, tachypnea, rapid breathing, crepitations on chest examination, sweating, due to hypoglycemia, hemoglobinuria, dark or cola-colored urine, oliguria, spontaneous unexplained heavy bleeding, disseminated intravascular coagulation, altered consciousness, change of behavior, confusion, delirium, coma. Investigations: rapid diagnostic test, blood film for malaria parasites. Thick and thin blood films should be done where available. FBC sickling test. Severe malaria - Chapter 18, Infectious Diseases and Infestations. 487. Random blood glucose, BU and creatinine. Blood grouping and cross-matching. Lumbar puncture in the convulsing or comatose patient to exclude meningitis or encephalitis. Treatment objectives: to ensure rapid clearance of parasitemia, to provide urgent treatment for life-threatening complications or conditions, for example convulsions, hyperglycemia, dehydration, renal impairment, to provide appropriate supportive care. Non-pharmacological treatment: place patients who are unconscious or having seizures in an appropriate position, to prevent aspiration. Pharmacological treatment evidence rating, AA. Pre-referral treatment: artesunate, IM, adults and children, 20 kg 2.4 mg/kg, children 20 kg 3 mg/kg, or artemether, IM, adults and children 3.2 mg/kg, or quinine, IM, 10 artesunate, rectal, 10 mg/kg, preferred in children under 6 years, EE table 110, or artesunate, rectal, 10 mg/kg, preferred in children under 6 years, table 18-10, dosing regimen for quinine IM injection in young children. Weight volume of quinine dihydrochloride injection, 50 mg/ml dilution, 5 kg 1.0 ml 5.1-7.5 kg 1.5 ml July 6, 10.0 kg 2.0 ml October 1, 12.5 kg 2.5 ml December 6, 15.0 kg 3.0 ml January 15, 17.5 kg 3.5 milliliters, half to each thigh. Severe malaria - 488. Table 18 to 10, Dosing Regimen for Quinine Injection in Young Children. June 17, 20.0 kg 4.0 milliliters, half to each thigh. January 20, 22.5 kg 4.5 milliliters, half to each thigh. June 22, 25.0 kg 5.0 milliliters, half to each thigh. January 25, 27.5 kg 5.5 milliliters, half to each thigh. June 27, 30.0 kg 6.0 milliliters, half to each thigh. The dosage for quinine is 10 mg, 0.2 milliliters per kilograms of body weight every 8 hours. Note 18 to 10, How to give intramuscular quinine in young children. Weigh the child. Prepare a quinine dilution of 50 mg/ml. Use a 10 ml sterile syringe and needle to draw up 5 ml of sterile water for injection or saline, not dextrose. Then into the same syringe draw up 300 mg, 1 milliliter, from an ampoule of quinine. The syringe now contains 50 mg quinine per milliliters. The dosage is 10 mg, 0.2 milliliters, per kilograms or body weight every 8 hours. Calculate the volume to give, based on body weight. For examples of body weights and doses in children: 30 kilograms, artesunate, rectal, 10 mg/kg, preferred in children under 6 years, 110. Administer by intramuscular injection to the thigh. If the diluted volume exceeds 3 milliliters, inject half the dose into each thigh. Intramuscular quinine in adults. Use a quinine dilution of 100 mg/ml. To prepare this, draw 2 ml of quinine 600 mg, and add 4 ml of sterile water or saline, not dextrose. The dosage is 10 mg/kg. Body weight of quinine given 8 hourly by DPIM injection, to a maximum dose of 600 mg. Small adults, weighing less than 60 kilograms, should be weighed to calculate the correct dose. Larger adults will simply receive the maximum dose, 600 mg. If the required volume is more than 5 milliliters, divide it into 2, and inject at separate sites. Table 18 to 11, Rectal artesunate, peripheral treatment in children, weight age artesunate dose regimen. 5, 8 kg 40 kilograms, 14 years 400 to 200 mg suppositories. Severe malaria Chapter 18, Infectious Diseases and Infestations. 489. B. Treatment in Referral Center. Note 18 to 11, Parenteral antimalarials and follow-on treatment. The current recommendation is to give parenteral antimalarials in the treatment of severe malaria for a minimum of 24 hours, irrespective of the patient's ability to tolerate oral medication, until the patient is able to tolerate oral medicine as follow-on treatment. Recommended follow-on treatments include DACs and quinine plus clindamycin. Artesunate, iWorld, adults and children, 20 kg 2.4 mg/kg 12 hourly given at time 0 hour, that is on admission, at 12 hours and 24 hours, then 2.4 mg/kg daily until patient can swallow, maximum 7 days, then a full 3-day course of recommended oral artemisinin in combination therapy. ACT, children 20 kg 3 mg/kg 12 hourly given at time 0 hour, that is on admission, at 12 hours and 24 hours, then 3.0 mg/kg daily until patient can swallow, maximum 7 days, then a full 3-day course of recommended oral ACT. Note 18 to 12, artesunate reconstitution for parenteral injection. Reconstitution, use a syringe to draw and inject the solvent, sodium bicarbonate 50 mg/ml solution, into the vial of artesunate powder. Shake the vial until the powder is completely dissolved, and the solution is clear. For intravenous injection, add either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution, to create a 10 mg/ml solution of artesunate. Draw required volume, and give slowly by IV at about 3 to 4 ml/minute either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution, to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject a separate slit. Add either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject a separate slit. Add either glucose 50 mg/milliliters, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal. Severe malaria - 490 saline solution to the reconstituted artesunate solution to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject at separate sites. See Table 112, Table 112, Table 112, BLA 112. For intramuscular injection, add either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject a separate slit. Add either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject a separate slit. Add either glucose 50 mg/ml, that is 5% dextrose solution, or sodium chloride 9 mg/ml, that is 0.9% normal saline solution, to the reconstituted artesunate solution to create a 20 mg/ml solution of artesunate. Draw required volume and give slowly by m anterior thigh. If the required volume is more than 5 milliliters, divide it into 2 and inject at separate sites. See Table 112, Table 112, Table 112, Table 18 to 12. Approximate quantities for dilution route of injection. Injection strength of medicine 30 mg, 60 mg, 120 mg, 30 mg, 60 mg, 120 mg. Sodium bicarbonate 50 mg/ml solution for reconstitution. Milliliters 0.512, 0.512. Glucose 50 mg/ml solution for injection, or sodium chloride 9 mg/ml for injection. Milliliters 2.55, 10, 1, 2, 4. Total diluent needed. Milliliters 3, 6, 12, 1.536. Artesunate concentration mg/milliliters 10, 10, 10, 20, 20, 20. Note 18 to 13. Calculation of dose of artesunate needed. Milliliters. Adults, for iWorld. 2.4 mg body weight, kilograms. IV artesunate solution concentration 10 mg/ml. Severe malaria - Chapter 18, Infectious Diseases and Infestations. 491. For iWorld. 2.4 mg body weight, kilograms. Artesunate solution concentration 20 mg/ml. Children 20 kilograms, for iWorld. 3 mg body weight, kilograms. IV artesunate solution concentration 10 mg/ml for iWorld. 3 mg body weight, kilograms. Artesunate solution concentration 20 mg/ml. Precautions: inject immediately after reconstitution, and discard if not used within 1 hour. Discard if solution is not clear. Do not use an IV drip. Give slowly by direct hive injection at about 3 to 4 ml/min or artemether, IM. Adults and children 3.2 mg/kg stat. Then, 8 hours later, 1.6 mg/kg. Then, 24 hours after initiation of treatment, 1.6 mg/kg once daily until patient can swallow, up to 5 days. Then a full 3-day course of recommended oral artemisinin in combination therapy, ACT, or quinine, IV, in dextrosaline, or in 5% dextrose, 5-10 ml/kg, adults and children 10 mg/kg, maximum dose 600 mg, infused over 4 to 8 hours. Repeat infusion 8 hourly until patient can swallow. Then quinine, oral, 10 mg/kg 8 hourly to complete 7 days of treatment, and clindamycin, oral, 10 mg/kg, 12 hourly for 7 days. Note 18 to 14 clindamycin should be administered with food and copious amounts of water. Quinine, IV, should always be given by a slow infusion, never by bolus intravenous injection, as this may cause severe hypotension. Or quinine, IM. Adults and children 10 mg/kg, maximum dose 600 mg, 8 hourly until patient can swallow. Then quinine, oral, 10 mg/kg 8 hourly to complete 7 days of treatment. Malaria in pregnancy - 492, and clindamycin, oral, 10 mg/kg, 12 hourly for 7 days. Referral criteria: patients diagnosed as having severe malaria, or who fail to respond to the recommended antimalarial medications, must be referred. Appropriate treatment as indicated above must be initiated prior to transferring the patient. If referral is not possible immediately, continue the treatment regimen as shown above for severe malaria, until referral is possible. 189. Malaria in pregnancy. Pregnancy makes women more likely to get malaria or die from malaria. Malaria infection is more severe during pregnancy, while pregnancy and its outcomes can become complicated by it. The effects of malaria on the pregnant mother include a severe form of the illness, anemia, miscarriage, preterm labor, and postpartum hemorrhage. Risks to the fetus include fetal anemia, prematurity, intrauterine growth restriction, low birth weight, stillbirth, congenital malaria, and increased perinatal mortality. Preventive measures must be emphasized, that is insecticide-treated nets, IDNs, and intermittent preventive treatment in pregnancy, IPT, under direct observation, while confirmed cases must be treated promptly. Treatment objectives: to ensure prompt and effective case management. Non-pharmacological treatment. Non-pharmacological treatment: A. Treatment of uncomplicated malaria in the first trimester. Quinine, oral, may be given as monotherapy. If clindamycin is not available, 10 mg/kg, maximum 600 mg, 8 hourly for 7 days, and clindamycin, oral, 10 mg/kg, twice daily for 7 days. Note 18 to 15. The drug of choice for uncomplicated malaria for pregnant women in the first trimester is oral quinine. ACTs are not recommended for use in the first trimester. However, their use should not be withheld in cases where they are considered to be life-saving, or where other antimalarials are considered to be unsuitable. Malaria in pregnancy - Chapter 18, Infectious Diseases and Infestations. 493. B. Treatment of uncomplicated malaria in the second and third trimesters. Artesunate plus MOD. Artesunate plus MOD quine co-blistered formulation, regimen for twice daily dosing, ortidocin mg/body weight is, MOD quine 10 mg/kg plus artesunate 4 mg/kg, taken as 2 divided doses daily for 3 days, after meals. Table 15, Tabla 16, Table 17, or artemethamphetamine, oral, see Table 18, or quinine, oral, see section treatment of uncomplicated malaria in the first trimester, see treatment of severe malaria in pregnancy, all trimesters and puerperium. Evidence rating: A. Artesunate, IV oral, then ACT, oral, for 3 days, see section on treatment of severe malaria above, or quinine, IV oral, then quinine plus clindamycin combination, oral, see section on treatment of severe malaria above. D. Treatment of severe malaria in pregnancy, second and third trimesters and puerperium. Artemether, then 3 days of oral ACT, see section on treatment of severe malaria above. E. Intermittent preventive treatment in pregnancy, IPT, IPT consists of giving the fixed-dose combination medication sulfadoxine pyrimethamine, SP, in treatment doses at predefined intervals after quickening, 16 gestational weeks. Current recommendation is that IPT with sulfadoxine pyrimethamine, IPT-SP, be given to all pregnant women at each scheduled antenatal care visit, except during the first trimester. WHO recommends a schedule of 4 focused antenatal care visits for normal pregnancy. In Ghana, the National Malaria Control Strategy reserves SP for the purpose of intermittent preventive treatment only. To prevent the development of drug resistance, SP is not to be used for other purposes such as treatment of acute attacks of malaria. Sulfadoxine, 500 mg pyrimethamine, 25 mg, oral. Seasonal malaria chemoprevention, SMC, 494. Note 18 to 16 co-administered as directly observed therapy. During antenatal visits on at least 3 occasions, and at most on 7 occasions. Dose of IPT antenatal visits recommended gestational weeks. Health worker to administer IPT 1 first ANC visit after quickening 16 midwives, medical officers, family physicians, obstetricians IPT to at least 1 month after the first dose. 20 midwives, medical officers, family physicians, obstetricians, physician assistants, community health officers, community health nurses. IPT 3 at least 1 month after the second dose. 24. IPT 4-7 at least 1 month after each dose. 28, 32, 36. 40. Note 18 to 17 pregnant women with the following conditions shall be exempted from using SP. First trimester of pregnancy, 13 weeks gestation, G6PD enzyme deficiency, severe liver disease, or unexplained recurrent jaundice, known allergy to any sulfa drugs or allergy to pyrimethamine. History of previous reaction to SP. Recent treatment with a sulfa drug such as cotrimoxazole, within 4 weeks. Post-dates pregnancy, gestation beyond 36 weeks. Breastfeeding. Acute case of malaria, treat as above. Owing to antagonism between folic acid and SP, folic acid supplementation should be delayed and started 1 week after SP administration. For additional information on IPT and malaria in pregnancy, refer to the latest Ghana Health Service training manuals and guidelines on the subject. 190. Seasonal malaria chemoprevention, SMC. This is the intermittent administration of full treatment courses using the recommended anti-malarial medicine during peak malaria transmission seasons to prevent malaria illness. A complete treatment course is given to children aged between 3 and 59 months at monthly intervals to a maximum of 4 doses during the malaria transmission season. In Ghana, SMC has been implemented in the northern savannah using sulfadoxine pyrimethamine and amodiaquine, SP plus AC. Meningitis Chapter 18, Infectious Diseases and Infestations. 495. Sulfadoxine pyrimethamine, oral, and amodiaquine, oral. 191. Meningitis. This is an infection of the coverings of the brain, and is most commonly caused by bacteria, viruses, fungi, and protozoa. One type, cerebrospinal meningitis, CSM, caused by Neisseria meningitidis, is common in the northern and upper regions of Ghana, and usually occurs in epidemics during the Harmattan season. The presentation may sometimes be confused with cerebral malaria. Meningitis is a medical emergency. Failure to recognize and adequately manage meningitis results in serious complications. Inform regional or district health authorities immediately. In epidemic meningitis causes bacterial Neisseria meningitidis, Streptococcus pneumoniae, Haemophilus influenza, Mycobacterium tuberculosis, Staphylococcus aureus, Escherichia coli, neonates. Viruses, for example herpes viruses, protozoa, for example Toxoplasma and HIV/AIDS, fungi, for example Cryptococcus neoformans. Symptoms for adults and children, 5 years. Fever, neck pains, severe headaches, photophobia, change in behavior, convulsions, vomiting. Children 1 year. Fever, irritability, refusal to eat, poor sucking, vomiting, drowsiness and weak cry. Meningitis 496. focal or generalized convulsions, after which the child is sleepy. Lethargy, bulging fontanelle signs for adults and children, 5 years. Fever, neck stiffness, positive Kernig's sign, altered consciousness. Coma, children 1 year. Neck retraction, presence or absence of neck stiffness, presence or absence of fever. Bulging fontanelle, coma. Hypotonia or hypertonia, convulsion investigations. FBC, rapid diagnostic test, to exclude cerebral malaria. Blood film for malaria parasites, to exclude cerebral malaria. Lumbar puncture, only after excluding raised intracranial pressure. Blood culture and sensitivity treatment. Treatment objectives, to identify and eradicate the causative organisms, to prevent complications, to prevent spread to contacts, to maintain good nutrition. Non-pharmacological treatment. Tepid sponging, keep the airway clear. Nasogastric tube feeding, if applicable. Pharmacological treatment. A. Bacterial meningitis. First line treatment. Evidence rating A. Ceftriaxone, IVN/DEEPM, adults 2 to 4g daily for 7 to 10 days. Children, 12 years. 2 to 4g daily for 7 to 10 days. Meningitis. Chapter 18, Infectious Diseases and Infestations. 497, 12 years. 50 to 80 mg/kg for 10 to 14 days. Neonates, 20 to 50 mg/kg once daily for 21 days. And vancomycin, IV, adults 15 mg/kg 12 hourly for 7 to 10 days. Children, 12 years. 15 mg/kg 12 hourly for 7 to 10 days. 2 to 12 years. 15 mg/kg 12 hourly for 7 to 10 days. 1 month. 2 years. 15 mg/kg 8 hourly for 10 to 14 days. 1 month. Not recommended or evidence rating B. Benzylpenicillin, IV, adults formula 4 hourly for 14 days. Children 0.2 μ/kg 6 hourly for 14 days. And chloramphenicol, IV, adults 1g 6 hourly for 14 days. Children 25 mg/kg 6 hourly for 14 days. This may be subsequently changed to oral therapy with significant clinical improvement. Or chloramphenicol, oily preparation, adults 100 mg/kg as a single dose. Children 100 mg/kg as a single dose. Note 18 to 18 not recommended for children below 2 months, and also for pregnant and lactating mothers. C for penicillin allergy. Clindamycin, IV, adults 600 to 900 mg 8 hourly for 14 days. Children 13 mg/kg 8 hourly for 14 days. And chloramphenicol, IV, adults 1g 6 hourly for 14 days. Meningitis, 498. Children 25 mg/kg 6 hourly for 14 days. Second line treatment. Evidence rating B. Cefotaxime, IV, adults 2g 6 hourly for 7 days. Children 12 years or body weight 50 kilograms. 2g 6 hourly 50 kilograms. 50 mg/kg 6 hourly. And vancomycin, IV, adults 15 mg/kg 12 hourly for 7 to 10 days. Children 12 years. 15 mg/kg 12 hourly for 7 to 10 days. 2 to 12 years. 15 mg/kg 12 hourly for 7 to 10 days. 1 month. 2 years. 15 mg/kg 8 hourly for 10, 14 days. 1 month. Not recommended. D. Prophylaxis for CSM. Prophylactic treatment is recommended for patients 2 days prior to discharge, and also for their close contacts. Ciprofloxacin, oral, adults 500 mg as a single dose. Avoidant pregnancy, children 5 to 12 years. 250 mg as a single dose. Or ceftriaxone, adults 250 mg as a single dose. Children 12 years. 125 mg as a single dose. Note 18 to 19 roll of steroids. Dexamethasone started together with the first dose of the appropriate antibiotic has been found to lead to major reduction in hearing loss and death in both children and adults. Dexamethasone, IV, 4 to 10 mg 6 hourly for 5 to 7 days. Referral criteria for all patients not responding to treatment within the first 48 hours for specialist care. Worm infestation. Intestinal Chapter 18, Infectious Diseases and Infestations. 499. Table 18 to 13, Summary of Treatment Options for Bacterial Meningitis. H. Pathogens. First line empirical treatment alternatives. Specialist care. 50 years meningococcus, pneumococcus, Haemophilus influenza, ceftriaxone and vancomycin, cefotaxime, meropenem, fluoroquinolones. 50 years pneumococcus, listeria, gram-negative bacilli, ceftriaxone or ampicillin and vancomycin, fluoroquinolone. Hospital-acquired staphylococci, gram-negative bacilli, pneumococcus pseudomonas, ceftazidime plus/gentamicin, meropenem, vancomycin. 192 worm infestation, intestinal. Infestation with worms is very common. Poor hygiene or contact of bare skin with soil in which the worm or its eggs live predisposes individuals to infestation. Causes: hookworm, ascaris, strongyloides, tapeworm, threadworm, whipworm. Symptoms: general yeast itching, perianal itching, threadworm, dry cough, when the larvae pass through the lungs, wheeze, when the larvae pass through the lungs, abdominal discomfort and or pain, easy fatigability, passage of worm or worms in the stool, altered bowel habit, vomiting of worms. Signs: pallor, features of malnutrition, worm infestation, intestinal, 500. Poor physical growth in children, large distended abdomen in children, wheezing. Investigations, stool for routine examination. FBC treatment objectives: to eliminate the worms, to treat the complications of infestation, for example anemia, malnutrition, to ensure proper sanitation, non-pharmacological treatment, ensure proper nutrition, proper hand washing with soap and running water. Pharmacological treatment, see table below. Pharmacological treatment of worm infestations. Referral criteria: refer patients with intestinal obstruction from a heavy load of suspected worm infestation to a surgical specialist. Pharmacological treatment of worm infestations. Worm treatment note: evidence rating: hookworm, mebendazole, oral, adults 500 mg a single dose or 100 mg 12 hourly for 3 days. Children, 12 months 100 mg 12 hourly for 3 days. Not recommended for children below 12 months, and in pregnant women. B. Oral bendazole, oral, adults and children, 12 months 400 mg as a single dose. Children below 12 months 200 mg as a single dose. Not recommended during pregnancy. B. Worm infestation, intestinal, Chapter 18, Infectious Diseases and Infestations. 501. Pharmacological treatment of worm infestations. Worm treatment note: evidence rating: ascaris, mebendazole, oral, adults and children above 12 months. 100 mg 12 hourly for 3 days or 500 mg a single dose. Not recommended for children below 12 months, and in pregnant women. A. Oral bendazole, oral, adults and children above 12 months 400 mg as a single dose. Children below 12 months 200 mg as a single dose. Not recommended during pregnancy. A. Whipworm, mebendazole, oral, adults and children above 12 months. 100 mg 12 hourly for 3 days or 500 mg a single dose. Not recommended for children below 12 months, and in pregnant women. B. Oral bendazole, oral, adults and children above 12 months 400 mg as a single dose. Children below 12 months 200 mg as a single dose. Not recommended during pregnancy. B. Threadworm, mebendazole, oral, adults and children above 12 months. 100 mg 12 hourly for 3 days or 500 mg a single dose. Not recommended for children below 12 months, and in pregnant women. Repeat treatment after 3 weeks. C. Oral bendazole, oral, adults and children above 12 months 400 mg as a single dose. Children below 12 months 200 mg as a single dose. Not recommended during pregnancy. Repeat treatment after 3 weeks. C. Worm infestation, intestinal, 502. Pharmacological treatment of worm infestations. Worm treatment note: evidence rating: strongyloides, albendazole, oral, adults and children above 12 months 400 mg 12 hourly for 3 days. Children below 12 months 200 mg 12 hourly for 3 days or thiabendazole, oral, adults 1.5 g 12 hourly for 3 days. Children 25 mg/kg 12 hourly for 3 days. Not recommended during pregnancy. Repeat treatment after 3 weeks. Alternatively, a 7 days treatment without repeat is acceptable. Ivermectin is the drug of choice, but has the danger of precipitating life-threatening encephalopathy in microfilaria endemic areas. B. Tapeworm praziquantel, oral, adults and children. 5 to 10 mg/kg as a single dose, 25 mg/kg as a single dose for Hymenolopus nana, repeated in 10 days, or niclosamide, oral, adults and children above 6 years. 2g as a single dose, taken after a light breakfast, c. children 2 years. 500 mg as a single dose 2 to 6 years. 1g as a single dose chew tablets 2 hours before a meal. C. 19. Chapter 503. Eye disorders. 193. Neonatal conjunctivitis. See section on neonatal conjunctivitis under neonatal disorders. 194. Xerophthomia. This condition is common in children. It is associated with inadequate intake of foods that contain vitamin A. It is a common cause of blindness in children. It is important to prevent this condition by examining the eyes of all sick and malnourished children. The diet of children should include foods that contain vitamin A, dark green leafy vegetables, for example kontomire, yellow fruits and vegetables, palm oil, milk, eggs. Parents and other caregivers should be discouraged from putting any traditional preparations such as herbs, seawater, saliva, urine, etc., or drugs into the eye, unless prescribed by a physician. Causes: vitamin A deficiency resulting from protein-calorie malnutrition, measles, malabsorption states. Symptoms: poor night vision in the early stages. Signs: dry conjunctiva, gray sclera, conjunctival folding, wrinkling, keratomalacia, cloudy cornea, soft and easy ulceration. Investigations: nil. Foreign body in the eye. 504. Treatment objectives: to recognize and correct vitamin A deficiency, to prevent complications, for example blindness. Non-pharmacological treatment: high vitamin A containing foods should be encouraged. Pharmacological treatment: give vitamin A to children as soon as the illness is diagnosed, and also in patients with measles and malnutrition. Evidence rating: A. Vitamin A, oral, children immediately after diagnosis 1 to 6 years. 200,000 units 6 to 11 months. 100,000 units then, after 24 hours, 1 to 6 years. 200,000 units 6 to 11 months. 100,000 units then, after 1 week, 1 to 6 years. 200,000 units 6 to 11 months. 100,000 units. Referral criteria: refer all established cases of xerophthomia to an eye specialist, if the condition is severe with an uneven or bulging cornea. 195. Foreign body in the eye. Foreign bodies refer to specks of dust, small insects or other tiny objects that get into the eyes. The foreign body may be either in the conjunctival sac, on the cornea, or inside the eyeball, intraocular. A history of the likely nature of the foreign body aids in its detection and removal. The foreign body may be seen by careful inspection of the cornea or conjunctival sac. Adequate lighting is needed to detect corneal foreign bodies. Causes: specks of dust, small insects, ferrous metallic specks, such as occurs with metal grinders. Other tiny objects. Symptoms: feeling of something in the eye, which may be irritating, sudden discomfort or severe pain, watering of the eye, red dye or eyes. Foreign body in the eye. Chapter 19. Eye disorders. 505. Photophobia, that is intolerance to light, inability to open the eye. Signs: evidence of foreign body. Conjunctivitis, tearing of the eyes. Photophobia. Chemosis, subconjunctival hemorrhage, irregular pupil and penetrating eye injury with retained intraocular foreign body. Blood in the anterior chamber. Hyphema. Investigations: X-ray of the orbit, suspected metallic foreign body. Treatment objectives: to remove superficial foreign bodies, to treat associated injury, to prevent complications. Non-pharmacological treatment: where the foreign body is under the upper eyelid, avert the eyelid and remove the foreign body. If the foreign body cannot be removed, apply topical antibiotic, pad the eye, and refer to an eye specialist clinic. Pharmacological treatment: A. Foreign body identification. Tetracaine hydrochloride, 0.5% eye drop, instill 1 or 2 drops free, or to evaluation. B. For eye irrigation. Normal saline, 0.9%. C. Prevention of infection. First line treatment. Evidence rating: C. Chloramphenicol eye ointment, 1% topical, after removal of foreign body. D. Pain control. Paracetamol, oral, adults 500 mg 1g 6-8 hourly as required. Children 6 to 12 years. 250 to 500 mg 6 to 8 hourly as required. 1 to 5 years. 120 to 250 mg 6 to 8 hourly as required 3 months 1 year. 60 to 120 mg 6 to 8 hourly as required. Red dye. 506. Referral criteria for patients with corneal foreign bodies, intraocular foreign bodies, persistent pain and redness of the eye to the eye specialist. 196. Red eye. Red eyes are either the result of inflammation of ocular tissue, or bleeding into the subconjunctival space. The pattern of the redness, nature of the discharge, associated pain and its intensity, vision loss and appearance of the cornea are helpful in characterizing the red eye. Red eye is a potentially very serious condition, especially in situations where the redness is around the cornea. Causes: conjunctivitis, corneal ulcer or keratitis, acute anterior uveitis, inflammation of the uveal tract, acute angle closure glaucoma, episcleritis, scleritis, subconjunctival hemorrhage. Table 19:1, characterizing acute red eye with no history of injury. Diagnosis: predominant pattern of redness, nature of discharge, vision loss, corneal appearance, associated pain. Conjunctivitis: palpable, inner lining of the eyelids, watery, mucoid, mucopurulent, or purulent nil, except when cornea is involved. Clear, may show punctate epithelial stains with fluorescein in keratoconjunctivitis. Nil to mild pain. Corneal ulcer around the cornea, watery or mucopurulent, variable gray or grayish-white patch when bacterial or fungal or dendritic when herpes simplex. Severe pain. Acute anterior uveitis around the cornea, watery, variable, clear to hazy, moderately severe. Acute angle closure glaucoma around the cornea, watery, profound, uniformly hazy, very severe. Episcleritis sectorial nil or watery nil, clear, mild to severe. Scleritis sectorial nil or watery nil, except when associated with uveitis. Clear, very severe. Red dye. Chapter 19, Eye Disorders. 507. Diagnosis: predominant pattern of redness, nature of discharge, vision loss, corneal appearance, associated pain. Subconjunctival hemorrhage, sectorial nil, clear nil. Table 19:2, summary of the common types of conjunctivitis and their management. Age and background of patients. Type of discharge: predominant type of ocular discomfort. Duration treatment: bacterial, all ages, purulent nil to mild, itching or pain 1 to 2 weeks. Antibiotic eye drops. Viral, all ages, watery to mucopurulent nil to mild, itching or pain 1 to 8 weeks. Symptomatic: allergic, children and adolescents. Stringy mucoid itching. Chronic intermittent mast cell stabilizing agents. Sodium chromoglykate 2% TRACHOMA*. All ages, associated with dirty, dry, dusty and poor environment. Mucopurulent nil to mild, itching or pain 1 month to 1 year or more. Tetracycline eye ointment, azithromycin tablets. WHO grading of trichoma 1, TF. At least 5 follicles in the upper tarsal conjunctiva. Indicates active disease and need for treatment. 2, T. Intense inflammation. Need for urgent treatment. 3, DS. Scarring stage. Old infection, now inactive. 4, TT. Trichoma trichiasis. Needs surgical treatment. 5, CO. Corneal opacities. Visual loss from previous infection. Investigations: conjunctival swab for culture and sensitivity. Purulent or mucopurulent discharge. Treatment objectives: to treat the infection in the case of acute conjunctivitis, to relieve pain, and refer immediately to the specialist for urgent management, to prevent blindness in the case of corneal ulcers, acute anterior uveitis, acute angle closure glaucoma, episcleritis and scleritis. Non-pharmacological treatment: acute conjunctivitis. Wipe discharges with tissue, discard it and wash hands after each wipe. Don't share towels with others. Adults and children should avoid close contact with others, for example from glaucoma. 508. School, work, camp and swimming. Pharmacological treatment. A. For treatment of acute conjunctivitis, first line treatment. Evidence rating: C. Tetracycline 1% ointment, apply at night for 7 days, and chloramphenicol 0.5% eye drops, 1 drop 2 hourly for 48 hours, then 1 drop 6 to 8 hourly for 7 days, or ciprofloxacin 0.3% eye drops, 1 to 2 drops 6 to 12 hourly. Referral criteria for corneal ulcers, acute anterior uveitis, acute angle closure glaucoma, episcleritis and scleritis immediately to the eye specialist. Also refer acute conjunctivitis, which shows no improvement after 48 hours of treatment. 197 Glaucoma. Glaucoma is an optic neuropathy usually but not always associated with raised intraocular pressure. It is the second leading cause of preventable blindness in the world. Chronic glaucoma may produce severe loss of vision and blindness without prior warning symptoms, and must therefore be screened for in all adults beyond the age of 40 years. Acute glaucoma is however associated with very high intraocular pressures, and very severe pain and inflammation of the eye, and can lead to blindness quickly if not treated. When congenital, glaucoma causes enlargement of the eyeball associated with increased sensitivity to light and watering. Pharmacological treatment may vary from patient to patient according to local availability, affordability, and individual response to treatment. Causes: acute closure of the drainage angle, due to pupil block in primary angle closure glaucoma. Inadequate drainage of aqueous from the anterior chamber, despite open drainage angles in chronic open angle glaucoma. Neovascular membrane in the drainage angle in ischemic eye diseases such as proliferative diabetic retinopathy. Displaced lens in secondary angle closure glaucoma. Malformation of the drainage angle in congenital glaucoma. Glaucoma Chapter 19, Eye Disorders. 509. Symptoms and Signs. Table 19-3. Characteristics of the various types of the common types of glaucoma. Symptoms and signs. Chronic open angle, acute angle closure, congenital. Onset usually 40 years and above. Elderly, infants and toddlers. Symptoms nil till late, then progressive. Visual loss, sudden visual loss, severe eye pain, very inflamed eye, watery discharge, headache and vomiting sometimes. Photophobia, watering. Intraocular pressure usually high, maybe normal, very high. Cornea normal, hazy enlarged, and hazy with linear breaks. Investigations: gonioscopy, central retinal thickness measurement, visual field analysis, optic disc photography, retinal nerve fiber thickness analysis. Examination of children under anesthesia. Treatment objectives: to prevent progression of the disease and halt further deterioration of vision. To normalize intraocular pressure. Non-pharmacological treatment: drainage surgery, laser surgery, glaucoma drainage device, various other implants. Pharmacological treatment. Note 19-1. Consult an ophthalmologist on the treatment of glaucoma. First line treatment. Evidence rating: B. Treatment is with one medication from one or more of the following groups: latanoprist, eye drops, 50 micrograms/ml. Cataract 510. Bimatoprist, eye drops, 300 micrograms/ml. Travoprist, eye drops, 40 micrograms/ml and/or Timolol 0.5% eye drops. Levibunilol 0.5% eye drops. Betaxolol 0.5% eye drops and/or Brimonidine 1 mg/ml or 1.5 mg/ml and/or acetazolamide oral 250 mg. Brinzolamide eye drops 10 mg/ml. Dorzolamide eye drops 20 mg/ml and/or pilocarpine 1.4% eye drops. Referral criteria: refer all suspected cases of glaucoma to the ophthalmologist for assessment and initial treatment. 198. Cataract. It is the opacity of the crystalline lens of the eye. It is the leading cause of blindness worldwide. Causes: old age, trauma to the eye, inflammation within the eye, metabolic conditions such as diabetes mellitus. Congenital symptoms: variable disturbance of vision, sometimes worse when sunny or reading. Glare, especially at night during driving. Monocular double vision in the affected eye. Change in refractive status: more short-sighted, myopic shift. More long-sighted, hypermetropic shift. White spot in the eye. Children. Signs: lens opacity, reduced visual acuity, reduced contrast sensitivity. Exposure: keratopathy. Chapter 19, Eye Disorders. 511. Investigations. Fasting blood sugar. FBC treatment. Treatment objectives. To improve vision. To prevent the development of amblyopia in the child. Non-pharmacological treatment. Use of spectacles. Surgical removal of cataract. Pharmacological treatment. Nil referral criteria. Refer all cases to the eye specialist. 199. Exposure keratopathy. Exposure keratopathy is the drying of the cornea as a result of inability to close the eyelids or blink adequately. If not detected and treated, can result in corneal ulceration and perforation leading to blindness. Causes: facial nerve palsy, for example Bell's palsy or leprosy, scarring of the eyelids, coma, thyroid eye disease, Parkinson's disease, proptosis, Stevens-Johnson syndrome. Symptoms: feeling of drying of the eye, foreign body sensations in the eye, photophobia, blurring of vision signs, logophthalmos, inability to close the eyes, incomplete blink, the upper eyelid does not cover the whole cornea during blink, infrequent blink, superficial punctate stains on the cornea, large coalescent corneal epithelial defect, corneal ulceration, corneal perforation, strabismus, 512. Investigations. Nil treatment. Treatment objectives. To moisten the cornea artificially to prevent the complications of dry eyes. Non-pharmacological treatment. Taping the eyelids closed in the comatose patient. Partial dorsorrhaphy. Education of patients with Parkinson's or thyroid eye disease to blink frequently voluntarily, rather than rely on reflex blink. Pharmacological treatment. First-line treatment evidence rating. C. Hydroxymethylcellulose, 0.3% eye drops, 1 to 2 hourly during waking time. Second-line treatment evidence rating. C. Polyvinyl alcohol, 1.4-2% eye drops, 1 to 2 hourly during waking time. And chloramphenicol, 1% eye ointment, at night before bedtime. Or tetracycline, 1% eye ointment, at bedtime. Referral criteria. Refer patients whose exposure keratopathy is not improving to the eye specialist. 200. Strabismus. Strabismus is misalignment usually of one eye preventing simultaneous viewing of an object by both eyes. Onset in children under 7 years interferes with the development of the visual system of the deviating eye in the brain leading to amblyopia. Acute onset at an older age causes double vision. Diplopia does not occur in children because of the ability to suppress the second image or development of amblyopia. Amblyopia does not occur if the deviation alternated from one eye to the other. The more frequent types are horizontal misalignment. Esotropia is convergent deviation and exotropia is divergent deviation. Causes: congenital misalignment, acquired deviation, paralysis of the cranial nerve E3 or IV, sickle cell disease, retinopathy. Chapter 19, Eye Disorders. 513. Fibrosis in an extraocular muscle. Myasthenia gravis. Intraocular lesion, for example retinoblastoma and macular scar. Symptoms: misalignment of the eye, impaired judgment of depth or distance, diplopia or double vision signs, deviation of the corneal light reflex in one eye from a central position, movement of the deviating eye to take up fixation when the fixing eye is covered, normal extraocular eye movement in non-paralytic strabismus, limitation of eye movement in paralytic or restrictive strabismus, hypermetropia on refraction in children, retinal lesion, for example retinoblastoma. Investigations: cycloplegic refraction in children. Other specific tests for suspected causes, for example myasthenia gravis or retinoblastoma. Treatment objectives: to identify and correct any significant refractive error, to treat any amblyopia, to relieve any diplopia, to correct the misalignment, to treat any underlying condition. Non-pharmacological treatment: spectacle correction of any refractive error, treatment of amblyopia in the deviating eye by patching the non-deviating eye, use of prisms to correct small deviations, patching of the deviating eye to relieve diplopia in older patients. Pharmacological treatment. Nil referral criteria. All patients diagnosed with strabismus must be referred to the eye specialist for further management. 201. Sickle cell disease, retinopathy. Symptoms: sudden loss of vision especially in sickle cell SC patients. Endocrine and metabolic disorders with eye complications. 514. Referral criteria. All sickle cell SC patients 12 years and above should be referred to the eye specialist for screening for proliferative sickle cell retinopathy. Refer all sickle cell patients with eye complications to the eye specialist. 202. Endocrine and metabolic disorders with eye complications. Referral criteria. Patients with persistently poor blood glucose control, poor blood pressure control, frequent diabetes-related admissions, visual impairment, cataract or any retinal changes, foot ulcers or gangrene, persistent proteinuria, or other chronic complications of diabetes should be referred to the eye specialist. 20. Chapter 515. Ear, nose and throat disorders. 203. Stridor. Stridor is an emergency condition. It has a characteristic noise in the inspiratory phase of breathing. This occurs when there is an obstruction of the upper airway from the nasopharynx down to the trachea and main bronchi. The obstruction is usually in the subglottic area. It is commonly a viral illness, and may be preceded usually by the common cold. Measles may also be complicated by laryngotrachea bronchitis, LTB. Two important causes of stridor in children are viral croup, LTB, and acute epiglottitis. In the management of stridor, steroids are most useful when given within 6 hours of onset of symptoms. Cough syrups containing opiates and atropine are contraindicated. Stridor in children causes viral, laryngotrachea bronchitis, bacterial infection, acute epiglottitis, inflammatory obstruction, inhalation of hot fumes, for example in fire outbreaks, angionephrotic edema, retropharyngeal abscess, inhalation of a foreign body, congenital malformation of the larynx, for example laryngomalacia symptoms, low-grade fever, hoarse voice, barking cough, breathing difficulty, restlessness signs. Stridor. 516. Low-grade fever. Restless apprehensive child, when obstruction is severe. Hoarse voice, barking cough, labored breathing, for example suprasternal, supraclavicular, substernal and intercostal retractions. Tachypnea, cyanosis and severe obstruction. Red in throat investigations. Sputum culture. Lateral soft tissue X-ray of neck, chest X-ray treatment. Treatment objectives: to avoid aggravation of the obstruction with thick or crusted secretions. To ensure early and timely relief of obstruction. Non-pharmacological treatment: ensuring good hydration including liberal oral fluids. Ensure maximum rest for the child. Establish the airway by intubation or tracheostomy in severe obstruction. Pharmacological treatment: A. For hydration of very sick patients who cannot drink. First-line treatment. Evidence rating: C. Dextrosaline, IV, 5%. B. For restless and distressed children who require oxygen. Oxygen, 1 to 6 L as required, based on oxygen saturation level. C. For steroid therapy. Dexamethasone, oral/M/IV. Children 0.6 mg/kg stat, or budesonide, nebulized. Children 2 mg stat, or prednisolone, oral. Children 1 to 2 mg/kg stat, or stridor. Chapter 20. Ear, nose and throat disorders. 517. Hydrocortisone, IV. Children 4 mg/kg 6 hourly for 2 to 3 days. Note 20:1. Steroids are most useful when given within 6 hours of onset of symptoms. Antibiotics should be given in suspected secondary bacterial infection. Cough syrups containing opiates and atropine are contraindicated. D. In superimposed bacterial infection. First-line treatment. Evidence rating: C. Cloxacillin, IV. Children 5 to 12 years. 250 mg 6 hourly for 7 days 1 to 5 years. 125 mg 6 hourly for 7 days 1 year. 62.5 mg 6 hourly for 7 days. And gentamicin, IV. Children 1 to 12 years. 2.5 mg/kg 8 hourly for 7 days 1 year. 2.5 mg/kg 12 hourly for 7 days. And metronidazole, IV. Children 7.5 mg/kg 8 hourly for 7 days. Second-line treatment. Evidence rating: C. Cefuroxime, IV. Children 20 mg/kg 8 hourly. And metronidazole, IV. Children 7.5 mg/kg 8 hourly for 7 days. E. For severe croup. Adrenaline, 1:1000 solution, nebulized, 2 ml stat. Then repeat hourly, if effective. Stridor in adults causes inflammatory obstruction, acute epiglottitis, laryngeal tumor, vocal cord paralysis. Stridor. 518. Retropharyngeal abscess. Inhalation of a foreign body. Symptoms: hoarse voice, breathing difficulty, restlessness signs, stridor, labored breathing, tachypnea, cyanosis and severe obstruction. Investigations: lateral soft tissue X-ray of neck, chest X-ray. Treatment objectives: to ensure early and timely relief of obstruction. Non-pharmacological treatment: establish the airway by intubation or tracheostomy in severe obstruction. Pharmacological treatment: first-line treatment. Evidence rating: CA. For oxygen therapy: oxygen 1 to 6 L as required, based on oxygen saturation level. B. For steroid therapy: hydrocortisone, IV. Adults 100 mg 6 hourly for 2 to 3 days. C. For superimposed bacterial infection: first-line treatment. Evidence rating: C. Amoxicillin plus clavulanic acid, IV. Adults 600 mg 8 hourly or 1.2 g 12 hourly and metronidazole, IV. Adults 500 mg 8 hourly for 7 days. Acute epiglottitis - Chapter 20, Ear, Nose and Throat Disorders. 519. Second-line treatment. Evidence rating: C. Cefuroxime, IV. Adults 750 mg 8 hourly and metronidazole, IV. Adults 500 mg 8 hourly for 7 days. Referral criteria: refer cases with severe obstruction and complications in children to a pediatrician or an specialist. Also refer all cases of stridor, if there is no expertise, to intubate or perform tracheostomy to a specialist. 204. Acute epiglottitis. This is an acute and life-threatening infection in which the epiglottis and surrounding tissue become acutely inflamed, and oedematous, causing severe obstruction of the upper airways. The disease tends to run an extremely rapid course, 4 to 6 hours, to respiratory failure and death. It is more common in children. However, the incidence has reduced significantly due to the current immunization schedule with the pentavalent vaccine. Examination of the throat in patients with this condition must be done only in the presence of a doctor capable and ready to intubate. Causes: Haemophilus influenzae type B, Streptococcus pyogenes, Streptococcus pneumoniae, Staphylococcus aureus. Symptoms: sudden onset of high fever, drooling of saliva, dysphagia, breathing difficulty. Signs: extremely ill and toxic child. Fever. Head is held forward to extend the neck. Breathing difficulty. Weak voice, not hoarse. Reduced air entry on auscultation. Stridor. Acute epiglottitis - 520. Cyanosis in very sick children. Swollen and reddened epiglottis. Investigations: FBC. Blood culture. Lateral soft tissue X-ray of the neck. Treatment objectives: to relieve obstruction, to treat bacteremia. Non-pharmacological treatment: establishment with airway, if necessary by intubation or tracheostomy. Pharmacological treatment: A. For treatment of bacterial infection. First-line treatment. Evidence rating: B. Cefuroxime, IV. Adults 750 mg 1.5 g 8 hourly for 7 days. Children 25 mg/kg 8 hourly for 7 days and metronidazole, IV. Adults 500 mg 8 hourly for 7 days. Children 7.5 mg/kg 6 hourly for 7 days. Second-line treatment. Evidence rating: B. Cefotaxime, IV. Adults 1 to 2 g IV or 8 hourly for 7 days. Children 50 mg/kg 8 hourly for 7 days or amoxicillin plus clavulanic acid, IV. Adults 1.2 g 12 hourly, increased to 1.2 g 8 hourly for 7 days. In severe infections, children 12 to 18 years. 600 mg to 1.2 g 12 hourly, increased to 1.2 g 8 hourly for 7 days. In severe infections, 3 months 12 years. 30 mg/kg 12 hourly, increased to 30 mg/kg 8 hourly for 7 days. In severe infections. Retropharyngeal abscess - Chapter 20, Ear, Nose and Throat Disorders. 521. 7 days 3 months. 30 mg/kg 8 hourly for 7 days per term and 7 days. 30 mg/kg 12 hourly for 7 days. Note 22. Treatment should be changed to oral antibiotics when appropriate and continuity for a total of 7 days. Referral criteria: refer all patients immediately to a specialist if there is no expertise available for intubation or tracheostomy. 205. Retropharyngeal abscess. This emergency condition refers to collection of pus in the retropharyngeal space. Early diagnosis and treatment will prevent mortality. Causes: group A. Hemolytic streptococcus, Staphylococcus aureus, osteomyelitis of cervical vertebrae from tuberculosis symptoms, fever, sore throat, difficulty in swallowing, hyperextension of neck, labored and noisy breathing signs, fever, reddened throat, large and inflamed tonsils, labored respiration with intercostal retractions, stridor, bulge in the posterior pharyngeal wall investigations, FBC, throat swab for culture and sensitivity testing, Ziehl-Neelsen stain to exclude tuberculosis, lateral soft tissue X-ray of neck, chest X-ray to exclude tuberculosis treatment objectives, to treat infection, to relieve the obstruction by draining the abscess, to relieve pain, retropharyngeal abscess, 522. Non-pharmacological treatment. Incision and drainage of pus under general anesthesia. Pharmacological treatment. A. For pain relief. First-line treatment. Evidence rating. B. Paracetamol. Oral. Adults 500 mg 1g 4 to 6 hourly. Children 6 to 12 years. 250 to 500 mg 4 to 6 hourly. 1 to 5 years. 120 to 250 mg 4 to 6 hourly. 3 months 1 year. 60 to 120 mg 4 to 6 hourly. B. For treatment of infection. First line treatment. Evidence rating. B. Cefuroxime. IV. Adults 750 mg 1.5g 8 hourly for 72 hours. Children 25 mg/kg 8 hourly for 72 hours. And metronidazole. IV. Adults 500 mg 8 hourly for 72 hours. Children 7.5 mg/kg 8 hourly for 72 hours. Then cefuroxime. Oral. Adults 500 mg 12 hourly for 7 days. Children 12 to 18 years. 250 mg 12 hourly for 7 days. 2 to 12 years. 15 mg/kg. Maximum 250 mg 12 hourly for 7 days. 3 months 2 years. 10 mg/kg, maximum 125 mg, 12 hourly for 7 days. And metronidazole. Oral. Adults 400 mg 8 hourly for 7 days. Children 7.5 mg/kg 8 hourly for 7 days. Second line treatment. Evidence rating. B. Pharyngitis and tonsillitis. Chapter 20, Ear, Nose and Throat Disorders. 523. Flucloxacillin, IV. Adults 500 mg 6 hourly for 72 hours. Children 50 to 100 mg/kg 6 hourly for 72 hours. And metronidazole, IV. Adults 500 mg 8 hourly for 72 hours. Children 7.5 mg/kg 8 hourly for 72 hours. Then metronidazole. Oral. Adults 400 mg 8 hourly for 7 days. Children 7.5 mg/kg 8 hourly for 7 days. And flucloxacillin. Oral. Adults 500 mg 6 hourly for 7 days. If patient is able to swallow. Children 50 mg/kg 6 hourly for 7 days. If patient is able to swallow. Referral criteria. Refer all cases to the ENT specialist. 206. Pharyngitis and tonsillitis. This is an infection of the throat and tonsils. Most sore throats are due to viral infections, and should not be treated with antibiotics as they subside within 3 to 5 days. However, it is important to diagnose streptococcal pharyngitis, since it may give rise to abscesses in the throat, retropharyngeal and paratonsillar abscess, as well as complications that involve organs like the kidneys and the heart. Streptococcal throat infections require treatment with antibiotics, in order to reduce the complications noted above. Causes: viruses, hemolytic streptococcus, Haemophilus influenza, other gram-positive bacterial symptoms, fever, difficulty in swallowing, sore throat, pharyngitis, and tonsillitis. 524. Runny nose, cough signs, reddened throat, enlarged and reddened tonsils, sustained high-grade fever, palpable tonsillar lymph glands, streptococcal pharyngitis. Runny nose suggests viral cough. Suggests viral. Red eyes suggests viral. Whitish exudate at the back of the throat as well as whitish tonsillar exudate. Scarlet fever rash. Investigations. FBC. Monospot test. Throat swab for culture and sensitivity treatment. Treatment objectives: to relieve symptoms, to recognize and treat streptococcal throat infection, to relieve pain. Non-pharmacological treatment. Warm, salty water gargles. Pharmacological treatment. A. For pain relief. First line treatment. evidence rating, A. Paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months 1 year. 60 to 120 mg 6 to 8 hourly or ibuprofen, oral, adults 200 to 400 mg 8 hourly, children 7 to 12 year. July 5, 10 mg/kg 6 to 8 hourly, maximum 30 mg/kg or 600 mg per day, 4 to 7 years. July 5, 10 mg/kg 8 hourly, maximum 30 mg/kg or 450 mg per day. Pharyngitis and tonsillitis. Chapter 20, Ear, Nose and Throat Disorders. 525b. For treating the infection, first-line treatment evidence rating, A. Amoxicillin, oral, adults 500 mg 8 hourly for 10 days, children 6 to 12 years. 250 mg 8 hourly for 10 days, 1 to 5 years. 125 mg 8 hourly for 10 days, 1 year. 62.5 mg 8 hourly for 10 days or amoxicillin plus clavulanic acid, oral, adults 1 gram 12 hourly for 10 days, children 12 years. 1 500 over 125 mg strength tablet, 12 hourly for 10 days, 6 to 12 years. 5 milliliters of 400 over 57 mg suspension, 12 hourly. 5 milliliters of 250 over 62 mg suspension, 8 hourly for 10 days, dose doubled in severe infection, 1 to 6 years. 5 milliliters of 200 over 28.5 mg suspension, 12 hourly for 10 days, dose doubled in severe infection, 1 month, 1 year. 2.5 milliliters of 200 over 28.5 mg suspension, 12 hourly for 10 days, dose doubled in severe infection, unit. 2.5 milliliters of 200 over 28.5 mg suspension, 12 hourly for 10 days, dose doubled in severe infection or amoxicillin plus clavulanic acid, IV, adults 600 mg 1.2 g 12 hourly for 10 days, children 1 to 12 years. 15 mg/kg 12 hourly for 10 days or crystalline penicillin, IV, adults 2 to 4 mu 6 hourly for 10 days, children 12 years. 2 to 4 mu 6 hourly for 10 days, 1 to 12 years. 0.6-1.2 mu, 25 mg/kg, 6 hourly for 10 days. Note 20-3. Do not give cotrimoxazole for acute streptococcal throat infections. Acute sinusitis. 526. Second-line treatment evidence rating, B. Cefuroxime, oral, adult 250 mg 12 hourly for 10 days, children 12 years. 250 mg 12 hourly for 10 days, 3 months, 12 years. 10 mg/kg 12 hourly for 10 days or cefuroxime, IV, adult 750 mg 8 hourly for 10 days, children 12 years. 750 mg 8 hourly for 10 days, 3 months, 12 years. 25 to 50 mg/kg 8 hourly for 10 days. C. For treating the infection in patients allergic to penicillin, erythromycin, oral, adults 500 mg 6 hourly for 10 days, children 2 to 8 years. 250 mg 6 hourly for 10 days, 1 month, 2 years. 125 mg 6 hourly for 10 days, units. 12.5 mg/kg 6 hourly or azithromycin, oral, adults 500 mg daily for 3 days, children 6 months. 10 mg/kg daily for 3 days. Referral criteria: refer patients with recurrent tonsillitis, retropharyngeal and peritonsillar abscess to an ENT specialist. 207. Acute sinusitis. This is an acute infection of the paranasal sinuses. It may lead to complications with attendant morbidity and mortality. Early recognition of this clinical condition is mandatory. Swimming in dirty waters, dental infection or dental extraction, fractures involving the sinuses, nasal obstruction from polyps and allergic rhinitis are predisposing factors to developing acute sinusitis. Causes: viral, common cold, bacterial, group A hemolytic streptococci, acute sinusitis. Chapter 20, Ear, Nose and Throat Disorders. 527. S. Pneumonia, S. aureus, H. influenza, M. catarrhulus, allergy symptoms, cough, nasal congestion, pressure in the face and head, frontal headaches, postnasal drip signs, yellow or green thick nasal discharge, which may be foul-smelling, halitosis, persistent fever, tenderness above and below the eyes, when patient bends over, or when these areas are tapped lightly. Investigations, FBC, X-ray of paranasal sinuses. Treatment objectives: to reduce symptoms of pain and fever, to eradicate infection, to encourage drainage of sinuses. Non-pharmacological treatment: adequate hydration, steam inhalation, tooth extraction under antibiotic cover, if dental focus of infection is present. Pharmacological treatment: A. For treatment of bacterial infection. First-line treatment. Evidence rating: B. Amoxicillin, oral, adults 500 mg 8 hourly for 10 days, children 6 to 12 years. 250 mg 8 hourly for 10 days, 1 to 5 years. 125 mg 8 hourly for 10 days, 1 year. 62.5 mg 8 hourly for 10 days or amoxicillin plus clavulanic acid, oral. Acute sinusitis - 528. Adults 1g 12 hourly for 7 days, children is greater than 12 years, 1/500 over 125 mg tablet 12 hourly for 10 days, 6 to 12 years. 5 milliliters of 400 over 57 mg suspension 12 hourly for 10 days, 1 to 6 years. 5 milliliters of 200 over 28.5 mg suspension 12 hourly for 10 days, 1 month, 1 year. 2.5 milliliters of 200 over 28.5 mg suspension 12 hourly, dose doubled in severe infection 2 weeks, 1 month. 1.25 milliliters of 200 over 28.5 mg suspension 12 hourly, dose doubled in severe infection. Second-line treatment. Evidence rating: B. Cefuroxime, oral, adults 250 to 500 mg 12 hourly for 5-7 days, children 3 months, 12 years. 125 mg 12 hourly, double in severe infection. B. For treatment of bacterial infection in patients with penicillin allergy. Erythromycin, oral, adults 500 mg 6 hourly for 10 days, children 2 to 8 years. 250 mg 6 hourly for 10 days, 1 month, 2 years. 125 mg 6 hourly for 10 days, neonate. 12.5 mg/kg 6 hourly or azithromycin, oral, adults 500 mg daily for 5 days, children 10 mg/kg daily for 5 days. C. For pain relief. Paracetamol, oral, to relieve pain if present, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months, 1 year. 60 to 120 mg 6 to 8 hourly. D. For nasal decongestion. Ephedrine nasal drops, adults 1%. Acute otitis media - Chapter 20, Ear, Nose and Throat Disorders. 529. 1 to 2 drops into each nostril up to 4 times daily when required, children 0.5%. 1 to 2 drops into each nostril up to 4 times daily when required, or neomycin 0.5%/hydrocortisone 1.5%. Nasal drops, adults 2 drops 12 hourly, children 1 drop 12 hourly. Referral criteria for all cases, which do not improve after 1 week of treatment, to the ENT specialist. 208. Acute otitis media. This is an infection of the middle ear, which communicates with the throat. It is important in a febrile child to look for it and treat it. Untreated or poorly managed cases may lead to complications such as mastoiditis, chronic otitis media, deafness, meningitis, and brain abscess. Precursors to the bacteria infections are viral upper respiratory tract infections. Causes: Haemophilus influenzae, hemolytic streptococcus, Streptococcus pneumoniae, Staphylococcus aureus. Symptoms: fever, sudden and persistent earache, purulent discharge from the ear, vomiting, diarrhea, crying and agitation, impaired hearing signs, red eardrum, discharging ear, occasionally inflamed throat, perforated eardrum. Investigations: FBC, ear swab for culture and sensitivity. Acute otitis media 530. Treatment objectives: to relieve symptoms, to ensure prompt and adequate antibiotic therapy, to prevent chronicity and other complications, non-pharmacological treatment, adequate hydration, surgical repair and drainage of abscess, pharmacological treatment. A. For pain relief, first-line treatment, evidence rating. B. Paracetamol, oral, adults 500 mg 1g 6 to 8 hourly, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly, 1 to 5 years. 120 to 250 mg 6 to 8 hourly, 3 months 1 year. 60 to 120 mg 6 to 8 hourly. B. For treatment of infection, first line treatment, evidence rating. B. Amoxicillin, oral, adults 500 mg 8 hourly for 10 days, children 6 to 12 years. 250 mg 8 hourly for 10 days, 1 to 5 years. 125 mg 8 hourly for 10 days, 1 year. 62.5 mg 8 hourly for 10 days, or amoxicillin plus clavulanic acid, oral, adults 1g 12 hourly for 7 days, children 12 years. 500 over 125 mg tablet 12 hourly for 10 days, 6 to 12 years. 5 milliliters of 400/57 mg suspension 12 hourly for 10 days, 1 to 6 years. 5 milliliters of 200 over 28.5 mg suspension 12 hourly for 10 days, 1 month, 1 year. 2.5 milliliters of 200 over 28.5 mg suspension 12 hourly, dose doubled in severe infection 2 weeks, 1 month. 1.25 milliliters of 200 over 28.5 mg suspension 12 hourly, dose doubled in severe infections. Chronic otitis media. Chapter 20, Ear, Nose and Throat Disorders. 531. Second-line treatment, evidence rating. B. Cefuroxime, oral, adults 250 mg 12 hourly for 5 days, children 125 mg 12 hourly for 5 days. C. For treatment of infection in patients with penicillin allergy, erythromycin, oral, adults 250, 500 mg 6 hourly for 10 days, children 2 to 8 years. 250 mg 6 hourly for 10 days, 1 month, 2 years. 125 mg 6 hourly for 10 days, neonate. 12.5 mg/kg 6 hourly, or azithromycin, oral, adults 500 mg once daily for 5 days, children 10 mg/kg once daily for 5 days. Referral criteria: refer patient to ENT specialist if there is no response after 10 days of treatment. 209. Chronic otitis media. This is a chronic infection of the middle ear with perforation of the tympanic membrane and pus discharging from the ear for more than 2 weeks. Causes: secondary bacterial infections, Pseudomonas aeruginosa, Proteus vulgaris, pneumococci. Symptoms: chronic ear discharge, atorhia, hearing loss. Signs: perforation of tympanic membrane, conductive hearing loss, ear discharge, epistaxis. 532. Investigations: ear swab for culture and sensitivity. Treatment objectives: to keep the ear dry, to treat any acute exacerbations and complications, for example mastoiditis. Non-pharmacological treatment: roll a piece of clean absorbent gauze into a wick, and insert carefully into the ear. Leave for 1 minute, then remove, and replace with a clean wick. Do frequently, at least 4 times a day. If bleeding occurs, drying the ear should be stopped temporarily. Nothing should be left in the ear between wicking. Avoid swimming or getting the inside of the ear wet. Reassess weekly to ensure that the mother is drying the ear correctly. Pharmacological treatment: A. For acute exacerbations, see section on treatment for acute otitis media. B. For topical antibiotic therapy. Evidence rating: B. Gentamicin ear drops, 0.3%, 2 to 3 drops 6 to 8 hourly and at night, or ciprofloxacin eye/ear drops, 0.3%, 1 drop 6 hourly daily. Referral criteria: refer all chronically discharging ears to the ENT specialist. 210. Epistaxis. Epistaxis, also called nosebleeds, is a common medical emergency, which requires prompt management to avoid morbidity and mortality. Causes: picking of the nose, especially when there is an upper respiratory tract infection, trauma, sinonasal and nasopharyngeal neoplasms, hypertension, bleeding disorders, atrophic rhinitis. Symptoms: nosebleed. Signs: nosebleed, epistaxis, Chapter 20, Ear, Nose and Throat Disorders. 533. Signs related to underlying cause. Signs of shock, if severe. Investigations. FBC. Sickling test. Coagulation screen. Liver function test. Retroviral screen, if indicated. Treatment objectives. To stop epistaxis. To prevent recurrence. To detect shock, and replace blood, if necessary. Non-pharmacological treatment. Sit patient up, and flex head to prevent blood running down throat and airway. Pinch soft part of nose for 10 minutes. Patient must breathe through mouth. Apply ice pack to nasal bridge. Pharmacological treatment. A. For hemostasis. First line treatment. Oxymetazoline, nasal spray, 2 to 3 sprays per nostril 12 hourly, or adrenaline, topical, as nose pack, on cotton wool. 1:1000 solutions. Referral criteria. Refer patients with recurrent or severe epistaxis to the end specialist. 21. Chapter 534. Oral and dental conditions. 211. Dental caries. Dental caries is a tooth surface cavity caused by acid demineralization of tooth hard tissue. It occurs as a result of bacterial conversion of refined carbohydrates to acids, which in prolonged contact with tooth surface leads to the demineralization. This process is entirely preventable, but can progress to severe decay and tooth loss, or complicated by infection. Causes. Acid demineralization of hard tooth surface. Symptoms. Usually asymptomatic. Tooth ash precipitated by hot, cold or sweet foods or drinks. Pain may be intermittent or severe, sharp and constant, if the nerve endings are exposed. Signs. A hole or black spot may be visible on any surface of a tooth. Tenderness on percussion of the affected tooth. Treatment objectives. To relieve pain. To arrest process by excavation and filling of cavities. To educate on good dental habits. To prevent complications. Non-pharmacological treatment. Regular mouth rinse, after refined carbohydrate intake. Brushing of teeth before bedtime. Pharmacological treatment. A. For pain relief. Evidence rating. C. Paracetamol. Oral. Oral candidiasis. Chapter 21, Oral and Dental Conditions. 535. Adults 500 mg 1g 6 to 8 hourly. Children 6 to 12 years. 250 to 500 mg 6 to 8 hourly. 1 to 5 years. 120 to 250 mg 6 to 8 hourly, or ibuprofen, oral. Adults 200 to 400 mg 8 hourly. Children 4 to 7 years. 150 mg 8 hourly, maximum July 5th 10 mg/kg daily. 6 to 8 hourly, 7 to 12 year. 200 mg 8 hourly, maximum July 5th 10 mg/kg daily. 6 to 8 hourly. Referral criteria. Refer patient to a dentist for definitive treatment. 212. Oral candidiasis. Oral candidiasis, oral thrush, is an infection of the mouth by yeast. It mainly affects the very young, the very old, or those whose immunity is impaired. It occurs more frequently in HIV/AIDS patients, the malnourished, diabetics, patients on long-term antibiotics and corticosteroids, and those with poor oral hygiene. Causes. Candida albicans, Manila. Symptoms. White patches in the mouth, burning sensation in the mouth, difficulty in swallowing. Breastfed babies may refuse to suck. Sore mouth signs. Well-defined white or cream-colored pustules and patches in the mouth. Investigations. Buccal mucosal scraping for fungal elements. FBS. Retroscreen treatment objectives. To eradicate infection. To identify and treat any underlying condition. Acute necrotizing, ulcerative gingivitis. 536. Non-pharmacological treatment. Proper oral hygiene and toileting. Pharmacological treatment. A. For treatment with uncomplicated oral candidiasis. First-line treatment. Evidence rating. B. Nystatin suspension, oral. Adults 100,000 units 6 hourly after food for 14 days. Children 100,000 units 6 hourly after each feed for at least 10 days. Make sure it is spread well in the mouth. Second-line treatment. Meconazole, oral gel. Adults and children 2.5 milliliters smeared on the oral mucosa twice daily for 7 to 10 days. B. For immunocompromised patients with oral candidiasis. Evidence rating. B. Fluconazole, oral. Adults 50 to 100 mg daily for 7 to 14 days. Children 12 to 18 years. 50 to 100 mg daily for 7 to 14 days. 14 days 12 years. 3 to 6 mg/kg on first day, then 3 mg/kg, maximum 100 mg, daily for 14 days 7 to 14 days. 3 to 6 mg/kg on first day, then 3 mg/kg every 48 hours for 14 days 7 days. 3 to 6 mg/kg on first day, then 3 mg/kg every 72 hours for 14 days. Referral criteria: refer patients not responding to above treatment, or if there is the presence of an underlying illness, for example diabetes mellitus, immunosuppression, to appropriate specialist. 213 Acute necrotizing ulcerative gingivitis. It is a specific gum disease affecting mainly the interdental papillae and gum margin. It affects usually healthy young adults with poor oral hygiene. Acute necrotizing ulcerative gingivitis - Chapter 21, Oral and Dental Conditions. 537 Causes: spirochetes, gram-negative fusiforms. Host factors of poor oral hygiene: cigarette smoking and immune suppression. Symptoms: gum margin soreness or pain of sudden onset, bleeding, malaise, bad taste and foul breath. Signs: crater-like ulcers and necrosis mainly limited to gum margin and interdental gingiva. Poor oral hygiene: fever, lymph node enlargement. Investigations: swab for culture and sensitivity. Treatment objectives: to eradicate bacterial overgrowth, to establish good oral hygiene, to control fever and pain. Non-pharmacological treatment: improve oral hygiene habits, for example brushing at least 2 times daily, frequent antiseptic oral rinse. Pharmacological treatment: A. For treatment of infection. First-line treatment. Evidence rating: B. Amoxicillin, oral, adult 1g stat, then 500 mg 6 hourly for 7 days. Children 7 to 10 years. 250 mg 6 hourly for 7 days 3 to 7 years. 125 mg 6 hourly for 7 days 1 to 3 years. 62.5 mg 6 hourly for 7 days. B. For individuals with penicillin allergy. Evidence rating: C. Clindamycin, oral, bacterial endocarditis and prophylaxis. In dentistry - 538 adults 150 to 300 mg 6 to 8 hourly for 7 days. Children 12 to 18 years. 150 to 300 mg 6 hourly for 7 days 1 month 11 years. 3 to 6 mg/kg 6 hourly for 7 days. C. For pain and fever control. Paracetamol, oral, adults 500 mg 1g 6 hourly as required. Children 6 to 12 years. 250 to 500 mg 6 hourly as required 1 to 5 years. 125 to 250 mg 6 hourly as required 3 months 1 year. 62.5-125 mg 6 hourly as required. Referral criteria for all patients after initiating therapy to a dentist. 214 Bacterial endocarditis and prophylaxis. In dentistry, antibiotic prophylaxis is an established requirement in the management of patients with cardiac-related diseases at risk of bacterial endocarditis in the course of dental manipulation. Predisposing risk factors include previous history of bacterial endocarditis, history of heart valve disease and a history of heart valve replacement. Causes: Streptococcus sanguis, Streptococcus mitis, Streptococcus mutans, Streptococcus salivarius. Other oral bacterial flora. Treatment objectives: to prevent seeding of oral bacteria during the transient bacteremic phase during dental manipulation and to enter cardiac defects and valvular lesions. Pharmacological treatment. First-line treatment. Evidence rating: B. Amoxicillin, oral, adults 2g stat, 2 hours before procedure. Children 50 mg/kg stat, 2 hours before procedure. Acute bacterial silodonitis - Chapter 21, Oral and Dental Conditions. 539 or clindamycin, oral, adults 600 mg stat, 1 hour before procedure. Children 20 mg/kg stat, 1 hour before procedure. Referral criteria: refer to a cardiologist if cardiac status cannot be ascertained or history is not clear. 215 Acute bacterial silodonitis. Bacterial infection usually of the parotid glands. It is mostly unilateral. Seen exclusively in debilitated, elderly, dehydrated patients or who have drug or disease-induced xerostomia. Causes: Staphylococcus aureus and anaerobes streptococcus. Occasionally, symptoms: painful parotid swelling of sudden onset, fever, chills. Signs: erythematous swelling, tense and shiny overlying skin, purulent discharge from duct. Investigations: FBC, culture and sensitivity of discharge. Treatment objectives: to treat infection, to provide pain relief. Non-pharmacological treatment: encourage bed rest, adequate fluid intake, discontinue medications that can cause xerostomia, surgical drainage if indicated. Ludwig's angina/cervicofacial abscess. 540. Pharmacological treatment. A. For treatment of infection. First line treatment. Evidence rating: B. Flucloxacillin, oral, adults 500 mg 6 hourly for 7 to 10 days. Children 5 to 12 years. 250 mg 6 hourly for 7 to 10 days. 1 to 5 years. 125 mg 6 hourly for 7 to 10 days. 1 year. 62.5 mg 6 hourly for 7 to 10 days. B. For treatment of infection in patients with penicillin allergy. Evidence rating: C. Clindamycin, oral, adults 150 to 300 mg 6 to 8 hourly for 7 days. Children 12 to 18 years. 150 to 300 mg 6 hourly for 7 days. 1 month. 11 years. 3 to 6 mg/kg 6 hourly for 7 days. C. For pain relief: paracetamol, oral, adults 500 mg 1g 6 hourly as required. Children 6 to 12 years. 250 to 500 mg 6 hourly as required. 1 to 5 years. 125 to 250 mg 6 hourly as required. 3 months. 1 year. 62.5-125 mg 6 hourly as required. Referral criteria: referred to a dentist after initiation of treatment. 216. Ludwig's angina/cervicofacial abscess. It is a spreading infection originating usually from a molar tooth into the facial spaces of the sublingual, submandibular and paropharynx. This happens when a periapical abscess erodes through the lingual cortical plate of the mandible and gains access to these neck facial spaces. The infection can then track down and enter the thorax. Another source of infection is the tonsillar crypt abscess. The initial presentation with swelling of the floor of the mouth and spread with upper neck involvement is termed Ludwig's angina. As it spreads down the neck, the term cervicofacial abscess is used. This condition is an emergency and must be treated as such. Ludwig's angina/cervicofacial abscess. Chapter 21, Oral and Dental Conditions. 541. Causes: odontogenic infection, hemolytic streptococci, staphylococci, bacteriids, tonsillar crypt abscess. Symptoms: facial swelling with floor of the mouth elevated with oedema, protruding tongue, drooling of saliva, fever, chills. Signs: tense and tender jaw swelling, board-like firmness of jaw swelling, severe systemic upset, raised floor of the mouth with limitation of mouth closing and saliva drooling. Dehydration. Investigations: FBC, BU/CR, X-ray of jaw. Treatment objectives: to treat the infection, to prevent dehydration, to control fever and pain. Non-pharmacological treatment: adequate hydration, intubation if airway obstruction present, incision and drainage as appropriate, extraction of tooth if it is the source of infection. Pharmacological treatment. A. For treatment of infection in patients unable to swallow and toxemic. First line treatment. Evidence rating: B. Amoxicillin plus clavulanic acid, IV, adults 1.2 g 8 hourly for 7 to 10 days. Children 3 months 18 years. 30 mg/kg 8 hourly, maximum 1.2 g 8 hourly. for Ludwig's angina/cervicofacial abscess. 542. 7 to 10 days, 3 months. 30 mg/kg 12 hourly for 7 to 10 days. And ceftriaxone, IV, adult 2g daily for 7 to 10 days. Children all ages 25 mg/kg 12 hourly, maximum 75 mg/kg daily. Second line treatment. Evidence rating: B. Clindamycin, IV, adults 300 to 600 mg 6 hourly for 7 to 10 days. Children 3 to 6 mg/kg 6 hourly for 7 to 10 days. And ceftriaxone, IV, adult 2g daily for 7 to 10 days. Children all ages 25 mg/kg mg/kg 12 hourly, maximum 75 mg/kg daily. Third line treatment evidence rating, C. Procaine-penicillin, IM. Adults 600,000 to 1 million units daily. Children, 27 kilograms. 600,000 units daily, 27 kilograms. 25,000 to 50,000 units/kg daily. Neonates, not recommended. And gentamicin, IV, adults 40 to 80 mg 8 hourly for 7 to 10 days. Children 1 to 12 years. 2.5 mg/kg 8 hourly for 7 to 10 days. 1 year. 2.5 mg/kg 12 hourly for 7 to 10 days. And metronidazole, IV, adults 500 mg 8 hourly for 7 to 10 days. Children 7.5 mg/kg 8 hourly for 7 to 10 days. Referral criteria: refer to the specialist as soon as possible. Chronic periodontal infections. Chapter 21, Oral and Dental Conditions. 543. 217. Chronic periodontal infections. Chronic periodontal infections are due to prolonged bacterial infection around the teeth, which leads to destruction of periodontal and bony supporting tissue of the tooth. This usually leads to pocket formation, gum recession, tooth mobility and/or loss. Causes: bacterial symptoms, recurrent painful chewing, mobility of teeth, bleeding gum margin signs, gum recession, pocket formation, loss of supporting bony tissue. Investigations: X-ray of involved teeth and supporting tissues. Treatment objectives: to restore tooth function, to treat infection, to relieve pain. Non-pharmacological management: debridement, reconstructive surgery. Pharmacological treatment: A. Adjunctive antimicrobial therapy. Clindamycin, oral, adults 300 to 450 mg 6 to 8 hourly for 7 days. Children 12 to 18 years. 150 to 300 mg 6 hourly for 7 days. 1 month 11 years. 3 to 6 mg/kg 6 hourly for 7 days. Or amoxicillin plus clavulanic acid, oral, adults 1 g 12 hourly for 14 to 21 days. Children is greater than 12 years. 1/500 over 125 tablet 12 hourly 6 to 12 years. 5 milliliters of 400 to over 57 suspension 12 hourly. Mouth ulcers. 544 1 to 6 years. 2.5 milliliters of 400 to over 57 suspension 12 hourly. 1 month 1 year. 0.25 ml/kg body weight of 125 over 31 suspension 8 hourly. 1 month. 0.25 ml/kg body weight of 125 over 31 suspension 8 hourly. B for pain relief. Paracetamol, oral, adults 500 mg 1 g 6 hourly as required. Children 6 to 12 years. 250 to 500 mg 6 hourly as required. 1 to 5 years. 125 to 250 mg 6 hourly as required. 3 months 1 year. 62.5-125 mg 6 hourly as required. Referral criteria for all patients to the dental specialist. 218. Mouth ulcers. Mouth ulcers are generally due to infection, bacterial, viral or fungal, neutropenia, malignancy-related or trauma. The common ones are aphthous and viral ulcers. Aphthous ulcers. Aphthous ulcer is a recurrent ulcer of non-viral origin that occurs on the movable surfaces of the oral cavity. Size is variable, but may have a rim of erythema with yellowish base, and later becoming a grayish hue. They are classified into minor, major or herpetiform on clinical presentation. The minor is 1 cm, and the major 1 to 3 cm in diameter. The herpetiform comes in multiple crops of 1 to 3 cm. Though the cause is unknown, systemic conditions associated with aphthous ulcer include Behçet's syndrome, HIV, vitamin deficiency states, vitamin B group, folic acid. Herpetiform ulcers are a crop of oral aphthous ulcers resembling oral viral ulcers. Behçet's disease is a more severe and generalized form involving the eye, skin, and genitalia. Causes: unknown symptoms. Tingling on the oral mucosa, prodromal phase. Painful ulcer signs: crater-like soft tissue ulcer with a yellowish-gray floor. Tenderness. Odontogenic infections. Chapter 21, Oral and Dental Conditions. 545. Investigations. Nil treatment. Treatment objectives: to control pain, to treat ulcer, to control stress, to prevent secondary infection. Non-pharmacological treatment. Proper oral hygiene. Relaxation. Pharmacological treatment. A. To control pain. First-line treatment. Evidence rating. C. Local anesthetic gel, oral, applied with a cotton tip locally to the ulcer base. Adults applied not less than every 3 hours as needed, and not more than 6 applications daily. Children applied not less than every 3 hours as needed, and not more than 6 applications daily. And ibuprofen, oral, adults 400 mg 6 to 8 hourly as needed. Children 6 to 12 years. 200 to 400 mg 6 to 8 hourly as needed. 1 to 5 years. 100 to 200 mg 6 to 8 hourly as needed. 3 months 1 year. Not recommended. Referral criteria: refer to a dentist if the ulcer does not heal within 2 weeks. 219. Odontogenic infections. Odontogenic infections are infections arising primarily from the tooth. This occurs as the result of intraoral bacteria gaining access to pulp via dental cavity, such as a carious lesion. The pulp undergoes necrosis and an abscess collects at the tooth apex over time. Causes: streptococci. Odontogenic infections. 546. Symptoms: pain on chewing, jaw swelling with persistent gnawing pain, fever, chills. Signs: tooth tenderness to percussion, lymphadenopathy. Investigations: X-ray of affected tooth. Treatment objectives: to control infection, to control pain, to remove source of infection, to restore tooth integrity and function. Non-pharmacological treatment: root canal therapy with drainage, debridement, episectomy, etc. Restoration of structure and function. Pharmacological treatment. A. For treatment with mild infection. First-line treatment. Evidence rating: B. Amoxicillin, oral, adults 500 mg 8 hourly for 7 days. Children 5 to 18 years. 500 mg 8 hourly for 7 days. 1 to 5 years. 250 mg 8 hourly for 7 days. 1 month 1 year. 125 mg 8 hourly for 7 days. B. For treatment of mild infection in patients allergic to penicillins. Evidence rating: B. Doxycycline, oral, adults 100 mg 12 hourly for 7 days. Note: 21:1 not recommended in pregnancy, lactating mothers and in children 8 years of age. C. For treatment with severe infection. First-line treatment. Evidence rating: B. Amoxicillin plus clavulanic acid, oral. Odontogenic infections. Chapter 21, Oral and Dental Conditions. 547. Adults 625 mg 8 hourly for 7 days. Children 12 years. 500 over 125 tablet 12 hourly for 7 to 10 days. 4 to 12 years. 5 milliliters of 400 to over 57 suspension 12 hourly for 7 to 10 days. 1 to 4 years. 5 milliliters of 200 to over 28 suspension 12 hourly for 7 to 10 days. 3 months, 1 year. 20 mg/kg of amoxicillin 12 hourly for 7 to 10 days. 3 months. 15 mg/kg of amoxicillin 12 hourly for 7 to 10 days. Or azithromycin, oral, adults 500 mg daily for 5 days. Children 10 mg/kg body weight daily for 5 days. Not recommended for children less than 6 months, because of a risk of pyloric stenosis. D. For treatment with severe infection in patients allergic to penicillins. Evidence rating: B. Azithromycin, oral, adults 500 mg daily for 5 days. Children 10 mg/kg body weight daily for 5 days. Not recommended for children less than 6 months, because of a risk of pyloric stenosis. Or clindamycin, oral, adults 150 to 300 mg 6 to 8 hourly for 7 days. Children 12 to 18 years. 150 to 300 mg 6 hourly for 7 days. 1 month 11 years. 3 to 6 mg/kg 6 hourly for 7 days. Z. For pain relief. Evidence rating: B. Paracetamol, oral, adults 500 mg 1g 6 hourly as required. Children 6 to 12 years. 250 to 500 mg 6 hourly as required. 1 to 5 years. 125 to 250 mg 6 hourly as required. 3 months 1 year. 62.5-125 mg 6 hourly as required. Oral squamous cell carcinoma 548. Referral criteria: refer all patients with odontogenic infections to a dental specialist after initiation of treatment. 220. Oral squamous cell carcinoma. This condition presents as a non-healing ulcer of more than 2 weeks in the mouth. There may be a genetic predisposition, but environmental causes have been identified. For an oral ulcer, 2 weeks observation for healing is usually adequate. If suspected to be due to an infection, an appropriate antimicrobial is given. Causes: usually unknown. Associations: tobacco/betel nut chewing, alcohol, smoking, HPV infection. Symptoms: non-healing ulcer in the mouth, pain, jaw swelling and deformity. Signs: intraoral mass ulcer, white mucosal patch, neck mass. Investigations: incisional biopsy for histopathology. Treatment objectives: to eradicate tumor mass/cells, to control pain, to carry out definitive treatment. Non-pharmacological treatment: surgery +/radiotherapy. Pharmacological treatment: chemotherapy +/surgery +/radiotherapy. Referral criteria: refer immediately to the oncologist for further management. Temporomandibular joint dysfunction and masticatory muscle dysfunction. Chapter 21, Oral and Dental Conditions. 549. 221. Temporomandibular joint dysfunction and masticatory muscle dysfunction. Temporomandibular joint (TMJ) dysfunction and/or masticatory muscle dysfunction is a complex of derangements affecting only the joint, the muscles of mastication, or both. The pathological process may be due to joint arthropathy, disc disease, or tension in tendons and masticatory muscles from abnormal movement behavior or occlusal disharmony. Causes: behavioral-induced bruxism, arthropathy, trauma, physical, occlusal disharmony. Symptoms: preauricular pain associated with opening and closing the mouth, clicking noise on opening and closing, dull, persistent pain in masticatory muscles. Signs: tenderness in the TMJ associated with mouth opening, clicking in TMJ on mouth opening and closing, tenderness in muscles of mastication on contraction, occlusal abnormalities. Investigations: X-ray TMJ views, ESR treatment objectives: to control pain, to relax muscles of mastication, to correct any stress-inducing imbalance. Non-pharmacological treatment: occlusal splints, onlays, reduced stress and encourage relaxation in masticatory apparatus. Pharmacological treatment: A. For muscle relaxation. First-line treatment. Evidence rating: C. Diazepam, oral, adults 5 mg 12 hourly. Trigeminal neuralgia. 550. Children 12 to 18 years. 5 mg 12 hourly. 5 to 12 years. 2.5 mg 12 hourly. B. For pain relief. Ibuprofen, oral, adults 400 mg 12 hourly as required. Children 6 to 12 years. 200 to 400 mg 6 to 8 hourly as required. 1 to 5 years. 100 to 200 mg 6 to 8 hourly as required. 3 months 1 year, not recommended. Referral criteria: refer all cases to the dentist for further management. 222. Trigeminal neuralgia. Trigeminal neuralgia is a condition characterized by unilateral facial pain that follows the distribution of the trigeminal nerve. It presents with recurrent, sudden onset sharp shooting pain in the face, and may have a trigger point. The patient may present with marked anxiety, and may mimic a psychiatric disorder. Causes: degenerative, inflammatory, pressure-induced symptoms. Sudden sharp shooting pain in the face. Severe anxiety. Signs: anxiety, hyposthesia of affected area, transient. Investigations: X-ray to rule out a fractured tooth, MRI to rule out intracranial pathology. Treatment objectives: to reassure patient, to allay anxiety, to manage the neuropathy. Non-pharmacological treatment: reassurance and counseling. Trigeminal neuralgia. Chapter 21, Oral and Dental Conditions. 551. Pharmacological treatment. A. For the control of anxiety. First-line treatment. Evidence rating: C. Diazepam, oral, adults 5 mg at night. Children 12 to 18 years. 2.5-5 mg at night. 5 to 12 years. 2.5 mg at night. B. For treatment of neuropathic pain. First-line treatment. Evidence rating: A. Carbamazepine, oral, adults 50 to 150 mg 12 hourly till resolution, maximum 600 mg 12 hourly, children 12 to 18 years. 50 to 100 mg 12 hourly, then increase to 600 mg 12 hourly, if necessary 1 month 12 years. 2.5 mg/kg 12 hourly, then increase slowly to 5 mg/kg 12 hourly, or pregabalin, oral, adults 75 mg 12 hourly till resolution. Children not recommended. C. For additional pain relief, ibuprofen, oral, adults 400 mg 8 hourly as required. Children 6 to 12 years. 200 to 400 mg 8 hourly as required. 1 to 5 years. 100 to 200 mg 8 hourly as required. 3 months 1 year, not recommended. Referral criteria: refer to the neurologist for further management. 22. Chapter 552. Disorders of the musculoskeletal system. 223. Osteoarthritis. This is a degenerative articular cartilage disease of varied etiology. It can affect all joints, but mostly the hips and knees. Important differentials include rheumatoid arthritis and tuberculosis affecting the joints. Primary osteoarthritis is usually age-related, old age, while secondary osteoarthritis may be due to other causes. Causes: trauma, infections, inflammatory arthritis. Symptoms: pain on activity, and relieved by rest initially. Joint stiffness, joint swelling. Limping signs: limping, joint swelling, joint effusion. Deformities: leg length discrepancy. Investigations: X-ray of affected joint. Treatment objectives: relieve pain, prevent progression, improve function of joint, prevent deformities or complications. Osteoarthritis - Chapter 22. Disorders of the musculoskeletal system. 553. Non-pharmacological treatment. Physiotherapy. Weight loss. Walking aid. Braces. Surgery. Aspiration of excessive synovial fluid. Osteotomies. Arthroplasties. Arthrodesis. Pharmacological treatment. A. For pain relief. First-line treatment. Evidence rating: A. Naproxenek, oral, adults 250 to 500 mg 12 hourly as required. Children not indicated. Or celecoxib, oral, adults 400 mg stat, then 200 mg 12 to 24 hourly as required. Children not indicated. Or diclofenac, oral, adults 50 mg 8 hourly or 100 mg 12 hourly. Children, 12 years. 50 mg 12 hourly 12 years, not recommended. Or ibuprofen, oral, adults 200 to 800 mg 6 to 8 hourly as required, maximum 2.4 g daily. Children 10 to 15 mg/kg 6 to 8 hourly as required, maximum 40 mg per kilogram daily. And diclofenac gel, topical, adults and children apply 12 hourly as necessary. Or rheumatoid arthritis - 554. Diclofenac spray, topical, adults and children apply 12 hourly as necessary. Second-line treatment. Evidence rating: C. For any of the following therapy, consult a specialist. Methylprednisolone acetate, intra-articular. Triamcinolone, intra-articular. Betamethasone, intra-articular. Referral criteria: refer complicated cases to the orthopedic specialist. 224. Rheumatoid arthritis. Rheumatoid arthritis, RA, is a chronic systemic inflammatory disease of unknown cause. An external trigger, for example cigarette smoking, infection, or trauma, triggers an autoimmune reaction, leading to synovial hypertrophy and chronic joint inflammation along with the prospect for extra-articular manifestations. It is believed to occur in genetically susceptible individuals and more common in middle-aged women. Causes: unknown. Autoimmune disorder, likely a combination of genetic and environmental factors. Symptoms: joint stiffness, painful joints, swelling of affected joints, deformity of affected joints, limitation of motion, skin nodules, difficulty in breathing, easy fatigability. Signs: persistent symmetric polyarthritis, synovitis, of hands and feet, joint stiffness, joint tenderness, joint swelling, joint deformity, limitation of joint movement, rheumatoid nodules. Signs relating to extra-articular involvement, for example lung disease, uveitis, pericardial or pleural effusions. Rheumatoid arthritis - Chapter 22. Disorders of the musculoskeletal system. 555. Investigations. FBC, ESR, C-reactive protein level, rheumatoid factor assay, antinuclear antibody, ANA, assay, anticyclic citrullonated peptide, anti-CCP, joint aspiration and analysis of synovial fluid. hepatitis B and C tests, HIV test, X-rays of hands and feet, MRI of cervical spine, to detect subluxation, ultrasonography of joints treatment objectives, to reduce pain, swelling and stiffness, to prevent deformities, to delay disease progression and long-term complications, to reduce drug side effects, non-pharmacological treatment, heat and cold therapies, orthotics and splints, physiotherapy, occupational therapy, adaptive equipment, joint protection education, counseling and education, synovectomy, tenosynovectomy, tendon realignment, reconstructive surgery or arthroplasty, arthrodesis, pharmacological treatment. A. Symptoms present more than 6 weeks or antibody positive, first-line treatment evidence rating. B. Prednisolone, oral, 0.5-1 mg/kg, body weight, caution 22:1. Take corticosteroids after food. High-dose glucocorticoids may cause insomnia. Immediate release formulation is typically administered in morning to coincide with circadian rhythm. And omeprazole, oral, adults 20 mg daily. Rheumatoid arthritis, 556. Children, 20 kilograms. 20 mg daily, 10 to 20 kilograms. 10 mg daily, 5 to 10 kilograms. 5 mg daily or esomeprazole, oral, adults 20 to 40 mg daily, children 12 to 18 years. 20 to 40 mg daily, 1 to 12 years. 10 to 20 mg daily, 1 year, not recommended. And diclofenac, oral, adults 50 mg 8 hourly or 100 mg 12 hourly as required, children is greater than 12 years. 50 mg 12 hourly as required, 12 years, not recommended. Or diclofenac, rectal, adults 100 mg 12 hourly as required, children, 12 years. 75 to 100 mg daily as required, 12 years, not recommended. Or celecoxib, oral, adults 400 mg stat, then 200 mg 12 to 24 hourly as required, children, 2 years, 25 kilograms. 100 mg 12 hourly as required, 2 years, and 10 to 25 kilograms, 50 mg 12 hourly as required, 2 years, not recommended. Or paracetamol, oral, adults 500 mg 1g6, 8 hourly as required, children 6 to 12 years. 250 to 500 mg 6 to 8 hourly as required, 1 to 5 years. 120 to 250 mg 6 to 8 hourly as required, 3 months, 1 year. 60 to 120 mg 6 to 8 hourly as required. And calcium supplements. Juvenile idiopathic arthritis Chapter 22, Disorders of the Musculoskeletal System. 557. Adults and children as required. B. Maintenance treatment for symptoms present more than 6 weeks or antibody positive, first-line treatment evidence rating. B. Hydroxychloroquine, consult specialist. Sulfasalazine, consult specialist. Methotrexate, consult specialist. Leflunomide, consult specialist. Or etanercept, consult specialist. Infliximab, consult specialist. Adalimumab, consult specialist. Certolizumab, consult specialist. Golimumab, consult specialist. Or rituximab, consult specialist. Anakinra, consult specialist. Abatacept, consult specialist. Tocilizumab, consult specialist. Tofacitinib, consult specialist. Second-line treatment evidence rating. C. Cyclosporine, consult specialist. Azathioprine, consult specialist. Gold salts, consult specialist. D-penicillamine, consult specialist. Minocycline, consult specialist. Referral criteria: refer all cases to a physician specialist or rheumatologist. 225. Juvenile idiopathic arthritis. Juvenile idiopathic arthritis results from abnormally regulated immune responses that lead to inflammation of joints, surrounding tissues and other organs. Often, non-rheumatic diseases that can cause similar features need to be excluded during evaluation. Rheumatoid arthritis in children may present in one of 3 forms: a systemic onset arthritis, Still's disease, polyarticular onset arthritis, 5 or more joints usually of both large and small affected, or polyarticular onset arthritis, fewer than 5 of mainly large joints affected, either of which may be rheumatoid factor positive or negative. Those with positive juvenile idiopathic arthritis 558. Antinuclear antibodies (ANA) tests need regular eye checks for uveitis. For this condition, it is mandatory for arthritis to be